2025, I invite Dr. Lalu Joseph, the Secretary General of CAHO, to introduce the conference theme. And just to tell you all, I just tried typing on Google that please write something about Dr. Lalu Joseph, that I can just put it up. And I had almost around 15 pages and talking about her. But I would say that she empowering, one of the most appreciated person in the healthcare industry, and we welcome Dr. Lalu Joseph. Ma'am, over to you.
Thank you so much, Dr. Santavana. Every problem has a solution, and you just have to be creative enough to find it. That's the motto, that's the theme. The technology and impact, solving challenges in healthcare. We have had excellent discussions for about 6 months, and I must really place on record our appreciation from the CAHO Governing Committee to Mr. Somital and Dr. Manish Kohli and the entire Technology Advisory Forum of CAHO for bringing this amazing theme and for curating the program. So you have a lot of exciting talks today, several challenges in front of you. Healthcare is all about challenges. It's one hospital, if it's 100 beds, employs more than 250 people. Starting from the doctors, the nurses, the technologists, the housekeeping, you name it, starting from the security, everybody has to be involved in the delivery. And there are challenges, there are problems. There are several people who have tried hard to sort out these problems, and we have them as champions here today who have addressed these problems through technology. Technology is the one that's going to connect all of us, and we all believe that technology is the one that's going to help us solve the problems in healthcare. So today we are going to have excellent sessions, and I really don't want to stand between you and the sessions curated so beautifully for you. So enjoy the academic feast, enjoy listening to all the champions who have solved the problems or tried to solve the problems, and I'm sure all of us have learning from what we can take from here today and yesterday. Thank you once again. Enjoy the sessions.
Thank you, Dr. Lalu Joseph. So the one thing I can challenge anyone in this hall to match her energy. You know, that's unbeatable. Her energy is legendary. So thank you so much for setting the context for the Cahotech 2025. So we are coming to almost the end of the inaugural ceremony. So to conclude the inaugural ceremony, I now request Mr. Prashant Sharma, MD of Charnock Hospital and also the President of Indian Chamber of Commerce National Healthcare Committee, to deliver the vote of thanks.
Good morning once again. I'm the only person who had the proud privilege to come here twice. So let me extend a very, very warm welcome to everybody here to this fantastic event, a sequel in many, many great events that Cahotech has had. Let me extend a very warm thanks to all our dignitaries here, all of whom are gems and jewels in our national diaspora, starting from Dr. Samanto, Dr. Chakravarti, Professor Dr. Acharya, Dr. Vijay Agarwal, Dr. Lalu Joseph, Mr. Satpathy, Dr. Shankar Sen Gupta, Dr. Manish Kohli, Dr. Sam Mittal, all the people in the Cahotech universe who have brought together a lot of efforts, a lot of inputs, and put this all together. I must also thank all our sponsors for being so generous, for being so kind, for being cooperative in making this happen. All the technocrats who have put in their exceptional, innovative ideas, the participants, and most importantly, the audience. This sector, I think healthcare has not yet been disrupted by technology. Whatever has happened in the primary space, outside hospitals. All other sectors, whether it is tourism, whether it is any other service sector, aviation, hospitals, hotels, have been disrupted by technology by the way we consume it. But healthcare has yet to be seen to be adopting technology in that fashion. Yes, some innovations have happened in the primary space, in out-of-hospital space, ambulatory care, but a major innovation is yet awaited in this very, very fast-growing, very large space that we have operating as hospitals. So it's my proud privilege to extend my warm welcome to all of you and to also extend my gratitude to all the participants and all the dignitaries on and off the dais. I wish you all a very, very fantastic day of learning. Thank you all for coming.
Thank you so much, Mr. Prashant Sharma. And just to give you an information, Mr. Prashant Sharma is now coming up with a hospital, which is a 200-year-old palace. It's going to be converted into a hospital and going to start in February 2026. So, sir, we all are going to come, irrespective of you inviting us. Thank you so much. Thank you to the audience. Thank you to the dignitaries. May we request you all to please stand up for the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल गंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगल दायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you all. May we request the dignitaries to please come ahead for a group photograph. Requesting the dignitaries to please come ahead for a group photograph.
So yeah, that was a power-packed inaugural ceremony. So before we get ready for the session 1, let's be mindful of the time. We are running a bit late. We call upon or we request the first panel to be ready. So, Santana, this is session. First, do no harm, delivering on patient outcomes and experience. That's the session. So I think it's more about Prem and Prom. What do you think?
Dave, yes, I think so. I know this Prem and Prom. I remember that when I was in college and we have the prom night, I met this handsome guy and I fell in Prem with him. And the outcomes were 2 children, Sanskriti and Swanand. And of course, the expectations were like, okay, it's never ending expectations.
No. You are going in the wrong direction, so that's not the Prem and Prom
That's
we are
what
talking
Prem and
about.
Prom is all about.
No. We have experts talking about Prem and Prom, not about the family saga that you are mentioning. So to discuss on that, we request Mr. Som Mittal, Chairperson, Patients for Patient Safety Foundation, former President NASCOM, to chair the session. Be the chairperson for the session 1.
And may we invite Mr. Jagdish Ramasamy, the Group Chief Digital Officer and Chief Information Officer of Narayana Health, who's going to be talking on the leverage tech for patient outcomes and experiences. Dr. Balu Krishna Sasidharan, the Professor Radiation Oncology at Christian Medical College, Bangalore, talking on enhancing the patient safety by involving and engaging patients.
We request everyone to settle down, please. Those who are assembled in the front, may we request all of you to please take your seat.
We request Dr. Pragati Shani, the chocolatier entrepreneur health professional, to present her case study video, and Dr. Adil Khan, the founder and CEO of Tulu Health, to talk on the digital consent and AI for enhancing patient experience. May we request all the dignitaries and the participants who are standing in the front row to please give space for the other speakers to come ahead. Our humble request to all who are standing in the front row, in the passage, to kindly give space. We request you all to please be seated. We request all the delegates to please be seated so that we can start the program.
Hello, hello. Oh, hello. Yes, you Sure. Hello.
Good morning. Can we have everybody seated, please? Appreciate it.
Check.
Okay, good morning. Let's start the action on the real sessions, and I have a great panel here. My name is Som Mittal. I am not a doctor. I represent the tech industry and have been associated with Cahotech almost from the first edition, which was 10 years back. I must thank, you know what, the session starts with do no harm. And we're only going to be talking about patient safety, and this is the first time that any Caho session has started with a patient focus. All of you start talking about healthcare all the time, and we talk about technology and so on, but I think this is one session that we're all going to be talking about how we meet the patient and affect the patient and relate with the patient. I'm going to be very quick. We have an amazing panel here, and I think the whole issue is, I heard about this word, technology is a disruptor. I don't like the word. It's always been an enabler. It doesn't disrupt anything. Apple may have disrupted cameras and so on, but this is only an enabler. It's not tomorrow, it's here. I think all the three panelists are going to be telling you about exact use of technology that is being done today. And where is it being done? It's being done to touch the patients, to impact the patients, to be able to communicate to each patient. This is the only industry ever that I know of where you cannot do customer segmentation. You might be calling it, these are diabetes, this is a heart patient, this is a lung patient, but every single patient is different and it's a segmentation of one. And if you have such a difficult industry, people like you have done a phenomenal job of adopting technology. I see doctors who are 65, 70 years old doing robotic surgery who have learned it now. But what is the difference? Why is it so difficult? I think our three panelists are going to tell you it's not difficult. Forget about what's behind. Just use the technology just the way you don't question when you use a phone. So our first speaker is Jagdish. Jagdish, your introduction will be up there. I'm not introducing you. But he is both a technology provider, a technology user, and a technology implementer. Jagdish.
A warm good morning to everyone. It's always a pleasure to come to Cahotech. This is one of the few forums where truly the two worlds come together, healthcare and technology. And to take a leaf out of our chief guest's address, Dr. Chakravarti from IIT Kharagpur, where he mentioned that we shouldn't look at technology and healthcare as two separate domains as such, and they need to be combined together to find solutions that are specific to this country because of our volumes, because of our specific challenges as a country that we face in terms of resource constrained ecosystem that we operate in, technology is actually will, I mean, it's a major area of focus that healthcare needs to hop on. And for whatever reason, we have been slow in adoption. And I think forums like Cahotech will go a long way in speeding up and accelerating that adoption. And I see all of these conversations and opportunity to share our ideas as a catalyst to truly propel adoption of technology tools and associated process changes that will actually deliver the change that we envisage. So can you put up the presentation? So today I represent Narayana Health. So, but I'll try to keep the message as generic as possible and possibly some learnings that we have had in our 25 years of existence, trying to shape and mold technology and our processes in this forum so that it may be something that you can take away with. Yeah. So, patient safety has always been a core focus for Caho, right? And today my talk will largely center around how we can use technology to a better, to improve the safety posture of hospitals. First do no harm, it's the promise of healthcare, and it's a fancy way of saying, primer non-nurturing. But I would like to redefine harm, bring it into the technology realm. How do you define harm when it comes to, let's say, the perspective of adoption of technology? It's not just physical, right? It is in our processes. It's in the way healthcare is delivered. Right? There are many ways in which harm can be caused to the patient, right? And some of the examples are over here. It's just that there are many ways that harm hides in our daily processes. It could be delays it could be as simple as patient waiting longer for care, or the doctor not having access to the records, the history of the patient. There are cases where patient allergies are not known to the treating physician, and that led to severe harm to the patient. Right? So, I urge all of you to look at harm in terms of things that normally get pushed into the operational side of things. But if a patient is waiting for care, if the documents are not up to date, the history is not known, if there is fragmented care, that itself can lead to harm. This is the average cost of breach in healthcare, right? When there is a error that happens, when there is a data issue that happens, the is responsible for more than 16% of all the cardiac surgeries in the country, and also in other specialty. So we tried to invert that equation and see how far we can go in pushing adoption. So we started in 2017 with a core team and the basic constructs, right? Some of our basic principles or focus areas started with putting clinical processes in the center of it and not start with billing or not start with supply chain. So that has been a core fundamental shift in direction that we started on. And since then we've moved ahead, we've added more capabilities to the solution and made it more pervasive in terms of its ability to connect all the various points that are there in the hospital. So as I was saying, fragmented automation does not deliver any value, right? You cannot have an automated supply chain when your doctors are still prescribing on a piece of paper, right? So that is where we have been focusing on and trying to change that focus back, bring it back to the clinical processes. And as I said, putting engineers inside a hospital has made a world of good. Making them having to have breakfast, lunch and dinner with doctors brings in a lot of meeting of minds and understanding of the two worlds that can actually come together to deliver what is needed for healthcare. So in terms of technology, our focus has been to build a tool that is scalable, that is secure, that is simply very intuitive for users to use. But the way to look at it from a target audience, right? What it means for the healthcare is that it means it is faster, it is safer, and it is better in terms of the care delivery that happens. So we see this as the role of technology is to move things towards a better ecosystem where things move seamlessly and information moves faster than the patient. And we believe that these will eventually lead to a much better quality of care. Yeah, these are some of the impact results that we've seen so far, and these are things that keep evolving. We keep KPIs that are more involved and more relevant for the business, right? Technology cannot be for the sake of technology, so it should be measured in the right terms to deliver the right amount of impact, right? So we have to upgrade and change our way of thinking. We have to see how we can move from just this digital being a good to have thing to something that is more impactful, moving from chaos to comfort. And do no harm means do more good, and our ability to deliver that as technology should be through augmented and connected care.
Thank you, Nitish. I think Rana is a very good example of an organization which adopted technology, made the technology work, and now they're offering the technology to other hospitals. So thank you, Nitish, and you're on both ends of it. Before the next speaker speaks, I think it's very important. This morning the discussion was we are in Odisha, Bhubaneswar, 80% are in villages, and a lot of stuff that we spoke about. But this is quite amazing that in India, digital literacy has preceded literacy. So everyone is today using a mobile phone, technology is in their hand. And if that is so, how can they use it? And I think that's what really Dr. Balu's presentation is about. How do you have and communicate with patients where you don't have the time, the nurses don't have the time, and you can still make it happen? Over to you.
Thank you, Mr. Mittal. Fellow speakers, members of CAHO, friends and students over here, very good morning to you all. Mr. Mittal has actually asked me to take one example from my practice where we found it as a patient safety issue, and then share with you how we are trying to solve it, and that's what I'm trying to do with you in the next 10 minutes. So that's why I titled this as Lost in Translation, and I feel that there is something beyond right to information, that is the right to understand. So about me, I am an oncologist. I work at CMC Vellore. I've been there for 20 years, and I also teach, treat, and do research, core research also. I also have an AI lab which works on image prediction models and also work on natural language processing to enable patient engagement. I've also been associated with Caho since last year, and that's probably about it. And to start off, I just want to share a story. 2004, that's probably when I moved from Trivandrum, where I have been all my life, to Vellore to do my training in oncology. And as any Malayalis and Tamilians here? Okay, there should be some. As any Malayali would believe, if you move to Tamil Nadu, we continue to speak in Malayalam and we believe that we are speaking in Tamil. That's a natural thing. So as a young doctor, I had this feeling that I had this practice every evening in the ward. My cancer patients, I do medicine reconciliation. I go and explain that to them, each of them. And I believe I am speaking in Tamil, but obviously I am mixing Malayalam and Tamil. And every time, next day morning, I realized that some of the patients have actually taken the medicine that was supposed to be taken in the morning, the previous night itself. And I didn't get a clue why this was happening until 1 week later, I just explored what happened. And then one of them said, "Doctor, you said Ravile Sabduko." Ravile in Malayalam means morning, and Ravile in Tamil means night. Okay, so you see how much difference it makes. It's just, it's a potential harm event, no? A patient taking medicine at the wrong time. We speak of it now, but this is 20 years back, a language barrier which is causing a patient harm. So this can affect life, and that's what we are trying to talk about in the next 10 minutes. So, sorry, I don't have a screen here, so I'll have to look there. So it's important that we as providers and our patients speak the same language, and which is a very impossible task in India because we handle more than 40 languages generally, and it is a concern in CMC because we, as whoever continues to work in CMC, have to use at least 5 languages to effectively communicate with our clientele, and that's not an easy task. So I'll just list out some of the issues when we have this language barrier. One is medication error, I just told you. Not only just a small example, but many others. We always give this in English and expect that the patient will understand that, but most often not so. And it is a burden on the caregiver to actually explain that in that language, but how many sustain that? We don't give it in their language, so that's a major issue. Consent, often we feel that, okay, all of us as practice just sign off every consent when we go to bank, when we buy a car, whatever. The same thing our patients also do. We expect that the doctor should sit and explain, but how many understand at that time, and how many doctors are able to actually communicate in their language, that's a major issue. So consent is a place where language barrier comes in and has a major issue. Symptoms, sometimes the symptoms that patients tell us, we may not understand because he may be speaking in Bangla, I will understand Hindi, and I assume that some of the Bangla words I am understanding it well, but not true. Of course, there is some drop in information when I gather that, and it is not good for a good patient care. And discharge instruction, again, this is linked to medications, but there are several other instructions that we give about their general health, which is often in English, and we are not able to actually communicate or make the patient understand. So the problem at CMC on the right is what you see as the patient's languages, and on the left are generally what we have as doctors who can speak mostly English and Hindi. And of course, some will speak Tamil. And we try to manage all the other languages with this. Whose onus is it to communicate? Is it for the patient or is it for the doctor? Most often we get irritated if a Bangla patient comes in our busy clinic and he can't speak, I'm losing time because there are 10 other patients waiting, isn't it? And the onus is on sometimes patient will bring an interpreter. Or is it for the doctor to actually provide an interpreter? How many interpreters will I have in my clinic? So it's often that the patient brings somebody who can speak their language, and often things are lost in translation. So we do adapt. We use gestures, family members as interpreters, multilingual staff, but that's not scalable. We will try and search around for people around in the clinic who can actually speak that language. And of course technology, but technology, again, literal translations in current technology may not make context. And also, if the translation is not verified, again that is a harm. For example, if I translate something for a patient in Telugu using Google Translate and give it to him, I can't read Telugu, isn't it? So how do I verify that that is true? It would have been a different meaning. So there is still a danger in using this technology to actually deliver to the patient. But we do adapt. I have this example when we were junior doctors, when we used to do pelvic examinations, we have a lot of Telugu patients with cervical cancer. So when we know only one word to make them position for examination is jargandi, that is you slide down. So after finishing the procedure, we don't know what to tell them to get up and go. So we go to the other side and say jargandi. So that's the way humans communicate. We adapt with what we know. But at this point, in this era of AI, we should go beyond this. It is an Indian problem. May not be only for CMC, because in India people travel for care, and people travel vast distances for care, and it is for us to actually enable some solution. So this is a graph which shows that the Indians do very well in 2 minutes, that probably others take more time. United States take 20 minutes. Can you tell me what it is? Anyone? Sorry? Counseling? We do that very well in 2 minutes. No? So this is one report which said that the average time an Indian doctor takes to see a patient is 2 minutes, which is fairly around that same. And as a clinician, I would say yes. If you take an average, that's the time that we. In that time, are you trying to break the barrier of language, or are you trying to examine him? Are you trying to give an advice, or are you trying to treat a wound? What all can you do? And this language barrier is a major issue, isn't it? So that's why we thought, okay, we should find a solution. So CMC and IIIT has a very good linguistic solution. We worked together for the last 4 years. I did share with somebody about the Bhashini model, which is a Government of India initiative of AI-based translation across the country for multiple languages. We fine-tuned the Bhashini model with CMC data because we had multilingual data for the last 4 years, and we have now a on-premise model called the Bhashini Health, which we use to create multiple products. And one of the first ones that we wanted to crack is the patient engagement or the communication, the patient being able to find his answers in his own language. So I'm not going into detail of this, but that's as I was asked, I'm just sharing a problem and telling you how we are trying to solve it. So here we have an AI-based solution where patients are given curated content in English in this app by the treating team, and the patient is able to actually ask questions in 8 Indian languages and able to get valid answers, vetted answers by using an AI agent. And this, I feel, is going to empower them to understand better what we are trying to do. And having a language model at that level, it is going to empower us to do more things, and that's the layers of Bandhu care. Primary layer is the patient engagement. Then what does the doctor get? If the patient has engaged with the app for 2 weeks, and at the end of 2 weeks, when they visit the doctor for that 2 minutes, the doctor is going to get an engagement report in English, which does a sentiment analysis and tells them, okay, this patient was concerned more about his swallowing, and probably you should address that. The questions were all related to that. This patient's issue was the pain. So that's one way you can enable the doctor to catch rightful information from the patient's environment than from at the clinic. So it's like a journaling for the patient in their own language, which AI would enable the doctor to get a report. Of course, this can lead to an agentic AI where somebody can fill up prompts in patient's language. The AI can do it for us rather than the conventional way of filling up forms. And of course, this would enable ethical consenting. I can discuss further about this in detail if you want to understand more, but we don't have the time for this. So I'm showing an example of a unique consortium where a problem-led solution has been developed by bringing a technology partner, a language partner, and a clinical group together. And this is a model that we would like to highlight for everyone, that find problems that are relevant and try to solve them with partners and collaboration. So I feel our patients, Indians generally, we are very happy to solve problems. We are contented at some level, and partially if we understand we are happy, but the new generation will not be so. We demand more, and patient safety demands more than just improvisation that we have been doing so far. And that I feel from right to information, we have to move on to the concept of right to understand. And that is what the concept like Bandhu Care delivers. And as this session means, if patients cannot understand, they cannot consent. And if they cannot consent, we are violating the very principle of doing no harm. Thank you.
Thank you, Dr. Babu. I think a very good example of something. This is not a pilot, it's actually running in civil road. So I think it can happen. Since this was do no harm, we had an actual patient. She moved back to India to take care of her parents, and she lost her father. And she lost her father. She's going to narrate that story. I'm sorry, we're getting a patient right here in the room, but I think her emotions are very important for us to understand how important is it for us to take care. Can we have the video before I ask Dr. Adil to take over?
Thank you for inviting me to Cahotech 2025. My name is Dr. Pragati Sahani. I'm a dentist with a public health background. Today, 5 months ago, I lost my father. He died on the operating table. On June 7th, he slept in the bathroom. We got an X-ray taken. It showed a hairline fracture. It was Saturday. I could not find an orthopedic surgeon to consult, so decided to take his reports to the hospital that we would always go to. But where his cardiologist practiced. My father had aortic stenosis, and I wanted my neurologist advice before I could take him for surgery. There, the cardiologist wasn't available, and the orthopedic surgeon their department told us to rush him to the ER as he would have complications of chest congestion or emboli. I was hurt taking my father with dementia in the night. On Sunday morning, I was able to move him to a private room. Again, I tried contacting the doctors, but could meet no one. Anxious, I called an orthopedic friend from a distance. And he said, not to worry, there was a procedure called proximal femoral nail fixation, which was simple, 30 minutes, and I was relieved. But he said my father needed cardiac clearance. When I returned to the room, the hospital had already taken consent from my father for the procedure. While I was relieved it was the same procedure I heard about, I was upset they did not think of telling me or my mother anything about it and what it involved. On the morning of the surgery, the orthopedic surgeon told my mother he was doing a new innovative procedure, which would cause the same cost, but we didn't have to worry, it would be quicker recovery. An hour into surgery, I went towards the operating room, wondering why he hasn't come out. Then my father had gone into a cardiac arrest. Later, I learned they had performed a cemented bipolar hip arthroplasty. No one knew of the change in procedure, nor the specialists who were working on the team in the operating theatre. He had died of a common risk called bone cementation implantation syndrome, which is very common among elderly with a chronic heart condition. This was never mentioned to us or was shared in the risk. I did not even know the name of the surgery till after he died. My father was supposed to go in for a 20-minute surgery, but he died. There are two main things that I think back, which I don't see in hospitals abroad, is informed consent. Informed consent means you inform the patient and their families exactly what you're going to do and what are the risks involved. We were not even communicated what the surgery was. We didn't even hear that name before. Forget the risk. And when I looked at the wrist after the death summary, it did not have anything called bone cement implantation syndrome. They told us it had an anaphylactic shock, which was also not there. I share my story today so we do no more harm and save another family from this pain. Thank you.
So we have heard this, right? And I don't know how many times I, as a patient, have gone on my behalf, on my family's behalf. I get these multiple forms. I have to sign, otherwise the procedure won't start. It's a 3-page document. I was told, I was informed, and I was never. Dr. Adil, you've been working with Caho to find a solution, because we know the doctors don't have the time to wait. Over to you.
Namaste, Sastriyakal, Salam. Excuse me if I cough, I come from Delhi, we are not used to fresh air. So, we heard her story, and to solve that very problem, Dr. Vijay, Mr. Som, we decided to build a non-profit, free for all solution where we guide the patient about their issues, about their procedures in the language which they are most comfortable. Can we have a video of our product, please? So as they are playing, so that initiative started as a Cahotech initiative, which we, Tulu Health developed it for them, so that we can empower every patient in this country with the right information before they go for any procedure, and they can have that consent signed and informed consent signed in the language which they are comfortable. So we have this product in more than 7 languages, and we are covering almost like around more than 55 plus procedures. The next video, please. Yeah, so basically we'll be telling you about what that platform is about, and we all can access that platform from the Caho's website, and it's available online for free, and where you can just go see that. So here we have the video. Can you play this? Play. So this is a platform where you can see we have partnered with Caho on that. Here we have a video on telling patient how to use this platform. On top of it, if a patient just wants to download the consent form, know about the issues, they can just write few basic details and they can go about it. On top of it, if they just want to understand the procedure, they can have a look at it, and they can, if they don't have time, they can just look at it like a wide, well-informed information about that procedure. If they don't have time, they can just look at the poster. Our product is available in almost 7 languages, covering 90% of the population. And then if they can't even understand, read, they can just look at the video in their own languages and they can find out more about it. That's about Caho's consent product. Now I will also share another story. Can you play that video? The next video.
So this is among the several videos, this is one of the videos that we have just started making. There will be many more to come. This is just an example of one which
Can you play the next video?
Why angioplasty is needed. Arteries can get narrow or blocked by fat and plaque. This reduces blood flow to the heart, can cause chest pain, breathlessness, or heart attack. Angioplasty opens the artery, restores blood flow, and helps the heart work better. What is angioplasty? Non-surgical, minimally invasive procedure, no open heart surgery, quick recovery, many go home after 48 hours. Can be life-saving during a heart attack. How it's done? A thin tube catheter is inserted through an artery in the wrist or groin. Doctor guides it using X-ray to the blocked artery. A small balloon is inflated to widen the artery. A stent, mesh tube.
So this was just one example of like many videos in many languages. Like we have created more than around 400 videos like this, and more every day are coming up. Basically, make sure that patient makes an informed decision before any procedure and know everything about that procedure. So this is just one of our initiative, and we are expanding more and more to make sure that patient makes informed decisions throughout their journey. As part of this, like now I'll tell you more about how Tolu Health is making an impact. So before I go ahead, I want to start with something very simple but a moment I cannot forget. A few months ago, my neighbor, a widow, 60-year-old woman with no kids, was trying to call her hospital because she was having a chest pain. The line never connected. She kept on calling again and again. It was not because people did not care, not because hospital did not care, but because the system was full. This is the part that breaks you, not the illness, but the silence. Every leader in this room knows the truth, that healthcare is not broken, it's overloaded. Your doctors are drowning in work, not just in clinical work, but in admin work, swamped with messages and calls from patients. Your front office is using more than 10 tools to manage just a one person's job. Can you play the video? So healthcare is fragmented, doctors are drowning at work, patients feel that they are unheard, they are alone in the journey. And while the system strains, the patient behavior is also evolving. As Mr. Jagdish said, the consumer behavior has evolved to the level because of Ola, Uber, Blinkit, and Zepto that people expect answers now. They expect clarity without confusion. And they want to feel seen. They want to feel guided. So this is where, sorry, I'm from Delhi. So the expectation is simple from the patient that know me, guide me, and stay with me even after I leave the hospital. Across the world, AI is no longer a preview. AI is here, as Mr. Soam said. It is at the bedside, it is at the front desk, it is inside workflows. And few hospitals among us are already using it in tier 2 cities like Patna. If the world is moving and we stay still, it itself is a decision. And this is not a technology question, it is a leadership question. Will you want to be an iPhone of this transformation, or would you want to remain a Nokia of this transformation? Now I will say a very scandalous statement for my industry that healthcare AI SaaS will not work. Why? Because every organization is unique. I was having a discussion with Ayush from Savodaya Hospital that every organization is different. Different systems, different journeys, different compliances. A universal AI SaaS model cannot solve that. It is built for everyone, it fits no one perfectly. That's why we started Tolu Health with a different belief that build AI agents around each workflow. Make it custom, make it precise, and designed to remove the operational bottleneck and real pain inside the hospital. Because every hospital has a soul and AI must understand it. The right AI does not replace your staff, it becomes part and it becomes in Patna has seen tremendous change. Now digital visitors do not disappear, they convert. Patients return, dormant patients come back live. And front office load drops and patient experience increases. 4 times more acquisition is not magic, it's workflow intelligence. So I must say, this is not hype anymore, it's happening today. So 3 years from now, a hospital among us will set India's gold standard for patient experience. Its doctors will be less burdened, its patients will be guided end to end, and last but not the least, the leadership will say, we chose to move early. Thank you.
Very much. We're running out of time. I thought we'd have a discussion, but I have just one question to three of you. Very briefly answer it. In the healthcare, we do find, as many of you mentioned, the focus of technology has been billing, appointments, and so on. But when you talk about these kind of systems, how difficult is it for them to implement? They have implemented robotics and all kinds of automation in clinical care. What's the bottleneck and what's your mantra to us? Jagdish?
I think that's the million or $1 billion question that the epic concerners of the world are trying to answer. I think some of it is what I touched upon in my presentation. From our experience, what we have found is if you are able to put both the clinicians and the engineers, the product managers and the UX designers in the same room and they spend enough time together, that is a great way to get the conversation started. Both need to appreciate each other's complexity. You cannot build a great EMR sitting in a software tech park. You have to be in the hospital. The solution needs to be born in the hospital, just like all of us that we born. So that is one area. The other area is, I feel that a lot of solutions are built as a replica of paper forms. That is a very wrong way to start because this is a much more smarter device. It can be much more efficiently used. So it needs to be molded to, the paper forms have to be, not just translated, but actually, converted and transformed to the digital ecosystem. Usability is a key part.
Make people comfortable with technology.
Yeah, build something so good that they can't refuse.
And if you have a problem, don't say ki IT wale ko bulao.
No, exactly. See, we've been blaming doctors if they don't adopt technology, like at least that's the inside thing that happens. But the same doctor is happy using iPhone and WhatsApp and everything else. It's just that we have failed them by not building something as intuitive and as useful.
Thank you.
Thanks.
Check. Always the blame comes to the doctors, and I accept that. For a doctor, the main target in the clinic is to satisfactorily finish the consultation and send off. So if I am asked to use a digital tool which is going to slow me down, I will not adopt it. There's no incentive there. Okay, digital tools have to enable me to do something more efficient, and whatever we have seen, whenever EMRs are thrown down on us, it actually makes me do more work, while I can actually do it on paper without using digital tools in 1/10 of the time. So the problem comes in where the development is thrown to a clinician, then clinician is not being part of the development. He is the primary user and the patient is the end user. I will also add, why is there no sustainability? Patients, for example, if they are trying to use a digital tool, you should have some way of ensuring sustainability by keeping their interest on. If I am starting a new game, for example, on the phone, there are several ways that they make you come back and play the game. When you create tools for patients also, if the patients are not using your, they will use once they are in the hospital. After that, if they don't use it, there is no value to it. It will just die down. So there should be some kind of way that you guys have to think to create sustainability and patient interest in maintaining the app. And also think of us doctors who are actually having very little time, don't slow us down by using your technology.
Thank you very much. You are one of those who were on this side and now they move to the tech side.
Yes. No, I totally agree with Jagdish that firstly we have to co-build. We have to co-build with the doctors. And at the same time, what Dr. Balu said, the primary job of doctor is not to use the technology, it is to take care of the patients. And to ensure that, firstly, technology, like IT teams and the IT people need to understand that you need to solve the most pressing problem of the doctors. Secondly, it has to integrate into the existing workflows. You can't create another work for them because they're already drowned with overburdened with work. And last but not the least, that
The technology should solve those admin and the boring tasks of the doctors and let the doctors do what they do best, care for the patients. That's what I will say.
Right, thank you. You know, I'll just say, we have 3 people here, I think they're going to be here hopefully the whole day. I spoke to each of them, and whatever solutions they had, they did not build it for themselves. Dr. Balu said he wants this to be democratized and others are allowed to use it. Jagdish ran there, he did, tested it. So it's not IT company coming and giving it out. These are people who are using it. And Dr. David Shetty, in fact, many times mentioned that this should be actually used across because the learning curve is shortened. Of course, here we have a doctor who is doing it, so I hope. So please use them because these are people who not only develop technology, they are using it and are willing to share it. Thank you so much. We're going to cut short this time, but give them a very big hand.
Thank you, sir. Thank you. It was a wonderful session. A lot of insights to be learned on first, do no harm to patients. So may we request the chairperson and speakers to, pose for a photograph here.
In the meanwhile, may we request Mr. Prashant Sharma, Dr. Deepak Mitra, Keshari Asthana, Mr. Vivek Rajgopal, Dr. Sujoy Kaur, and Mr. Lakshay Arora to please come up on the stage.
So the next session is on innovation at the intersection, harnessing opportunities to leapfrog India's digital adoption journey. Very, complex topic itself in terms of the words used, right? Innovation at the intersection, harnessing opportunities to leapfrog India's digital adoption journeys. But we have a very, very expert panel and chairpersons to continue this session. So, to chair the session, may we request Mr. Prashant Sharma, Managing Director, Charnock Hospital, and Dr. Deepak Mitra, Managing Director, Sun Hospital Private Limited, to occupy the position in the dais. Yeah, and we also request the speakers, Keshari Asthana, Chief Technology Officer, Microsoft India's Public Sector, Healthcare AI Stack from data to co-pilots to agents. That's the topic he's going to talk on.
May we request the next speaker, Dr. Vivek Rajagopal, who's the Group Chief Analytics and AI Officer for Advanced Analytics at Narayana Health, who will be talking on use of data analytics and AI in Indian healthcare systems. To please come up on the stage. Requesting Dr. Sujoy Kaur, who's the Chief Medical Information Officer and VP Apollo Hospitals, who will be discussing and giving an insight on taking a leap of faith. It's your opportunity. And Mr. Lakshay Arora, who's the Group Manager Marketing at Intuitive India, talking on advancing minimal invasive patient care by Darwin-C surgery.
Yeah, while the stage is being set, we request the chairpersons to, please control the time as we are running a bit late with the sessions. So, each speaker is allotted a specific time, so we request the speakers to stick to the timelines given.
Good afternoon, everybody. Good morning, Sil. In the interest of time, we will ask all our speakers to have a very short introduction of themselves and their activities, etc. Let's keep it to 1 or 2 minutes each, and thereafter we will have a start. Dr. Deepak. We start with Vivek. Would you like to introduce yourself?
Hi everyone, very happy to be speaking here. I'm Vivek Rajagopal, the Chief of Analytics and AI at Narayana Health. Been with Narayana Health and healthcare for about 15 years now. I run the Medha Data Intelligence and AI platform that powers Narayana and several other hospitals across India and outside of India as well. Very happy to be here. Thanks.
Thanks, Vivek. Keshri, you want to go next?
Hi, I'm Keshri Asthana. I'm the CTO for Government Business for Microsoft. And thanks for getting me here. There are two reasons. One, of course, being part of such a esteemed group. And second, allowing me to breathe some fresh air. I'm from Delhi. So thanks for getting me here.
Thanks, Keshri. Lakshay, you want to start?
Yeah, hi. Good morning, everyone. My name is Lakshay Arora. I am a Group Marketing Manager with Intuitive India. Very happy to be here and speak about robotic-assisted surgeries today. Thank you.
Lakshay, Dr. Sujay, please.
Hello, I represent Apollo Hospitals, working with Apollo Hospitals for past 20 years, also about the last 8 years, so where we have 3 labs now which design, develop and deploy clinical AI solutions.
Thank you, Dr. Sujay. Now I hand over to Dr. Deepak Mitra to kindly take this session forward.
Good morning, everyone. As we know, we are running short of, rather behind time. So I request, I think I was instructed to ask you to start. Yeah, so you have a flight. Yes. Yeah, please go ahead.
Good morning. I woke up at 3 a.m. in the morning, did my slides, and I thought I'll come here and talk about a leap of faith. Can I have my slides, please? As I said, I've been working with Apollo Hospitals for the past 20 years, 8 years as the CMIO, where I have now 3 labs, including the one that we have a partnership with the University of Leicester, where we go about in design, development, and deployment of clinical AI solutions. If the slide comes by, that would be fantastic. If they don't, because of some issues with the dimensions, that's fine as well. So I've been asked to talk here about how do you leapfrog to digital and AI excellence in Indian hospitals, particularly those which are struggling in terms of looking at clinical outcomes and the different ROIs that a lot of hospital managers or executives would look at when deciding to pick and choose what is the way that they would go about in going forward. And in terms of that, it doesn't work. In terms of that, the fundamental of this is to actually look at how you go about in the metamorphosis from caterpillars to butterflies. I was opening a conference in Dublin earlier this year, and then in Singapore, and I used this word, which is actually not mine, it's from one of the professors at my alma mater at MIT, where we talk about digital transformation when it is done right, is like a caterpillar turning into butterfly. And when it's not done appropriately, you'll have faster caterpillars moving all over your hospitals. Sometimes we see a lot of faster caterpillars in the way we go about in doing digital transformation. And the choice is therefore ours, whether we want to see, whether we want to build those or bring those butterflies, or whether we want to have those caterpillars to come by. Fundamentally, from 3 perspectives, you would need to look at the push that comes externally to an institution, either from regulatory, or rising AI capability, or mature global trends that you need to keep up. But it's all about what comes from inside. And if you look at this, which I built on OpenAI last night, is about what exactly the voices that are coming in from your institution to do digital and AI transformation. There are people who go about and asking, we need a baseline audit. There are people who will talk, why should I adopt EMR? There are people who would talk about, I want to use AI, but AI is of no use. And they go about in talking to their clinicians, and the clinicians go about in talking about saying that to their patients. And that is something which we fundamentally talk here in one of our publications, which is now taken up by World Economic Forum, to actually look at how you go about in building the trust from the algorithms to the physicians and physicians to the patients. And if you're not able to build those trust, either in digital format or in your AI story, you are missing out something. And that's what I call as heterogeneous perception. There will be few people who would like to wait and test it out and see the real world evidence before you go about in adopting digital and of course in AI. There's no harm, no shame in that. But what you have to do is to have a continuous conversation, which are the concepts and values that you would normally look at your leaderships to actually take in your organization. Next slide, please. Can I have the next slide? In the pursuit of this, what I'm going to show you and what normally I take up as a teaching case study. Next slide. What I teach at my students at IIM Calcutta, and I see a couple of them here, is about the case study in which certain organization back in 1999 wanted to go about in doing digital transformation. And it showed a landscape, which I wanted, yes, it showed a landscape of their various functions and individual softwares that they had in different hospitals. Now, if you look at it from a perspective of what I call the standardization and integration in a hospital setting, they would be neither standardized nor integrated. They're neither talking to each other, or nor they are actually having in a way which they talk even with each other within their own organization. And if you go about and ask these questions as to what went wrong for this organization, particularly from the perspective of change management, which I'm trying to put in the perspective of the leapfrogging that we need to do. Next slide, please. Is about understanding what are those status quo systems, whether it is the legacy of systems, complexity of processing, inadequate skills, clarity of data governance. What is in it for me? Why should I do this? And this is something which is often, sometimes, which comes in our conversations. And of course, we all know about the conversation that comes out in who owns the data, the transparency, and the lack of understanding in that. Next slide, please. So here is something that I proposed to Kako. I was asked by Dr. Manish to actually give a template of 8-step leapfrog about going and starting from a very baseline to where you have adopted AI within your organization and you are trying to do this. And there is an 8-quarter, 2 years journey that you can possibly go about in taking, starting with a very digital audit within your organization, looking at your foundational EMR, looking whether you are going to invest. I know my good friends from Microsoft are going to talk about it. I've been working with them for 8 years now with the different teams both in India and in Redmond. And then of course look at it from the perspective of how much you invest within cloud and how much you invest within systems that are within the purview of something like a workstation, where you can bring in the servers and put it within your systems. And all of them have their own security concerns, by the way, which possibly we will allude at some point of time. And then how you go about in looking at it from a clinical workflow digitization, AI readiness, and then intelligent choice architecture, which I will talk about in a while. Next slide, please. The previous one. And when you go about in doing this is the structured method by which we went about in our journey, which is coming out in publication very shortly, where you are looking at everything from a finance function to a supply chain to revenue management to patient safety to the clinical one. And I really endorse the comment that has come that you cannot just convert your paper records to an electronic records and then go about in having that, because you have to bring in technologies, which my colleague Jaideep will possibly talk in his speech around the, bringing in something like an ambient listening, and how ambient listening is changing the paradigm of the conversation that we are having in our clinics. But interestingly, we are now seeing the use of this in operating theatre. And in operating theatre, particularly where you want the anesthetist to chart every bit of it? Can he use the ambient listening and see it in around that? Next slide, please. I want to now quickly go and give you the tenets of 5+1 digital excellence story that I learned myself at MIT Sloan. And it talks about operational value. You have to fulfill operationally what you commit digitally. If you're saying that the food will be delivered to you within 30 minutes, you're expecting it to be. So it's the same thing for your, for your medications to be delivered. And whatever that you are getting in terms of, shared patient insights from the operating arm of your digital, or the digital arm of your operations, you would have to then go about and seeing how do you go about in sharing this with your clinicians, with your patients and all that. And I think fundamentally this is what we don't do in anywhere in the world. I have, at this point of time, experience of rolling out my own algorithms in 31 countries in different health systems. And I have seen in this that somehow we're not ready to share the insights or provider insights that we get there. And then we need to talk about positive network effect. I talked about that there would be some heterogeneous perception where people will not join the bandwagon and start adopting AI or digital technologies from day one. They will do at some point. But that is the positive network effect that we need to build. In the interest of time, I want to go quickly into accountability frameworks, which is about, how do you go about in balancing innovation in your organization with the overall purpose, or what is the purpose of your organization, what we call as autonomy versus alignment, and how do you bring them together to move forward with that. The fifth part of this is that there are brilliant startups that are available in India at this point of time. How do you go and choose them, pick them up, take it into your organization and see what blends into your own ways of doing it and then take it in that way. And the last one comes from Clayton Christensen, of course, whoever went to Harvard knows Clayton Christensen very well. He talked about how much do you go about in depending on those third party and how much do you go about in building your own systems appropriately. Next slide, please. In all of these, you would need to see how there are digital touchpoints that you bring from access, assessment, care, outcomes, and outreach with indicators for each one of them and how you go about in following this. Next slide. I want to now leave behind the thought process. If you follow Lancet, and if you followed the Lancet that came out, last month for Lancet Gastroenterology, it talked about certain endoscopy system where you are beginning to de-skill doctors because you are adopting AI. And that's a problem because classical CDSS, which was talked about from this platform, is not sufficient. In fact, it will lead to de-skilling of doctors, clinicians at some point of time. Then how do you go about going out with that? What is the root out of it? And the root out of it is intelligent choice architecture, something that we are doing as a research at MIT, and we are looking at it from that perspective. The way you will have to address this is to first look at your capability structure as to what your organization has a capability. The second is where you have to bring the compute, whether you do it with cloud or whether you do it with your on-prem, GPU sets and others. But the cognition comes from the clinicians. The way by which you compute the data, by looking at multimodal data that we have in clinical terms at this point of time, whether you are bringing it from your EMR or your imaging systems or your high velocity, high volume, high variable data, and putting them together to do the compute, the decision has to be taken by the doctors. Now, in doing this, what can AI do? AI cannot tell the best path that you need to go about in taking. You need to give choices with reasoning, with the probability of the outcome, the clinician. And that's how it has to go about in doing this. And we are working on that, where you require 4 sets of collaborative work. 1, that you do within your organization. 1, 2, that you do with the with your community, and the third with you do with different institutions worldwide. Last slide. Next slide, last slide. And that has helped us now to actually build 20 different, and there are other 40 different things where we are doing active research of clinical AI at Bono, which are now being used by, as I said, in 31 countries, where one of the other healthcare systems are working on it at this time. There are more than 5 million people who have thought about taking them in an appropriate way. They are in disease risk prediction, they are in imaging signals, acute care, and of course, throughput optimization, where you go about improving your productivity in your organization. I'll stop with that, with a caveat that it is the moment for you to go about and take that leap of faith in identifying what that starts in your organization as process for digital and AI excellence. You have to do it in a bit of a holistic way to get the maximum benefit out of it. Thank you very much.
Thank you so much for sticking to time and addressing an issue which is a problem with lots of hospitals across the country.
We would humbly request all the speakers to please adhere to the time. I'm requesting the chair to please make a note of it. Thank you, sir.
I now request Stana.
Thank you. Hi, thanks for giving me audience, and I will quickly take through a couple of pain areas that we've seen, we've heard from the speakers already. One, there was a very big point made by the earlier panel that don't throw technology at the doctors if it doesn't improve their efficiency. And give them time to provide more care rather than getting them to adopt digital kits. I think those are the two things which really makes my presentation, and they set this up for me. Thank you so much. And I think I'll take you through a stack which can really enable more efficient clinical procedures and enable the efficiency, improve the efficiency of the health providers. And considering that, why this really matters, I'll be speaking on, I'll be repeating what people have been talking till now. It's like 80% of the data that's there in the organization, it's currently unstructured, it's currently in form of images, DICOM, etc. And what ultimately happens is that to make sense out of it, there's lots of documentation that is done around it. So one, the unstructured data, and then the documentation, which burdens the caregivers and the doctors. And then it becomes a manual handover. Once there's a documentation, there's a manual handover that comes into play, which again reduces the whole efficiency, makes the process slower. And I remember one of the esteemed speakers talking about AI can't solve all the problems. Absolutely, AI can't solve all the problems. And the thing is, AI will not be able to even solve this problem if the data is not properly arranged or properly governed. So, the stack that I am talking about is having three main components. One is the data foundation, second is the co-pilot for the people, and third is the agentic automation. I'll explain one of each of these quickly. What are these, and how I see this as helping improve the efficiency, helping improve the caregiving process.
So the data foundation is more about collecting standard formats of data or the data from the entire lay of land from the different systems that are there in the organization, and collect the data in form of normal file or DICOM format and put it into the storages that you can name it as bronze, silver, gold, or whichever mechanisms that you would want to really make them. And then you standardize the metadata, take the data out of the data, take the data which defines this data and standardize that. So for example, if you have the DICOM data, there's lots of metadata that's attached to the DICOM. Extract the DICOM data from there and the metadata from the DICOM and store it, make it in a standard format. So now, and make it into a standard, one of the standard formats that globally is being used is the OMOP format. So make the data, store it in the final gold storage, which will have this data available to the different AI models. The second is the co-pilots for people. Co-pilots, it's a specific name, it's co-pilot, it's not pilot, it's not going to replace any doctors. It's just that going to help the people make their work more efficient. And it helps in doing the mundane tasks, the admin tasks that the doctors do, the admin tasks that the nurses do. They convert their admin work and their meetings, etc. to actions. They give them access to information. Suppose there is a doctor looking for a particular code for a particular disease, get them that information readily available. So co-pilot will be able to access the information from the data store that's there in the data foundation. So once you have the data in the standard OMOP format, or you have the data available in the PHI data available in a standard format that a co-pilot can understand, that data will be now accessible in a human interface, even queryable format, which will make the doctor access the data without knowing much about technology. He doesn't have to own it, he doesn't need to learn the technology, he just need to now start chatting with the technology. And the third one is, these are some of the questions that the doctor can ask any of the co-pilot. They can go and ask, what is the co-pilot, what is the patient experiencing, was the patient experiencing ear pain, gets the data from the patient's record. Something very, very similar, some these questions where the doctor needs to go and browse through a whole lot of paperwork or different systems. This will now be accessible directly via the co-pilot interface. And then the third one is the agentic information. Now the doctor needs to do workflow, needs to do some work that needs to go through a certain workflow. So he now needs to delegate actions for somebody to do it. And that is when the agentic framework comes into play. He can then go and ask the agent to do something for him. And the agentic workflow, keeping the human in loop, it can keep the human in loop, and keeping the human will finish off the work that's required. Again, the agentic will use the same data framework that's there, available, and the knowledge, it has trained on the knowledge that's there in the data framework. So this will be a multi-step action, but the workflow will be fixed, and the agentic will be able to go ahead and do that. So the doctor, there's a data that has been collected from the organization, the information is now available in a human interface, queryable format, and then there is a mechanism where the action from that data also can be done using the agentic automation. So what's an agent? Agent is basically it's an interface, it's a piece of technology which is built on LLM, which reads, understands your instructions in human language and interacts with different tools to give an output, and it can call the tool and take an action on top of that tool, etc. So and you can do lots of customization on the agentic framework. You can make it work in a way that it's very suited to your particular workflow or uses your data to build its knowledge and then act on that knowledge. Now, and when you are developing a tech on top of it, it becomes completely different. The way the tech is developed on top of it
completely becomes probabilistic and writing from log and really writing. So what happens now is we are this whole stack enables better accessibility to the tech to the non-tech world as well as making data more accessible. So that's what all about the co-pilots and the agents together. But on top of it, this is a PHI and it needs to have governance and control on top of it and safety on top of it. So, and the safety has to happen not only on the data but also on the AI. The AI should not be doing something that it should not be allowed to do, or if there is something that the hospital should not be doing, or the doctor or the caregiver should not be doing, that knowledge, that control has to be passed to the agent and the AI also. And that's where the governance and the safety comes into play. So it has to be, the governance and safety will be a horizontal line for the entire stuff. Couple of more minutes. So the value and impact that we have really seen, this is something that, and Apollo is one of the examples. Apollo has developed a health co-pilot themselves, which they have implemented. And there's a huge impact that we have seen in lots of places where the documentation time has gone down 45 to 60%, and the pre-auth cycles have gone down. The meeting to action conversions have happened very fast. Meeting to action have moved very fast. So we are seeing lots of benefits, and the adoption ladder, again, it's not something that you have to go on the complete stuff on day one. You don't need to boil the ocean on day one. You can go step by step, pick up one workflow, see the benefits, get the feedback, see the weaknesses, improve the weaknesses, and then move ahead. So, and the way this whole learning is all about, because it's AI, it is and it needs to be trained and ensure that it understands the data, it keeps maturing over the period of time to ensure that the governance is there, the capability is there. So that's what it's all about. These are some of the real use cases where we are seeing this getting adopted globally. We have seen transformation in clinical workflows. We are seeing acceleration of clinical research and patient care. We are seeing personalization of patient engagement and enhancement of actionable management. So management of actionables. So I think we are seeing lots of adoption of this stack already, and the whole standardization and the amount of data that's there and the amount of knowledge that's there in already existing in the hospitals is really going to help. But that I would say that's thank you for that, and we can continue with it. Yeah.
Thank you so much for sticking to time. I think technology is available and it's progressing very rapidly. It's up to the doctors and the healthcare workers to embrace and use it.
That's the story. Has to be the technology has to be doctor friendly.
That's right. Thank you so much. Yeah, Dr. Shujail has to leave, unfortunately, and so thank you.
Yeah, slides, keep the slides ready for Mr. Rajagopal, please.
Mr. Rajagopal, without holding you up, please go ahead.
So very happy to be speaking here. Once the slides are up, we can start. In the meantime, I'll set a stopwatch to 10 minutes and we'll see if technology can help in better process control. It will be a demo. So I'm going to be speaking about the use of data analytics and AI in Indian healthcare systems specifically. And we are going to see what it takes for Indian health systems to be able to adopt data analytics and AI. And we'll be sharing a little bit from our own journey at Narayana Health on how we went about building Atma and Medha, our EMR and our data analytics and AI platforms, and how we have gone about the adoption journey and some of the challenges and decision points that we had. How many of us think that data analytics and AI is useful in Indian healthcare and needs to be adopted? Can we have a show of hands? Great. I think most of us seem to think that data analytics and AI is of good use and should be used in Indian healthcare, but yet somehow it has not translated to the industry. The adoption of data analytics and AI is abysmally poor in Indian healthcare, even though all of us believe that it is something that should be done. It's a no-brainer, right? So for that, we'll just spend a couple of minutes in understanding the economics of the Indian healthcare system. In terms of, we all mentioned in this session, earlier sessions, earlier panels, morning sessions, that India is a resource-constrained environment in terms of healthcare. So in terms of beds per population, when we compare ourselves to the OECD countries, India has about 1.3 beds per thousand population, as opposed to the 2 beds per thousand population that WHO recommends. Which means we are clearly among the lowest in terms of beds per population when we compare ourselves with developed countries. Given that we have very low beds, what would you expect the occupancy to be? Given that supply is so much less than demand, we expect our hospitals to be brimming with occupancy, right? Overflowing with occupancy. If we compare occupancy of Indian hospitals compared to the developed hospitals or developed economies hospitals or the OECD countries, in terms of occupancy also India is the lowest. In terms of occupancy, we stand at around late 50s or early 60s, whereas some of the Western countries, they're at 70%, and some of the more mature economies are even at 80%, which means they're making full use of their healthcare infrastructure. So, we need food for 10 people. We have only food for 6 people, but somehow only 3 people have shown up to eat the food. That is the problem. That is the paradox of the Indian healthcare system. There are 4 fundamental problems in the Indian healthcare system which is responsible for this paradox. Some of the earlier sessions also addressed it. Access is one. We all know that the urban-rural divide is there, and our healthcare system is primarily urban-centric. It is 70-30 in favor of the urban, whereas the population is the other way. Only 30% reside in urban and 70% are in the rural. The second problem is affordability, which is one of our biggest challenges. Now in the 1.3 beds per thousand population that we spoke about, a significant portion of it, about 60% of it, lies in private healthcare. And private healthcare is beyond reach for many. Even in the urban areas where healthcare infrastructure is centered, it is out of reach for many. Which is why there is very, very low occupancy even in the private health systems that are there in urban areas. Third, of course, is trust. In rural areas, in second tier, third tier towns and cities, even if there are hospitals that are there, people don't trust them fully for tertiary work. They may go there for primary or secondary care, but for tertiary care, everyone wants to go to the big hospital in the big cities.
So there is a problem of trust also. And lastly, there is a weak triaging system that is there, which is essential for any good healthcare economy, where your GP network is extremely strong and triages the workflow that actually needs to go to the big hospital. This we often see is the problem in government healthcare setups, which is why many of the government hospitals are actually overflowing in terms of capacity. Because not everyone actually needs to go to a tertiary care facility, but because the triaging system is poor, everyone ends up overloading the main hospital. These are the fundamental problems in the Indian healthcare system. So that then brings us to the question. We all thought that data analytics and AI is essential and is for the good of the healthcare system. The fundamental question is, who pays for it? If I told you a good healthcare data analytics system exists and it is available for 20 lakhs, then you would think many hospitals can afford it. If I told you it costs 1 crore to put it up, okay, maybe a fewer number of hospitals can afford it. If I told you it costs 20 crores to put up such a system. So who pays for data analytics and AI? That is the fundamental question we need to answer to be able to understand how we can use data analytics and AI in the healthcare system. The Indian healthcare system today is characterized by high out-of-pocket spend, which means lesser number of people are covered by government insurance or by private insurance, and about 60-70% of the healthcare spending in the country happens out of pocket. Which means for a hospital system, which is an institution, the patient has very low bargaining power, especially in the private system. It is a single patient versus an entire healthcare institution. And the easiest thing for the hospital to do is not to spend on a data analytics system, but rather pass on their inefficiencies as higher bills to the patients, because the patient simply cannot challenge the institution. With deeper insurance penetration, with deeper penetration of government schemes, it will essentially cause the unionization of the customer, which means they will have better bargaining power, which is a market force which can then force the hospital to use data analytics and AI to bring down the cost of care rather than passing on the inefficiencies as higher bills to the customer. So that is one of the fundamental problems in our health system. And private healthcare being 10 to 15x as expensive as public healthcare, affordability is too huge a barrier to cross today. With minor operational efficiencies, it is very difficult to bring down the cost of care enough to be able to bring in a lot more people into the ambit of healthcare. We definitely need data and analytics and AI to transform the system, but today it is just a gamble that hospitals have to take. It is a huge leap of faith where they will have to throw in a ton of money and with no clear result that is there. It is a leap of faith that hospital systems have to take. So, for it to not be a gamble, we need to ensure certain things that go into building a successful data analytics and AI system. One thing we need to ensure is there is clear purpose to anything that we do. Data analytics and AI cannot be opportunistic, it has to be strategic. Where we say, I need to crack this problem, and when I crack this problem, this is the expected outcome of it. That needs to be very clearly defined. Analytics is a journey. It is not a random project that you pick up. And there is a clear pathway to this journey which needs to be followed, and that pathway needs to be strategic and not opportunistic. I came across this great tool, why not use it? That cannot be the approach to analytics, that will inevitably fail. And the second thing that we need to do is to ensure that there are success metrics very clearly defined around every project that we take up, so that everything is measured, the ROI is clear, which means we know what we are spending for. And the ROI pathway from the investment to the financial component needs to be mapped out and needs to be visible to everybody. So analytics is not just a few dashboards that are just put together. That is not a data intelligence system. A data intelligence system, as we mentioned, has a journey to it. First of all, there needs to be a clear data intelligence strategy. Data intelligence needs to be thought of as a separate, decoupled layer that sits on top of all your applications that can provide insights in a consistent manner that is tailored towards specific objectives. You need to put in place a data lake. You need to have a process to map and clean up your master data. You need to have unified data integration pipelines. You need to have a robust semantic layer that sits on top of all of your data, serving as the single source of truth for your entire organization. You need to have robust data governance, including data lineage, understanding failures, understanding data errors and rollback mechanisms built in. You need to have basic KPI monitors around every area in the organization, which is level 1, and level 2 is purpose-built analytics that is meant at solving specific problems. And finally, you also need to look at analytics and AI delivery mechanisms, which is critical. When we think about analytics, primary things that an organization should look at, or what we look at, is democratization and institutionalization of analytics. When we say democratization, every role in the organization and every decision they make is driven by data. And when we say institutionalization, data intelligence and AI is not a choice, but it is the process. Which means it is integrated into the workflows and not a system of choice. And finally, you measure everything. Everything ties back to ROI. That is the takeaway from this session. So finally, is there really an ROI available in healthcare for us to tap into? That is the question. We have gone through how to ensure that, how to figure out who pays for it and how to track the impact of analytics and AI. But is there really an ROI in Indian healthcare for us to tap into? And the most common thing, so to complete the story, we have huge demand, we have very less capacity, but that capacity is not being used. That is what we discussed. But the most common sight you see in any hospital that are not brimming with occupancy is people sitting and waiting in different areas of the hospital. Which means you have capacity, you don't have enough takers for that capacity, but still somehow you have waiting times. Which means there is a real opportunity for ROI. There is a lot of inefficiency in the system. The way we have gone about it is we've broken it down by area and understood how we can solve for inefficiencies in every area. And with respect to AI, we have approached, so data intelligence we approached it through functions. AI, we approached it through stakeholders, building co-pilots around every stakeholder that is there in the health system. In the interest of time, I'll end here. I'm available and we can discuss after the session as well. Thank you so much. It has been wonderful interacting with you.
Thank you, very interesting topic, and sorry for ringing the bell twice. I think Mr. Rola is next on.
Good afternoon, everyone. While I wait for my slides to be pulled up, thank you so much, Caho, for giving us this opportunity for giving me this opportunity to present here. I'll shift gears to a very important aspect of the Indian healthcare, the surgery landscape. So, how is technology shaping and making sure that the future of surgery is enhanced by going into the minimally invasive segment? As I was preparing my slides for speaking at this, India's most premier healthcare technology conference, Cahotech, I started, reflecting back on what role should technology have in an healthcare context, especially, as I said, in the surgical landscape. Should it have an active role? Should it have a passive role? Should it define or, should it drive advances in healthcare? From a surgery perspective, I think at least, these are some of the areas where technology should affect, and enhance things such as it should improve clinical outcomes. It should improve patient recovery. Technology should help the system to become more operationally efficient. It should lower total cost of care. And when I say total cost of care, I mean the total, the total amount that the patient has to spend from his or her own pocket for the entire healthcare episode. And also, technology should play a role at improving access to care, making sure it reaches places where, India needs it the most. That is what our quintuple aim at Intuitive is. We aspire to improve clinical outcomes by reducing length of stay, reducing complications. We plan and we aspire to enhance patient and surgeon experience by providing better ergonomics. We also make sure that we aspire to reduce the total cost of care by making sure that there are less surgical variations in the post-surgery landscape that the patients undergone, and also expanding access to tier 2, tier 3 cities of India so that they have this technology available at their disposal. I represent Intuitive Surgical. We are a global pioneer in robotic-assisted surgery. We are an organization of about 12,000 employees globally. Interestingly, we have treated about 16 million patients till date, and there are 80,000 surgeons across the globe who are trained on robotic-assisted surgery at 60+ robotic training centers that we have across the world. The mission of Intuitive and the motto of Intuitive is minimally invasive care is life enhancing, and we aspire to bring it to all patients who deserve it. Intuitive manufactures and sells robotic systems, but it is, we are proud to be called an ecosystem. The products and the ecosystem come with the name of Da Vinci. Now, whether it was the erstwhile Da Vinci S, which was probably introduced about 30 years ago, to the upcoming Da Vinci 5, which is scheduled to be launched in India soon as work goes on. The prime motto of keeping patient benefit at the core has been the driving force in making sure that our products are manufactured. In this short 7-8 minutes from now, I would want to cover only 3 aspects, 3 learnings for you. A, familiarize you with what robotic assisted surgery looks like. Answer the bigger question on why robotic assisted surgery. How is it different? What role does it play? Third, give you a glimpse of how this technology of robotic assisted surgery has been adopted in the world, and then of course deep dive into how it has been adapted in the Indian context. So starting with what is robotic assisted surgery? When a patient is recommended a surgery, there are few options that he or she has as of today. The traditional open surgery, which started with the belief that yes, surgery, is an art, and the surgery is performed by handheld instruments. The only thing that in such a open surgery, what happens is that patients end up having a much bigger incision, because the surgeon is not able to see the area which is affected, and they need to make a bigger incision to reach that anatomy. Fast forward to maybe 2010 onwards, we started seeing traditional laparoscopy as another way in which surgeries can be performed. Now, a laparoscopy improved definitely access to reaching the anatomy, making sure that the surgeons are able to see the anatomy. But with the laparoscopy also, there were certain things which Intuitive felt that could be improved, and those aspects were taken care of. And the reason for them, for those aspects was to make sure that patient's outcome can still be improved, as you move from the laparoscopy to robotic surgery. So if you move from left to right on this slide that you see here, basically the level of minimally invasiveness goes up. Open surgery is not minimally invasive. Laparoscopy is minimally invasive, but the next level of minimally invasive care comes with robotic assisted surgeries. Okay, very briefly, what happens in a robotic assisted surgery? First of all, it is robotic assisted. It is not done by a robot. So a surgeon sits on a console. Imagine the surgeon is sitting, comfortably on a chair on a console, and he has a high definition viewer in which he or she can see the patient anatomy, and there are master controllers on which the surgeon moves his hands to make sure that instruments move along, by a scaling effect in the patient's body. Now the advantage here is that wristed articulation is possible. The instruments that moved are controlled through, a computer, kind of a computer between the surgeon and the patient. So they provide greater range of motion. The instruments move in a more precise and a smooth manner. And also, there are no tremors. Imagine in the laparoscopic surgery, when the surgeon is doing a surgery, there might be shaking of his hands, and that might affect clinical outcomes. But in robotic surgery, it's a tremor-free technology. Surgeon stands in laparoscopic surgery and does it. And sometimes have to be in awkward positions to reach the anatomy. In a robotic assisted surgery, the surgeon is comfortably sitting on a chair, not even entering the sterile field, making it ergonomically very, very satisfying for surgeons. And I think that is the reason someone said in the morning, right, that 60-year-old surgeons have also started adopting robotic surgery, because it gives them a confidence that it can improve and enhance, their working or their surgical life as well. So they can operate more because they are more comfortable in it. Second, I think a lot of you in the room would want to understand, why robotic assisted surgery. When laparoscopy is available, it is also keyhole. But apart from just the session or advantages I said, why robotic assisted surgery? I think the main reason robotic assisted surgery is because of improved clinical outcomes. Now we did a meta-analysis of patients across the globe for 12 years across 22 countries, 7 surgical procedures. The outcomes measured here were, the outcomes mentioned here were measured. A lot of patients, were sampled in this. About 1.19 million patients who underwent a robotic surgery, 1.09 million patients who underwent a lap surgery, and 1.65 million patients, who underwent an open surgery. And it was across, randomized control trials, prospective studies, and other studies. What we found that most of the outcomes that matter to a patient were favorable in robotic assisted surgery when you compare it to lap versus open. Be it the length of stay, be it complications, be it readmissions, be it reoperations, or mortality rate. Robotic surgery significantly outperformed both both when it came to lap as well as open surgery. And hence, keeping patients' interest in mind, this technology is going leaps and bounds, by making sure that adoption is increasing. Now, as I said, from an adoption point of view, we have served about 16.9 million patients, till now. We have about 10,000 odd systems across the globe and 43,000 peer-reviewed articles. Interestingly, in the last year itself, about 2.6 million patients were treated on a Da Vinci system, and about 1,800 systems were installed, across the globe. Robotic assisted surgery is not limited to urology or gynecology or general surgery or cardiac. It has its adoption across multiple specialties, and the global trends of adoption clearly show this. In fact, urology, which was supposed to be a gold standard in terms of robotic assisted surgery, now general surgery and gynecology have fast adoption, in this as compared to urology. Quickly coming to Indian adoption, we have about 220 plus Da Vinci systems in India. Treated about 1.5 lakh patients till date. 40 plus procedure types in India are covered through robotic assisted surgery. And finally, an interesting statistics, because we are in Bhubaneswar, 1 out of every 4 patients we treat live in tier 2 cities. Thank you so much. I'm more than happy to take any questions. Thank you so much.
Thank you, sir. With that, we come to the end of this session. I think there is no question and answer.
Thank you, chairpersons and speakers, for this fantastic session. A lot of information coming in. I think your brains must be really,
And this gentleman was sitting behind and saying, I don't know what is going to be leaping as a frog and all. I told him, don't get into the animalia world and into the amphibian category. It's something which is different. So I had to make him understand the entire concept of what was being discussed.
Thank you for that. And we move to the session 3 and an announcement. Few very exciting, awards are going to be announced very soon. That's going to be next session. Session number 4, which will be announcing the Pitch Fest winners. And also immediately after lunch, we'll have the Hospital Innovation and Early Adopter Awards also being announced. So please stay tuned and keep your brains intact and focused. So we move on to the session number 3, Creating Tomorrow's Enterprise, Process Redesign and Change Management.
This reminds me of one of the movie scenes of Nava MBBS. Do you remember that? In that emergency?
Yeah.
Exactly. So how many of you all still remember that emergency scene when the patient is coming? Exactly, yes. I've had an experience like this. So this is something which you can relate to, that particular experience, and we will be discussing like how you need to change your processes and how you need to have a management of your processes. And for this, we invite Dr. Nithiraj Kande, who is the Global Chair of HIMSS Task Force and Managing Partner of Medium Healthcare Consulting Private Limited. Welcome, sir. The speakers.
Mr. Sujit Thakur, Chief Information Officer, Rajagiri Hospital, Kochi. He'll be speaking on transforming healthcare access with intelligent digital systems. And we also have Vijay Govindaya, Head IT Business Partner, Narayana Health, who will be speaking on re-engineering the patient experience using AI.
And I have someone from my field, Dr. Mamta Soni, who is the Chief of Lab Services at Apollo Central Reference Lab. And she will be talking on the future-ready laboratory, innovating beyond today's challenges through total laboratory automation. And Dr. Amitesh Khare, who is the Chief Medical Officer at Blockstripe AI, from insight to action, bridging clinical intelligence and operational efficiency. We request the chair to please take care of the time, and we request all the speakers to please abide by the time that has been given to them. Thank you so much.
Over to Dr. Gandhi to chair the session.
Good afternoon, everyone. I hope everyone's settling down behind also. And first of all, thank you so much, Kaho, Vijay sir, Lalu ma'am, and the entire team. Dr. Manish for taking up such a great initiative and powering Cahotech and the committees. I would like to set the context now for this session. We have 5 people, of which 4 are directly related to the industry. I work as a consultant, so sometimes I can be on both sides of the table. The most important part here, as you've learned, is we deal with behavioral changes, whether it's doctors, patients, or healthcare workers. A lot of times in theory, as Vivek mentioned in the previous session, it's very easy to say that I will use analytics, but analytics or any other practice that you use has to be deeply ingrained within the system. And the system itself cannot change very quickly. However, how does a particular system change? How do hospitals reinvent their processes? And how can it actually be made to happen? That is what my 4 esteemed colleagues are going to demonstrate out here. I would request everyone to please, devote their kind attention and ask us any questions. That's why I'm keeping the prologue a bit short, because I want them to utilize as much time as they can to share all these practical examples, and after that I would encourage audience to have an interaction with them. With this, I invite our first speaker, Mr. Sujit Thakur.
Thank you, Dr. Nithiraj. Thank you, everyone. So,
there is always a benefit of starting any session as the first speaker, because then you can set the context and maybe say the same things. Okay, I mean, something about myself. I mean, like Dr. Nitira said, I come from a technology background, but been in healthcare for almost 25 years. Worked in hospital, but then moved sides, worked on the technology side, and then started this company, Cahotech Technologies. And within this, we have partnered with a lot of hospitals. Our presence is in 11 countries. But using this role, I also am a CHCIO. So I help hospitals not only use the system, but to change the entire, what we spoke yesterday about people, process and technology there. So what I'm going to talk about, a very small initiative, which is primarily the QR code based, the usage of kiosk and all. Before I start, I'll just ask a question. What do you think, from a patient perspective, if a patient comes for an OPD and goes for a doctor consult and doctor prescribes some labs and he was to take a pharmacy, what would be number of places where he'll have to wait? What are the places where he'll have to wait? Give me a number, just a number, quick, because Dr. Nitira said we'll have to make it quick. 4? 5? Okay, what else? 4, 5? 4 maximum? And I'll say it is more close to 10. First he waits for, if he's a new patient, he waits as a registration counter. Then he goes and does the billing. If the billing and registration is not at the same counter, then he goes to the nursing queue, he waits there. Then he goes for the doctor, he waits. Then doctor prescribes few things. He goes to the billing counter again. 5. He goes to sample collection, he waits there. He goes to pharmacy for the billing, he waits there. Then waits for the dispensing. So close to 8. If there is radiology and few other tests, then the wait is countless. Now how can we use technology to solve this? So can we go to the next slide, please? Okay, thank you. So, I mean, again, I'll skip the text. This is not important. What is more important is that we make the system such that the interaction. I'll show you a video of a place. This is actually Rajagiri Hospital, the JC Grade Hospital. Fortunately or unfortunately, I don't know, I'll leave it to Father to say that. But they're using our software. I'll show you the case study. I'm also the CIO for them. So I'm showing you this video. Okay, can you please play this video? Can you go back to? When I say, can you stop it? So this is a kiosk that we have enabled. There the patients can do a self-registration. Again, there are two options. You can have an Aadhaar-based registration. You can have a non-Aadhaar-based registration as well. Yes, please. The consents are taken care of. While the video plays, I'll also keep speaking about. If you know, DPDP Act has been announced and notified by the government day before yesterday. No, you have to play the video, please. So the patient consent becomes very important. With this, that is automatically taken care of, because that once the consent is given, the SMS goes to the patient, WhatsApp goes to the patient that you have already given the consent. Because it's linked to Aadhaar, then all the nuances of the consent goes there. The demographics comes automatically, so that absolutely nothing that needs to be updated except address in case that needs to be changed. And this what we are showing is this is the actual thing. Other details are actually marked. You can't edit any of those. Quickly enter the details and the registration is done.
patients can book their own appointment there. Again, this is also OTP based. I mean, they can use their WhatsApp. Of course, there is a multi-channel. They can call up the call center, but then they can book the appointment also on the kiosk. And there's a lot of configuration. You can make the payment mandatory for a couple of doctors, so it's not that they can just take the appointment. You have to make the payments as well. In case there are any marketing brochures that you want to put, you can actually do that also. Plus, we also have an option for So this is once the doctor actually has prescribed, and all the doctors there are using the system. Once the doctor prescribed, the patients can go to the kiosk and do a self-billing. Majority of the patients, if they're not paying cash, they pay by credit card. Same thing can be done by the system themselves. So they go to the kiosk, do the self-billing. They don't have to go to the counter at all, because all the clinicians are using the system. The prescription comes to their WhatsApp automatically. If they can use it, the bills come to their WhatsApp automatically. They go to the kiosk, they do the prescription or orders which have been given to the doctor. Those also can be. Can you play the video, please? Excuse me. Can you please play the video? Let us stop. Can you take it? Okay, well, Dr. Nitya helps with the technology always betrays, so there has to be a fallback. But I can tell you this hospital here, there is no registration counter at all. No registration counter means no registration counter. There is of course a financial benefit. You don't need paper, you save cost there. But I think what is even more important is the patient experience. I don't have to wait for anything. And patients nowadays, because we as patients, we are used to this. We are doing it in any other industry. We are doing it in airlines, we are doing it while ordering food, we are doing it while booking our tickets. I mean, why can't we do it in the hospital? So same thing. We also have a QR code based registration, and that is what video is all about. I mean, you can just scan the QR code. Again, the idea is you don't have to necessarily go to the same place. If there are different clusters for OPDs, you don't have to go to the registration counter, then go to that cluster. You can directly go to the counter, scan the QR code, do the registration from your own phone, and then you can do the billing, and your name is in the queue. If you have already taken the appointment, it will come there. You can do a self check-in, do the payment there. If you have already done the payment, you just do the check-in, and you just, I mean, the whole idea is to give the digital experience, but the bigger idea is that patient convenience and patient experience. If you go to the next slide, and you can skip, drag the video to maybe 1.5 minutes, you can just drag that. It has moved out from here. The third slide. Okay, sure. So
I mean, again, the whole idea is that the 8 touch points that we spoke about, a minimum 8 touch points that patient encounters during the OPD, that can be reduced to either 1 or 0. The reason I'm saying 0 is because there are QR code, you just scan and you can do it, all of this on your phone itself. The typical, one of the questions that we get asked is, will it cost money and how much will it cost? In fact, it will pay for itself because you are saving a lot of cost, and because you are replacing systems from the desk, you can utilize that real estate for something else, and because it's QR based as well, then actually what the patients are using are their own phones, so you save that hardware cost as well. So that's precisely what I wanted to talk about. There were a few other slides, and so essentially what I'm trying to say is anything and everything what happens in an OPD encounter, the patient can do themselves. It is safe, it is secure, the communication comes to them automatically on their WhatsApp, and it's OTP based, so that it's not that it can go to any third. It can be integrated with Aadhaar also, so the nuances of DPDP, that's also taken care of. Thank you very much.
I would like to now invite Dr. Mamta Soni, and she'll speak on the total lab automation at the Apollo Reference Laboratory. Can we have the slides, please?
So good afternoon, the beautiful city of Bhubaneswar and the beautiful place called KIT University. It's my first time here. While the slides are being played, I just want to be grateful. Had a fantastic darshan today. Woke up at 3 a.m., went there at 4 a.m. We were here back on the first session. So it's a blessed day. Thank you, Caho, and especially Cahotech, and the organizers for inviting me and giving me this opportunity to share my thoughts on how technology is changing the laboratory perspective, the future ready laboratory with advanced total lab automation. Yeah, so just the classification of automation, because many people are not from the lab services. So, every other laboratory, it kind of advertises itself saying that we are automated laboratory. But actually, if we go by the definition of automation, no single definition exists actually, but analytical automation is where all analyzers are existing as standalone machines. So most of the laboratories in our country are having only the analytical automation. These are where there are analyzers which are working totally independently. Then we have the partial laboratory automation, which are automation islets. The lab analyzers are interconnected and partially integrated with pre-analytical workstations such as in the work area, integrating clinical chemistry and immunochemistry testing. So many of the even advanced labs in our country have this partial lab automation. And then we talk about the total lab automation, where most analyzers performing different tests like clinical chemistry, immunochemistry, hemat, hemostasis, so on and so forth, on different sample matrices like whole blood, serum, immunized or citrated plasma, are physically integrated as a modular system or connected by assembly lines, which can be a track, a belt, or any other type of conveyor. So this is what is actually a total lab automation. So why automation and digital solution? Digital solution at length has been spoken about for the hospitals, for the patient safety, but why for the lab? So we understand this. Objectives to consider for technology gain automation, I'll just rush through it because time is short. It is to extend clinical capabilities, improve quality of care, standardize the processes which we have, attract, retain or develop the workforce, reduce risk and liability, burden of overhead cost, improve profitability, stay competitive. So these are some of the reasons for which we should go for a total lab automation. Now let's see a standard workflow in a standard lab, in a mid-segment to a bigger segment laboratory. This is what happens there. There are pre-analytical pathways, analytical pathways, and post-analytical pathways. So when you give a blood sample to the laboratory, there are so many steps which are being taken care of. So pre-analytical is when the patient presents to the phlebotomist, the person who draws blood, to the time it is received into the laboratory for processing. So till the time the sample starts to get processed, all these steps are covered into the pre-analytical phase, and there are 18 steps ballpark. And then of course there is analytical phase and post-analytical again after the results have been generated from the analyzer. What happens till the report goes to the patient? So there are some 13 steps there also. Pre-analytical takes around 60% of the man-hour, analytical 30% and post-analytical around 10%. But then more the technicians, more the techs handle the tubes, the greater is the risk. So in the pre-analytical phase, we actually see there's a lot of fatigue happening, there's a lot of injury which can happen, there can be a blood spill which can happen, then of course there is an extended turnaround time. So more we do things manually, more the processes are handled manually, greater is the risk which can happen both to the patients in terms of error reports as well as to the staff. So what is the solution? Of course, automation. But it's not really wise to go very enthusiastic on automation. We have to first prepare our laboratory for automation. So the basic thing is that we have to find out from ourselves, ask ourselves a couple of questions. Do we have a standardized process? Because having a process standardized and documented in detail is critical to successful automation. An unstandardized process will result in an unstandardized automation. How frequently does the lab process change? So these are the pre-work which we need to do when we are deciding on an automation, because knowing the areas where frequent changes would occur needs a system with a flexibility to support the processes. So while we are choosing as lab leaders, as hospital leaders, as decision makers, what automation we should go on, we should have answers to these questions. How much of the laboratory process actually needs to be automated? Do not go ahead and automate everything, because the enthusiasm to automate processes can lead to over-engineering. Automation of some specialty areas actually can make the process more complex. So let's not make the laboratory a factory. We have to be very wise on what step are we choosing for it to get automated. So once we have the standardized lab processes, flexibility of a future lab growth and the simplified work within your controls, our lab is ready for automation. One thing we have to remember, if you automate junk, you get automated junk. So it's very important that we delete the junk out of our system and then go for automation. The first rule of any technology used in business is that automation applied to efficient operations will magnify the efficiency. But the second is that automation applied to an inefficient operation will magnify the inefficiency. So it's important that first we become efficient with our systems and then automate them. So step by step, leverage the technology to eliminate bottleneck, journey of continuous improvement. I'm talking only about the laboratory, that is my work area. The first step is to crawl, where we have minimal automation. Second is to walk-in automation, where we have integrated immunoassay, clinical chemistry analyzers, and there are some IT solutions to it. Third is to run towards automation, where we have more robust IT solutions. We have some pre-analytical stations. We have automated some of the pre-analytical and post-analytical processes. And finally is to fly, which is what I'm going to talk about. So this is the Apollo Central Reference Lab story. The Apollo Chennai DigiSmart Lab, which is India's largest zero human touch end-to-end multidisciplinary automation. So the sophisticated workflow and the automation design, it seamlessly integrates major disciplines of the laboratory like hematology, clinical chemistry, etc. into a digitally monitored automated track system, which helps us to consolidate huge work volumes and tube movement in line with the lean design thinking. So this is the laboratory, this is the topography. This laboratory caters to the hospital division as well as to the retail laboratories, so we get samples from everywhere. This is important slide because it talks about the informatics. Many IT heads are here. So we have two IT systems because one is from the retail and one is from the hospital, and they are interchangeable, and they are not interchangeable. They are irreplaceable because each of it is important for its business growth. So what happens is that They both are there in the system, we get samples received on one, and then we integrate into the middleware which is provided by the vendor, which is the Navify Lab Ops, and then they go their separate ways. They go populated to Apollo 24/7 or the retail business, and the hospital sample goes and gives the reports to the hospital system. So that is what a very good integration has happened. Also, employing advanced robotics, recursive workflows, high definition cameras, bespoke algorithms, and a lot of automation, we have been able to optimize processes, mitigate errors, and actually give a zero human touch laboratory where the volume has significantly increased right from 21% to around 40%, but our turnaround time has significantly improved. And turnaround time is the most important thing which a clinician wants or a patient wants from its laboratory. They want us to be as fast as possible. There are many steps which I said in the beginning. There were so many manual steps, and so many of these have been automated. Around 6 main and 14 sub-pre-analytical steps are automated. 3 main and 12 sub-post-analytical steps have been automated, and a total of 52 associated potential errors have been eliminated in our system. Time is short. I mean, this presentation at least requires half a day to tell all the success stories. But then there are success stories apart from the tag, apart from the volumes, also on cost efficiency, staff satisfaction, risk reduction, sorry for the and missing, zero error, and of course a competition leverage because we are the best in the country. Vision should always be do today, do now what patients need next. Thank you for your time. This is Zero Touch, end-to-end, multidisciplinary automation and digital solution at Central Reference Laboratory, Chennai. Thank you for your patient hearing. Glad to be here.
Thank you so much, Dr. Mamta. I think all of us learned a lot about laboratory. Those who may not have known too, I would like to ask Vijit from Narayana Ayurveda Health to now speak about some of the applications and use of AI that they have done to eliminate a lot of steps as well as optimize their workflows.
Good afternoon all, Vijay here. I head the IT business partner for the Narayana Group. Today I'm speaking something really close to everyone's heart. That's re-engineering the patient experience with the AI. Well, we have been speaking about AI, I mean, somewhere or the other, everyone keeps hearing about it. And from morning we have been hearing a lot of talks about AI. I think every hospital today, every healthcare or the clinics basically implemented the AI or the digital journey in some other way. Where exactly our steps begins with? We have AI in radiology today, diagnostics and predictive analytics as well. But what about AI in the patient journey, where every step, patient really looks at long waiting queues and all of that. That's the way we need to really look at how we can simplify the journey using the AI. Every hospital starts the digital journey, right? We mentioned about it. But what do? We start from the digitization. The digitization is where we mentioned about converting the direct papers to the PDFs, files to the folders. That's where we look at. Is that something which is really going to make any change, any difference in the overall impact of the patient care? Anyone? Okay. So next we start with the digitalization. In digitalization, many a times we actually look at transforming just the workflows to automations and it could be the patient forms, or it could be billing, lab, or all of these processes which we automated basically. But where exactly the real transformation happens is with the AI-driven insights. That's where the digital transformation comes in, and we'll be able to make those changes or bring AI in our practice. Okay, that's where the true digital transformation happens. We have been speaking about AI, and I think we have moved from the artificial intelligence to the augmented intelligence today. had a couple of other things to speak, but in the interest of time, I'll quickly move on because I have certain videos and demos also to be part of my slide. So, where exactly the patient journey starts is basically with the OP or an IP. In the OP, it typically starts with I booking an appointment or you booking an appointment basically. And how do you book an appointment? It starts with the digital journey is one on a mobile app or in a web app, or you call to the contact center. The mobile app booking an appointment is been a seamless journey.
This is Neha. How may I help you?
What started before me? Let it come.
Actually, I'm looking for an appointment with Dr. Grace.
Thank you for sharing that. Just to confirm, are you already registered with Health City? And are you calling from your registered number?
Yes.
Thanks for confirming. I'll check your details now. Please hold on while I verify this. Thanks for confirming, Ms. Sara Rakis. Please hold on while I check available slots with Dr. Grace. Could you tell me if you have a preferred date or time for your appointment?
Yeah, can you check for today any available slot is there?
Thank you for waiting. Dr. Grace has slots today in both anesthesia and dental departments at 2 locations, Kamnabai Clinic and our Cayman Islands main hospital. Could you confirm which department you'd like, anesthesia or dental? And would you prefer morning or afternoon?
Department, I'm not sure. Can you please help?
Of course. Just a quick question. Are you seeking help for pain, surgery, sleep issues or dental care? Tell me a bit about your main concern or symptoms so I can guide you to the right department.
Yeah, actually I'm facing issue in my tooth cavity.
Thanks for clarifying that. Since it's a tooth cavity, I'll connect you to Dr. Grace in the dental department. Would you prefer a morning or afternoon slot for your appointment today?
Afternoon slot would be fine.
Okay, it has an, okay, just a quick question. Here the patient interacted, he called the contact center.
Yes, we've got several afternoon slots today with Dr. Grace in the dental department at Kamana Bay Clinic. Just to confirm, will you be able to come in after 1 o'clock? If yes, shall I offer some available times?
Yes.
Great. Here are a few available afternoon slots with Dr. Grace in dental today. 1:15 to 1:20 p.m., 1:30 to 1:35 p.m., 2:10 to 2:15 p.m., 2:45 to 2:50 p.m. Would you like to pick one of these or need a later time? Hello. Welcome to Health City.
Okay, so what did we see here? The patient called the contact center. Who was the other person who was answering this call? Do you think it was a human? The bot, what we have is able to pick up. The patient mentioned about he would just like to consult a doctor. He was not sure about which department to consult. So the bot suggested, based on the symptom, the bot was able to suggest whether he wants to meet a dental doctor or an anesthetist or a cardiologist. So the bot was able to answer which department to he has to consult, the time slots which is available for his appointment, and the continued audio which we had also had a reschedule and a cancellation option as well. So this is where the patient would really like to speak to, or where you can really look for the real transformation happening. So the journey begins with the appointment and then they go with the pre-assessment. Today morning, one of the speakers was mentioning about how do we solve a problem in terms of the patient coming and, patient not waiting in the long queues to complete their assessments, then go to the doctor. The next quick video will show you how exactly the pre-assessment can work, and this can also help you understand how quick the patient can sit at home, finish his pre-assessment, and then come to the hospital, directly walk to the doctor.
Hello. Namaste, I am Medha, your cardiology nurse. I need to ask a few quick questions before you meet the doctor. say, end conversation to stop anytime. What heart problem or symptoms brought you to see the cardiologist?
I have pain in my chest.
How long have you been experiencing this chest pain?
For the past 2 weeks.
How would you describe this chest pain? Is it sharp, dull, burning, or something else?
It's sharp pain, mostly towards the right side.
Have you been diagnosed with any heart-related condition in the past? If yes, please share the details.
In the interest of time, I'm just stopping all the videos in between. Kindly excuse me for that. But the same pre-assessment, what you saw here is not a fragmented one. It's not just that the bot records it. It goes and sits into the doctor's EMR screen, which means that the patient comes to the hospital, directly walks to the doctor has already all the pre-assessment filled in, and the doctor starts the consultation immediately. Which means that, look at the way we have transformed the journey of an outpatient with no waiting queues, okay? I have a kiosk component also here, I'll not touch upon on that. Already my friend Sujit has spoken on about it. It's similar features what we have, and if at all, if any of the patient has not completed his online payments, they come to the kiosk, complete their payments, either it could be consultation, services, diagnostics, radiology, anything, they can just come, finish it. Additionally, what we have also done in the kiosk is, whenever the doctor places an order for any of the investigation, they need not have to go back to the counter again. The kiosk is able to serve that as well. And what we have additionally done is, look at how we can reduce the time of doctor during the consultation, referring back to multiple screens in terms of the looking at the lab investigations, radiology, past history, medications, everything. That's where we have the tool which will analyze everything, help the doctor what exactly they need to really look at and complete the consultation, prescribe and move on. Before the second bell rings, I just need to finish it, so I'll just quickly move on. So, next comes the where does the patient access the reports? We have an NHCare app, which is a patient app where they can access all the reports, bills, discharge summary, everything. So this is the OP journey. Now quickly I'll move on to the IP journey. The next comes is the IP journey, inpatient journey. The doctor might have prescribed or advised for an admission. Many of the times we know that there is a placeholder for a doctor in any EMR today to actually advise for an admission, request for an admission basically. What happens when the doctor writes advice for admission or ADV for ADM, basically in the note section? You lose that lead. The patient will not be aware that he has been requested for admission. The doctor will not be aware that whom I have requested for admission. The hospital will not know. We have an AI component which will pick in any of the places wherever the doctor has written, either he has written advice for admission or ADV for admission, it will pick up that and put it into the admission request. If you look at the screen, you can see the AI component on the left in the document number. That's where the AI has picked it up. The system has picked it from the note section. We have close to 500 such requests in a month, in a day, sorry. Alright. Then quickly move to the admission board basically. I'll just explain to you, just go through this because the video has already got played. I'll just explain on that. happens when there's been advice for an admission or request for an admission? The patient has to get admitted. Typically what happens basically, whenever the patient has to get admitted, they come to the hospital, they come to the hospital and then they will have to fill the form, they will have to give their ID proofs, make the payments, then the bed gets allocated. All of this typically takes around 2 to 3 hours of time that everyone might have experienced. What we do, the moment that the request for admission has happened, the admission bot will trigger a message. The bot starts responding with the patient, and that's when it will collect all the details, including the ID proof, and it will even send a link for the payment. Once the payment is done, the hospital acknowledges it, everything is automated, and the bed gets allocated. This is on the admission bot, and yeah, we are also working with smart scheduling, but I will not touch upon on that since the remote monitoring is basically once the patient has got admitted, what's next. Today the doctors in our hospital does the rounds first round happens sitting at home or in the car while someone is driving. How? That's the app which we have for the doctors. Majority of it, everything, we ensure that the doctors gets all the details on the app for them to check which patient, what is the immediate care or the critical care, what is required, and they come to the hospital prioritizing which patient or which ward for them to visit first. Even the risk scores, everything is calculated automatically, and they get the analysis happens. Next comes once the patient is admitted, what comes next? Many of the times it's about how does the patient raises the complaints or raises a request. How do we know? Many of the hospitals today, we know that every bed has a nurse calling bell. The moment nurse calling bell is pressed, the nurse comes in. Nurse is supposed to do the clinical work, care for the patient. Are they supposed to do the housekeeping, or if the food is cold, have to replace it? Who has to do this? The respective departments. How does this get routed through the respective department? That the bot automatically does it. It will route through it will take you through the right departments. The AI will do that. This is how the entire journey is, even including the discharge process. The discharge process is something which the moment the patient is marked for the discharge, the payments, everything can be done online. While the bot, the patient will be able to even track the status where exactly the clearance is pending for. In the interest of time, I'll just quickly leave the slide. It's a you can just read that. You can clearly understand what exactly we are trying to measure out of the entire AI journey. One thing I would like to leave before I leave is basically everything, whatever we have done is the AI on top of the application layer, because you cannot run the AI layer without an application of the structured data basically. So whatever you are seeing is all measured. With this, I will thank you Nitiraj.
Thanks so much.
It was an additional time. Thanks.
Thank you. We just have a paucity of time, but in the interest of the audience, what we can do is we'll have the videos played while the lunch break happens. So I request Amitesh now to please.
Thank you, Kaho, and thank you, Nitiraj, for the warm invite. So, I know it's almost lunchtime, and I'm stopping you from lunch, and already so many insightful sessions have happened. So we'll try to keep it very simple, exactly like how our product is, like very simple. How do we understand what's the clinical intelligence, and how do we really bridge operational efficiency with clinical intelligence? So I am Dr. Amitesh Khare, the Chief Medical Innovation Officer at Oxtribe, and next slide. So a brief background about me: I am an alumnus of AIIMS New Delhi and ISB Hyderabad, and over the last 5-10 years I have been working with operational teams at AIIMS New Delhi, understanding that the large volume of patients which we have at our hospitals, how do we really solve those problems? Now the problems which we face in modern hospitals is, and everyone has talked about it, and it might sound repetitive, that
there are fragmentation of care, and we are talking about data appearing in silos. But what I want to focus upon is that a lot of data opportunity is now getting generated because a lot of hospitals are adopting digital solutions of different levels. So you have hospitals with really mature digital systems which have data captured across their pain points, whereas you have hospitals which have adopted data processes in part and pieces. And our journey has been shaped out by the experience and challenges of those hospitals as they have shaped. So leading hospitals face this challenge that on one side they have a footfall of, let's say, 1,000 to 2,000 patients entering their OPD campus every day. However, if you would ask them at the end of the day how many of them were, let's say, prescribed an IPD or prescribed some radiology investigation, now the guy would be downloading one Excel sheet on their EMR, and then another billing data would be downloaded, and then the operations manager would be reconciling them, and then that data would be transferred to the operations team to look into it. So what I am speaking is not just a story of just one hospital, but a journey of a lot of hospitals in different phases of digitization in India. And because of this, we are not just missing out on real-time intelligence and business opportunities, but are also losing opportunities of providing care when it is timely needed. So, DocStripe started working on the principle of how do we marry clinical intelligence with operations. So what does clinical intelligence really means? So we talk about a unified intelligence layer which runs across your hospital. It connects all data points across your OPD, IPD, diagnostics. The patient might be coming up with past medical records. There could be some investigations done across the journey of the patient in the hospital. Now what it is doing is, it is predicting those care needs, creating those dynamic engagement pathways, and most importantly, creating opportunities of engagement. And towards the next slides, I'll show you how do we do it. Moreover, it also automates follow-ups, different multi-channel engagement for patients, be it for their OPD engagements, be it there for their diagnostic engagement, be it there for their laboratory or even post-discharge care. And that is how our single goal of how do we align patient outcomes with a financial performance, which also helps the hospital to ensure that they are able to run sustainably. So, just at a snapshot, if we were to look, and I'm sure again, sounding repetitive, if we are looking at the journey of a patient across the hospital, so you see there are multiple care gaps which exist in the ecosystem. So, I mean, someone who has visited in the OPD might be, asked to go to a radiology setup, get an appointment there, get an opinion there, maybe a comorbidity consultation, an IP advice. There might be more processes in the journey. Elective surgery schedule would require 4 additional steps, getting a PAC done. Now patient is also waiting for a cross. So there could be multi-chronic, multi-morbid patients who would be requiring, multiple consultations, and the bottlenecks can be any. So it can be a cardiology clearance which is actually preventing a total knee replacement from happening. Now all of these processes are happening in the hospital. There can be issues as trivial as insurance, file pending, and you could have maybe a patient who is willing to get into the, looking for a second opinion but has not been provided. So what DocStripe does is identifies all of these opportunities using our AI-first platform, and how create those navigation pathways through which we are able to engage with them timely and provide the most important outcome, which is timely care, and the second aspect which would create a win-win mechanism for the hospital to have financial stability for it to run sustainably. So what DocStripe does is, again, we are a holistic solution. Again, we understand that India is a country where you have varying level of, and we were talking about in the morning session that what are the solutions which can really work for tier 2 cities, tier 3 cities. I mean, I am a small hospital, I am just 100 bedded, or I am a 1000 bedded hospital. What is that solution? What is that holistic single platform of digital transformation which can sit, integrate, work anonymously, work independently across all forms of hospitals, and that is what DocStripe is here to offer. It's a plug and play deployment. I mean, it all depends upon your tech maturity. So it works with, so like one of our great partners is Max Healthcare. We work across group there. So we're working with one of the most advanced secure systems, as well as We have partners which are small hospitals, 50 bedded, 60 bedded, 100 bedded. So it all depends upon what is the requirement of the hospital, and our focus is very clear. We work with the hospital across the specialty you want to grow in. So there could be a standalone orthopedics hospital which is a 50 bedded hospital. It's not that patients who require a total knee replacement could wait there. So are there digital solutions which can actually help and improve engagement, and that is DocStribe all about. And it covers the whole continuum of journey from pre-arrival of the patient to OPD, IPD and post-discharge. So how do we do it? Again, it's a very simple 5-step process. We start with data ingestion, so it could be prescriptions, diagnostics, vitals, notes, any document, any form, digital, handwritten, all of it comes together, it is all ingested, and the next layer is contextualization, so that is where a deep LLM understanding comes in. So we create that clinical intent and clinical understanding of that patient, and there it automatically shifts to cohort identification, so we there start to identify who are these high-risk patients across different specialities. So there might be, some triple vessel disease blockage patients in a cardiology OPD who might require a very different nature of care compared to, let's say, a general medicine OPD patient. Because we also need to understand, and since we are talking about system redesigns, that healthcare professionals are overburdened. If I ask my nursing staff or if I ask my engagement team to talk to all the patients who have come to an OPD or an IPD every day, the system is bound to crash. So at the outset, we have to create that Pareto efficient frontier where we are engaging to the ones who require the most urgent care. And then it moves to an action layer where AI agents trigger follow-ups or alerts, and then the feedback loop where the system learns from itself. So again, we can work with the unstructured data. We have also developed custom predictive models across different specialty. The engagement is again multi-channel, so there are WhatsApp conversational platform where it, at Medanta, the platform which any WhatsApp trigger which comes out of Medanta is powered by DocStribe, and that serves as a clinical assistant which hospitals can use for identification of trigger points which patient might have to offer even after when they are not in the hospital ecosystem. You have examples of identification of those nudges and how do we book appointments and how those updates are reinforced back into the hospital ecosystem. So what we do is not just focus on patient while he is in the hospital, but across the whole journey continuum, which starts before the arrival of the patient into the hospital and ends with post-discharge. Again, this is an example which I can skip. So this is where the magic happens. So this is with the patient. Again, it's an admin level dashboard. So you are able to see a snapshot of a bird's eye view of how the complete ecosystem might look like. Again, all are customizable and all are modular frameworks. So for example, someone would want to understand that I want to engage with the cardiology cohort and all the high-risk patients amongst them. So you can drill it down, you can go across the specialties, and we have developed detailed workflows across different specialties. And this, once you open up any particular patient, you can identify what are those parameters, what is the layer of the evidence, and simultaneously engage with the patient on the same platform. Very quickly, our operational efficiency metrics. I mean, we talk about using the same base of retention for patients to improve OPD to IPD conversion, post-discharge patient retention, which increased by 22 percentage points, and this is the average across partner hospitals. We were able to reduce the turnaround time by 83%, and overall, the whole patient care experiences, there have been testimonials, stories where we have been able to shift the nature of care from reactive to proactive in whatever places we have been working, and we are live across major hospitals group, and what we want to convey with DocStribe is that together let us focus on understanding different needs of different hospitals and see how we can work together and create an ecosystem where the needs of small to large to any form of hospitals can be met. That's all. Thank you from my side.
Thank you so much, speakers. I'm just giving time
check, do we have time for 1 or 2 questions? No, okay. So we'll take the questions, you can meet the speakers over lunch, and we'll definitely play the videos which we missed out on. Handing it over to our host.
Yeah, thank you so much, Chair and the speakers. Please, assemble here for a photograph. So meanwhile, we have good news and a bad news for you. So what do you want first?
We would always prefer to have something which is good.
No, good comes next. We'll start with the bad news. So there won't be a scheduled lunch break today. That's the bad news for you. But then, good news is you can go as small batches and have food and come back. Don't go together, so hall will be empty. So maybe few of you can go and come back and then join, because there are a few announcements happening. So especially people who are participating in the Pitch Fest, the hackathon, the hospital innovation adopter, early adopter are requested to stay here, because that's going to happen now. Others can go in small batches and come back.
And the ones who go a bit later will get something which is special. So the ones who are leaving early, they are going to miss on something which is very good, especially for the food.
So may we invite the chairpersons for the Pitch Fest, Dr. Muthu Singaram, CEO IIT Madras STIC Incubator, and Mrs. Mukta Arora, founder and CEO of Leo Health, to come on stage. They are the pitch masters for years for the Cahotech, and we request them to take the session forward.
And the theme is the best of Pitch Fest, healthcare startups transforming care.
Good afternoon. Good afternoon. Thank you for giving us this opportunity to present the Pitch Fest and also the poster presentation which was done yesterday. So first of all, thank you to all the startups who took part, to all the jury and all the mentors who helped selecting them. So I'm going to call 4 other startups to do a live presentation, and I'll tell you what to do when you come up. So the 4 I'm going to call up is, of course, I have with me Aurora, who will also help me with this. These are the 4. Please come up if your name is announced by the MC.
I'm having a tough time with all the pronunciations, and if it's going to be some way a bit distorted, I'm extremely sorry for it. The Pitch Fest startup presenters: Medlast Private Limited, Euro VIB, Gargi Automated and Robotic Gadgets Industries Private Limited, for automated transformable bed and e-chair, the BabyQ Private Limited, for product DIQ and service GI Bud, and the Primary Healthcare Private Limited for Mobi Lab. We request all 4 to please be present on the stage.
Give a huge round of applause for the winners, the 4 winners for the Pitch Fest Cahotech 2025. I'll repeat the names. So please come fast. We are short of time. Please come fast. Medlast Private Limited, are you here? Gargi Automated and Robotic Gadget Industries Private Limited. Yeah, all of you can assemble on the stage. BabyQ Private Limited and Primary Healthcare Private Limited.
Okay, we're going to keep it very simple because we are running late today. So each one of them will do for 2 minutes. They will tell you their problem and solution, Okay, so starting with you. Just talk about it, no need slides, nothing. If you cannot sell your idea in 30 seconds, then it's not great, right? So I'm giving you 2 minutes, that's 4 times the chance. Go for it.
Good afternoon. My name is Nirmal Kumar from Medtalks Private Limited. So we are working on catheter-associated urinary tract infection, and we are developing a device, Eurovial, which is going to prevent these infections. So this infection is very common, very most common hospital-acquired infections, and it takes thousands of lives every year. So basically, we are developing this device. This is going to prevent this infection, and we can make this deadly infection just a minor infection because of this device. So we think that it is work with the two existing synergistic mechanism. Based on that, basically we are irradiating the UV and the surface acoustic wave. So basically, combination of these two technologies are used for controlling the infections. Thank you so much.
Very good, excellent. That was less than 2 minutes. See, you can do it. Okay, Gladly go for it. Bit little bit louder so they get encouraged.
नमस्ते, मेरा नाम शीतल है और मैं गार्गी ऑटोमेटेड एंड रोबोटिक गैजेट इंडस्ट्रीज प्राइवेट लिमिटेड की संस्थापक हूँ। हम बेड रिडन पेशेंट्स के लिए असिस्टिव टूल्स बनाते हैं। उनका जो मेन प्रॉब्लम है लिफ्टिंग एंड शिफ्टिंग, उसके लिए हम असिस्टिव टूल्स बना रहे हैं, जिसमें हम अभी प्रस्तुत कर रहे हैं ट्रांसफॉर्मेबल ऑटोमेटेड ई व्हील चेयर, जिसमें पेशेंट अपने मर्जी से बाय जॉयस्टिक यूजिंग जॉयस्टिक मोबाइल ऐप या कंट्रोल वॉइस ऐप से बेड को व्हील चेयर में कन्वर्ट कर सकता है। ये व्हील चेयर जो है, इसमें हमने कमोड चेयर भी इंक्लूड की है, तो उनके साफ सफाई के लिए जैसे कुछ दिनों के बाद बेड रिडन पेशेंट्स को खुद ही ट्रेन किया जाता है कि वो अपनी साफ सफाई खुद कर सकें, तो वो भी उसमें हो सकता है। दूसरी बात है कि इसमें हमने बैटरी बैकअप दिया है कि अगर सोचिए कोई बेड रिडन पेशेंट्स अपने घर से काम कर सके या अच्छा इंफ्रास्ट्रक्चर हो तो उसमें वो घूम के काम भी कर सकता है। तो ये ऑल इन वन 4 in 1 इक्विपमेंट का काम करता है, जैसे बेड, रिक्लाइनर, ई व्हील चेयर एंड कमोड चेयर ऑल्सो। साथ ही साथ इसमें हमने जो उनकी मेन प्रॉब्लम है एक ऐसी व्यवस्था की है जिससे कि उनकी स्किन को हमेशा हवा लगती रहे, और बेडसूर का जहाँ तक हमने सर्वे किया है, उपयोग किया है, उसमें बेडसूर का खतरा करीबन 70% तक कम होता है। साथ ही साथ ये इंडियन एटमॉस्फेयर या फाइनेंशियल स्टेज को देख के कि ये बजट फ्रेंडली है, जहाँ पे आपको 4 इक्विपमेंट पे खर्चा करना पड़ रहा था तथा सबसे जो महंगे बेड्स खरीदने पड़ रहे थे, ये आपके कॉस्ट कटौती करता है, आपका टाइम बचाता है, और फैमिली और केयर गिवर्स जो है या फैमिली मेंबर जिनको अपना समय खर्चा करके एक पेशेंट की निगरानी करनी पड़ती थी, ये सब कुछ आपका बचाता है और ये कॉस्ट फ्रेंडली भी होता है। और हम कोशिश कर रहे हैं बेड रिडन पेशेंट्स या एजड पर्सन्स या जो इंजर्ड पर्सन्स है उनको थोड़ी बहुत मोबिलिटी और सेल्फ थोड़ा बहुत अपने मतलब डिप्रेशन से बाहर निकाल सके। थैंक यू।
Good afternoon, ma'am. Imagine a world where, in the rural corner of India, a parents with their children having diarrhea, which is very most common public health concern, and coming to hospitals, and doctors or any frontline health worker prescribing antibiotics without doing any confirmation test whether this diarrhea requires antibiotics or not. So with that concern, with that program, when we have visited more than 20 primary health centers and rural health hospitals, so we found doctors are prescribing unnecessary antibiotics, or frontline health workers who are prescribing unnecessary antibiotics to their children. Then we come up with directive. Hello everyone, myself Manish Kumar Swami. I am the founder and CEO of BabyQ Private Limited. With me, my co-founder
I'm Rishika Keria from ABQ Private Limited. So as Manish rightly mentioned, that antibiotic has been prescribed to children and 1 in every 5 child dies due to antimicrobial resistance. So we are here with a mission to reduce 20% of overuse of antibiotics and give children a better and brighter future. So with DiaQ, we detect early and protect always. Thank you.
Thank you. The next one, please. Primary health tech.
Yeah, good afternoon all. So myself Parth, I am from Mobilab. I am presenting a Mobilab, which is a portable diagnostic medical device which can do around 25 plus tests of liver, kidney, heart, diabetic and anemia profile and can give result in a few minutes. So this is a lab in a box. So in 2020-21 we have started working on like what are the gaps of diagnosis. So if you go in today also in rural area, in villages, if somebody wants a diagnosis, they need to travel to 10 to 15 kilometers to urban city area lab, and after one day they get result, and they are also earning 300 to 400 rupees. So we are come up with a thought like how we can bridge this gap. So we have made a portable lab which can be placed at doctor's clinic, and there and there diagnosis of primary care can be given. So doctor's clinic, pharmacy store, lab, diagnostic lab, nursing homes. So we are making available this device. This device can do LFT, KFT, lipid, hemoglobin, anemia, all type of screening. And our R&D is currently working on thyroid profile, vitamin D3, B12, urine analysis, fever panel. So at the end, it is going to be 50 plus parameter in just lab in a box. So with this idea, we are reaching out last mile clinics, rural India, and CHC, PHC, ASA worker level to bridge the gap of diagnosis.
Very good. Everyone is finished within 2 minutes. People they complain when I told them 2 minutes. They all did a good job for 2 minutes. Please give a hand again for that. Don't go anywhere. Please stay there. Ramya, can you please come up, please, with your students who did the hackathon? That's fine. Whoever you have. Yeah, you want to say something?
Thank you, Taho, for giving all of us at KIT this opportunity to encourage students to think about hospital problems in reality. So basically what KIT did was conducted a hackathon over 24 hours, and they were presented with 2 challenges, either developing a discharge assistant or developing a digital consent companion. So some of the teams focused on the consent companion, and yesterday they presented at the Pitch Fest, and many people in the audience were very impressed by what the technology students, undergrad students came up with in a very short span of time. So they're looking forward to working with all members of CAHO, all delegates here, and trying to work on their problem and take it to a more polished solution, just like all the other Pitch Fest teams here are doing. So I would like the team to introduce themselves.
Hello everyone, I'm Shriyansh Patnaik, and I'm a first year student in KIT University.
First year, KIT University.
Good afternoon everyone, I'm Kavya and I'm also a member of Team Tangle, and we have made a digital platform called Know Your Consent, and we're looking forward to make it better, work on it, and somehow try to match or even reach somewhere closer to the other teams that participated in the Cahotech.
Hi everyone, my name is Bayan and I'm the leader of Team Tangle. Our app basically verifies that consent is understood by the patient, and we work on this.
Okay, can I get 3 more teams to come up? This is not in any order, just a business call you. Infinis, Infotech LLP, are you there? Please come. Labs Private Limited. Labs Private Limited. Number 3, that's Pros Cyto Labs Private Limited. Come please. These 4 please. third one, Extra Private Limited. You are there? Extra? Sure, you are there? Not sure? Extra, not sure, not sure? Okay, not sure, never mind, okay. So these are the people who participated, and now I'm going to ask the President to say a few words before we hand them a token of our appreciation for taking part. And I think we should all clap for everyone. If you will clap for ceremony. Very awesome.
This has been a great exercise where we have tried to involve the young minds to get connected with the problems of healthcare. So I think this is going to go a long way in building this relationship. We look forward to Caho and you nurturing with each other and interacting with each other. Thank you very much for being here. Yes.
So Caho and KIT organized a hackathon, and the winners get 10,000 rupees as cash prize, and Plan B won the 10K prize.
The leader's name is Aryan Pandey. Plan B, the Caho KIT hackathon on the 4th of November. Plan B.
Not here. Okay, so the 5K second prize goes to Tangle, Mayank Ranjan. Yeah. Yes, and there are a few finalists who gets a certificate. Pure Cure. The team is here, Pure Cure.
So here you can come up and collect it.
Please raise your hand if you are there in the audience. Pure Cure. No, I don't think they are there.
Not here.
Stack Overflow.
No, the other teams are not here. So we'll go to our poster presentation.
Yeah. So the poster presentation winners in the order 3, 2, 1. In third position is Infedis Infotech LLP. Do we have here? Yeah.
We request you all to please clap.
Yeah, please applause. Oh.
Thank you. They are really putting a lot of efforts.
The second winner is Labs Private Limited. We have the team here. Labs Private Limited. And the first position is Xshore Private Limited. You have the team here, Xshore. Yeah, please come first. Xshore Private Limited. Yeah, they're there. Yeah, they're coming. Run.
If you run, you can have a better lunch. You also come up, get somebody else to take the picture. Get somebody to take the picture, you come up. Come. You get the picture anyway, they'll send you a copy. Come stand there.
So,
team member.
One of the finalists is over here, sir. So we would like to invite Mind Morphs. Mind Morphs put up their presence. Yeah, please do come. Thank you.
This is for the kids.
This is for the hackathon.
Hackathon finalist, Mind Morphs, they are present over here. So requesting the backend team to please give their certificates.
All those who got your prizes, don't leave the room. We'll take a picture together. Then you can put it in your website. We'll all get some promotion. Some influencers. Thank you. Now for the big one, do it from the reverse, please.
Yeah, so the Pitch Fest startup presenters in this order: Medlarks Private Limited, Eurovib. Please come and collect your. Oh, just a minute, sorry. So this is 4, okay. Sorry.
Okay, so he's taken it upside down. I'm going to take it the other way around. So that's when you don't eat food and your glucose levels start falling. May we request upon Primary Healthcare Private Limited for Mobi Lab to come forward for the and BBQ Private Limited for the product DiQ and service GI Bud. So please come ahead. They are all together.
A huge round of applause for the new energetic creative minds. BBQ Private Limited. Now we have Gagi Automated and Robotic Gadgets Industries Private Limited. And Medlarks Private Limited. Both the teams are requested to come and collect their mementos. Gagi Automated and Robotic Gadgets and Medlarks Private Limited. Any closing remarks from the chairs?
Okay, that sort of ends the presentation. Thank you very much to the President, to Lalu, everybody who took part here. Thank you so much. Can everybody come up and take a picture? And also, of course, to Gupta, who's here as well. So, and thank you, Lalu, so we can go to the airport happily. Even though we are on the same flight, but okay. So, can all the winners come up here to take a picture together with everybody? Even the others come, please.
Yes, the winners of the Pitch Fest, please.
Ramya, you also come.
You are good.
You are the leader.
The winners, the finalists, all of you all please be here for a photo session.
And any of the juries there also please come. More the merrier.
Jury members for the Pitch Fest, please to join the stage.
Please come. And those speakers also come.
I can see Ranjit sitting
there. Speaking did the master class. Come.
This is a proud moment for this young generation and we all should be there to support and give them a big, huge round of applause. Please motivate them. Thank you so much.
Thank you very much.
So we are moving to session 5 now.
Thank you.
Because as we are already running short of time, thank you Dr. Muthu and Mrs. Mutta. You've become a doctor anyway, so as good as a doctor. So session 5, again, this is the results of the innovation, hospital innovation and early technology adoption awards. So may I request the chairs, Dr. Ayush Gupta, Captain Bobby Ramesh and Mr. Rajarajan to come out of the stage. Do we have the chairs here? Yes. Chairs first have to come, then we will call the participants. Yes. So the chairpersons for the session 5, which is the best of hospitals championing innovation and early technology adoption. Over to the chairs.
So we have Dr. Ayush Gupta, Consultant Internal Medicine at Sarvodaya Hospital, Healthcare, We have Captain Bobby Ramesh, who's the Group Director Nursing Excellence at the Sarvodaya Healthcare. And we have Mr. Rajarajan S., the Group COO of Ashram Hospitals. Welcome.
Hello, good afternoon everyone. Thank you for attending this session. Instead of feasting your stomachs, you are feasting your brains. That is what we like. Thank you for honoring us. And this is a very interesting session because yesterday we had 45 sessions of different people coming up with their solutions, with their different problems. And we had a lot of discussion and a lot of interactive sessions because it was very well time bound. They all were very well prepared. And today we have curated the selected of them. They are not the best, we cannot say they are the most elaborative or most technology-wise very advanced, but they were the ones which we thought will be nice for us to share in the forum, and we can bring those ideas among ourselves, and so that because knowledge shares and we grow with that. So we would like to share those presentations. They have been curated by the jury and my colleagues. I'd like to thank Rajarajan sir and Captain Bobby Ramesh ma'am for helping me out in this journey. This is one of my first on this desk, on this dais. So excuse me for any mistakes if I make. And thank you for this opportunity. And I'd like to Raja sir to please start with the session and we can call the first 3 people.
So thank you all. It was such an enlightening session yesterday. As Dr. Ayush had mentioned, it was about 45 presentations we had to sit through, but it was no pain because each of it brought a different flavor, and the technology utilization in various areas. We had majorly arms as in admin excellence, business excellence, we had academic excellence, clinical excellence, nursing excellence, HR excellence. So very many different profiles presentations were seen, and one thing which stood out was that every organization today is inclined for technology, digital transformation. They are open, and some of the questions which came also kept us thinking as in, what is it, how do they select the technology, what is the cost for each of this technology, how can they take on the cost and all the stuff. So it was a very packed session. The seminar hall was always filled, and some of the jury members, we had a separate jury for the first healthcare organization innovation and a separate set of jury for the early technology adoption. But what had happened was some of our jury members stayed back for the second session as well, which shows their commitment and also the interest level and the kind of presentations we had for that day. So we would now start with calling some of our members, jury selected presentations to come up on the dais and present. So if those members are there, first I would request for the want of time to come and occupy the left flank over here. So those 9 teams have been notified. So if you can come and occupy the left flank, we could know, and we would start calling out each of you to come and do the presentation to this grand audience.
Thank you, sir. Thank you for that amazing introduction. And so before we start, I'd like to tell you that we have curated these 8-9 presentations in a sequence of how the journey happens. So the one of the first one you'll be seeing is from the HR perspective, and I'd like to invite our speaker, Miss Akansha, for the first session. Can we have a round of applause, please? She's from India. I'd like Captain Bobby to give an introduction, please.
So welcome Ms. Akansha Ticholkar, Group CNO of Medcare Hospitals, all the way from Dubai. And she would be presenting on retaining talent, restoring balance, a tech-driven nursing journey. Over to you, Ms. Akansha.
Yeah, so thank you so much, and I'm here to present
retaining talent, restoring balance, a trait-driven nursing journey. And how this nursing journey has began? This nursing journey began with one of my nurse, Yara, who was high-performing nurse, who has resigned, and when I have an interaction with her, I had sorry. Sorry, then can I continue like that? Then I can continue because with the interest of time. Yeah. With the interest of time, if I can continue without slides, I can continue without slides. So this journey began, as I said, when she has resigned, and I have an interaction with her. And it was really an eye-opener for me because see, we had a nursing attrition rate of 23%. So we were thinking we are at the best, but then when I have interacted with her, I felt there is a room where we can reduce the attrition rate of nurses because she was leaving due to the burnout. Burnout due to non-nursing core activities. Usually the issue which comes where nursing call bells, where lot of non-core activities nurses are supposed to do. There was appointment confirmation which nurses were supposed to do it. So that's again adding into their burnout, as well as there was issues like insurance follow-up and so on. So this was a burnout. Apart from that, there was like when we have straight shifts, and cyclic duty rostering, the workload is uneven distributed. So there are some days or there are some peak hours were there where the workload was very high, which was causing the stress on the nurses. Then they had a limited access for training because of the 12-hour shift. So these was the issues which, because of that, we thought let's work on it. So every year when we have a strategy meet, we think of what are the next year's strategies. So that 24-25 when we had a meeting, we thought, okay, let's concentrate on reducing nursing attrition rate from 23 to 20%. Then let's work on reducing the nurses or minimize the non-core activities, optimize nursing resources, because it's very easy that there is nurses, when you ask them, they will say it is a shortage of nurses. It's lot of time, it's not a shortage of nurses, it's how do you optimize your nursing manpower, and then enhancing access for training. So with that, what we have done we have conducted a focus group discussion of our nurses. First, we have conducted a burnout assessment test of the nurses. When we have conducted a burnout assessment test, almost 47 nurses were under burnout, whether it is a moderate and high risk. Then we thought let's have the focus group discussion to actually understand their stressors, and they also surfaced out the same issues, almost the same issues what Yara has brought to my notice. So then we thought let's work on integrating some or investigating some technology which will help us to redesign our nursing workflows, and which can help us to optimize our nursing manpower and reduce the burnout among the nurses. So what we have done as usual, project charter was formed, we had interdisciplinary team was formed where HR, IT, finance, very important, I always tell, and service excellence as well as nursing leaders. Then we had tech-enabled solutions. We thought, okay, fine, after brainstorming, we decided to have the tech-enabled solution. The first was One Touch, that is a Treatwell, from Treatwell, that is an app which helps calls or the call bells or the call lights to direct to the stakeholders. Those services like water, patient needs a water, it needs to go to the housekeeping, patient needs a food, it needs to go to the F&B. So that's way it was redirected. So that was there. Then AI powered automated call system where there was no need for nurses to do the confirmation in OPD, but this AI powered call system from Exotel was helping nurses, or they helping to have the automated calls, which has reduced significantly nursing workforce workload, as well as we have actually a very simple BI report which has taken from the system about the peak hours analysis. When we have taken our peak hours analysis, we were able to do the dynamic duty rostering, and then training accessibility for the nurses by adopting Lippincott, and one simple system for the nurses to reach out to our nursing leadership by developing the QR code, where nurses can access the QR code and they can reach out to the nursing leadership. And that has helped, all this technological adoption has helped us to reduce our nursing attrition rate from 23 to 18%. We have gained almost 4,000 of nursing efficiency hours. We have our patient satisfaction score has increased, courtesy compassion has increased to 95%, and call bell attendance response has increased to 94%, and we have got awarded as a great place to work. Our organization has got as a great place to work, and you know, every survey where we do, nurses participate more, and 87% were nurses who participated, and that's again, and apart from that, we had again an operational benefit, that is our no-shows in the OPDs have reduced from 20% to 7%. Thank you very much.
Thank you, Dr. Akasha, for your wonderful presentation. Nice to know adopting technology, you all could reduce the attrition rate, reduce the burnout, and having QR code to access nursing leadership, that's an innovative idea as well. Good to know that, and thank you so much once again for the presentation. Over to Dr. Ayush now.
Thank you, ma'am. So, we'll be bringing upon our next presenter now. Thank you. And before I bring him on, he has a very interesting insight towards his employers, and we'd like to invite him. He is Dr. Shivam from Apollo Sage, and what he's going to present is something that all new larger setups need to understand, that when you are trying to have a complete setup engaged and how you get them on single tone, he will be sharing a good light on that, and we'll be requesting you to restricting to 4 minutes, please, if possible.
Sure.
Thank you so much, sir.
Good afternoon, everyone. After a heavy lunch, so we're going to only 4 minutes talk, and thanks to this smiling gentleman who makes me alive to come all over to Bhubaneswar to present this presentation. And we are 350 bedded hospital, started 2.5 years ago with a venture with Sage Group in Apollo Hospitals. And this is one of the niche program done by our clinical directors called Dr. Anupam Siddhal and Dr. Ravni. This thing is made an Apollo Learning Together point as well. Anyway, we are just sending our medical officers and medical directors to across the Apollo group of hospitals to learn other new things. So what we did was, we made all our clinical governance committees to be met by all our clinical directors should participate in it, and learnings from this to taken to the junior levels. And what we have done is, I have called my own team, whatever the committees may be, mortality committee or Code Blue, HACC committee or MRD, whatever the committees, they will be sitting and learning with me. The new talents who was coming to us will be learning from this one, and it was very easy for us to make them learn. This is developing, again I'm saying, developing the program is always easy. How to implement these programs and how to execute the programs. Again, they came with a new answer that this is one of the KRA of our medical directors, which means we need to do it, or else our appraisal will be down. So next, these are the formats where we need to give a feedback on these things, whether it is started on time, whether it was preferring the format what it was given, all those things. And this is one of the things where we have, I have attended an Nellore unit. And this is one of the things, next thing is Lighthouse 2.0 dashboard, which deals with the mortality exclusively. I have taken only the mortality into the picture here. The mortality, the whole year of mortality comes with me. We have just analyzing the mortality things, level 1, level 2 forms. These forms which has made us to analyze what are the things to be best done, whether code blues, to reduce the code blues and other things, where we have level 1 and level 2s. This is automated Power BI dashboards. Then next thing, we will be filling this. All the deaths will be filled by medical officers and other medical officers in the first 7 days. Automatically this triggers, if it comes on the triggers, it goes to the level 2. Level 2 is carried out by myself and our team of mortality members. And this is the category, and according to the categorization we will categorize, and category 4 and 5 will be presented by our medical officer in our board, the whole Apollo boards, once in a quarter. The other things will be separately monthly reviewed by the common corporate team by the clinical directors. And
according to the next thing is again the mandatory thing in all accredited hospitals, SMR and Euro scores for all our CABG cases. We do in our HMS system, it's automatically pulled up in the Bedmatra score, and this is useful for us in risk certification as well as in the NABH portal also. And these things all led to our next technology program, which is remote monitoring, which is all infancies, life sciences, and other couple of companies were doing it. We have started an enhanced connected care, which we reduced our code blue and other things based upon this mortality analysis and other things. Thank you.
Thank you, Dr. Shivu. I think the insight that I can get from him, because as a director myself, I think that there are apps getting developed for users at the ground level, but there are not getting apps and software developed but us at the director level. And when you tell us that using this at your center, you are able to, learn and grow with it.
Yes, it lowers the administrative cost also. That's important.
But that's nice. And I think the implementation is really nice, that we are able to see the learnings, and the simplification of the tools is very nice. Thank you so much, sir. Thank you. Can we have a round of applause for him, please? Thank you. And now the next that I am going to invite is a very special place where I have in the last 2-3 years seen a lot of implementation. We see houses where generation happens of ideas, generation happens of softwares. This is one place where implementation of these ideas gets landed. So if you want any kind of testing to be done, that if it has been tested and tried, you can come to this center. That is what I have learned from this center. So inviting Miss Devi from Kaveri Hospital for the next presentation.
So Kaveri has been at the forefront of technology. We have a person who's leading that, Arvind over there. If you could just rise up so that everybody sees you once. Yeah. Mr. Arvind, and flanking him is Sajid, two people who I look upon for technology. So, one of the most difficult things in hospital is financial reconciliation. Do you all like to check your wallet and see money missing out of it? Does anybody like it? No. So this was one of the presentations where they were talking about fintech space in healthcare. And it's a wonderful thing, and I'm sure you could connect with them to understand how you could all implement. The reconciliation time is phenomenally reduced. And thank you, madam. We're pleased to have you present this for us. Thank you.
Good afternoon to all. I am Devi. We are representing a Kaveri group of hospitals. Today, we are excited to present our innovation, the automated card and UPI verification system, a digital solution that ensures faster, accurate and error-free financial reconciliation. First of all, let me explain our problem we face. Our finance team had to manually check and match the hundreds of transactions every day. This includes card and UPI payment made by the patient during patient advance, discharge, lab investigation, scan, X-ray, etc. In these payments, we had to check here data from various platforms such as HMS portal, Merchant portal, finally SAP. HMS for our hospital management system is a base document, then Merchant portal to match the HMS for bank reconciliation, finally SAP to match the HMS for our financial reconciliation. Each hospital handle around 200 to 300 line items every day. With 12 operational units, our team has to verify thousands of transactions every day. It took approximately 3 hours per day per unit per person. Because of this high volume of transaction manual checking, our staff has to work extra hours for during audit, financial closing, etc., which caused stress, human error, delay in reconciliation and time consuming. After implementing RPA, which is robotic process automation, we can able to validate data at the time and share our report automatically in our mind. The impact of this RPA, we can able to reduce our daily verification time 3 hours to just 30 minutes, which is 80% improvement in efficiency, accuracy and reliability. Then coming to techno of RPA. figure, the bot automatically returns the transaction report with merchant portal without any human intervention. Reconciliation, it reconciles 200 to 300 daily transaction line by line without any human effect with zero effect. Consolidated report, bot generate a consolidated verification summary, report in Excel within a minute, then team review the bot generated report for accuracy, compliance and record validation. Finally, the report is ready for a finance governance. Then coming to finance governance and operational impact. After implementing RPA, it's not only improved our daily work, it's also made our finance system stronger. It's a better accuracy, reduction of manual work, and clear and transparent process across all units. Then coming to impact, since the first unit was successful implementation, after we had to able to move on 5 more additional hospital units based on our CFO feedback to the next phase of implementation, which is consistent and uniform reconciliation process across all units, improved efficiency, accuracy and transparency, reduced manual workload and turnaround time. This is the final evidence of the RPA. This is the evidence to share our report automatically in our mail-in transaction. This is not a standard report, it's a customized report. Thank you.
Thank you very much, madam. The applause says it all. Thank you.
Thank you, ma'am. Now I'd like Captain Bobby, ma'am.
May I now call upon Mr. Hassan from New Mausat Hospital, all the way from Kuwait, who would be presenting on application development for doctor's scorecard, supporting ongoing professional practice evaluation. As you all know, that OPP or ongoing professional practice evaluation is very important exercise in accredited hospitals, and the hospital has developed a software, or they have adopted an application development which makes the life easier for the medical services and also of the HR. So over to Mr. Hassan from New Mausat Hospital, please.
Yeah, so the New Mausat Hospital is from Kuwait. We have the representation of Mr. Vivek, the Chief Operating Officer of New Mausat. They are connecting the team members from Kuwait for this presentation. The thing is, New Mausat Hospital is the first private hospital in Kuwait, and there are about 19 private hospitals only in Kuwait, but then the healthcare is very good and well established. They are one of the few hospitals which is both accredited with JCI and also with the Canadian accreditation. And OPP, as we all know, is something which is mandatory for JCI. So they have brought in a process and phenomenon to do it. I think maybe able to connect to the team. Do we have Asit online?
Yes. Good day, everyone. Thank you. I am Mohammed Hassan, Head of Patient Safety from New Mausat Hospital, Kuwait. Thank you, Kaho, for giving us this opportunity to present our improvement project. And this is just our layout of our hospital, private hospital, 60 years ago it was established. And as you mentioned, Doctor, it has dual accreditation from JCI as well as Canadian accreditation. Going to our challenge or problem statement, our data collection was for OBBE system was very inconsistent, paper-based and manual, which resulted in very delayed timeliness for data collection by 40%. This reflects for affecting timely identification of performance concerns and also compromise the patient safety and quality care that we are providing. So the direction and approach was to develop a digital OBBE system that is transparent for everyone, supports data-driven decision making, and strengthening our compliance regarding MOH in Kuwait and JCI as well as ACI. So our SMART goal was designed as specific, measurable, achievable, relevant, and time-bound to be finalized and achieved within 3 months. And our quality methodologies that we used: plan, do, check, act. As you know, in plan phase, we are gathering all our requirements and formulating our problem statement. Also, we gathered a multidisciplinary project charter from HR, IT, information technology, quality, medical director office, and the clinical departments. Building capacity was done, and identification for our KPIs, what we should gather either to be hospital-wide, like utilization KPIs, and in same time, some KPIs should reflect the specialty specific, as I will show later. In Do, we are doing our pilot testing, and we are doing automation for some clinical departments. Check that we monitor what are the results for our pilot testing, and act to standardize, built in our data collection to be automated and digital, to have real-time access to our clinical performance. What is the outcome and achievements have we achieved? We fulfilled 100% on-time OBBE evaluation, with 80% less for the workload for the data entry process owners, and physician engagement for the tool was 95% with satisfaction, due to the transparency and promptness of the tool. In the same time, we have identified performance concerns regarding our physicians, and in the same time, we strengthened our accountability and the clinical governance processes. I'll show some examples. This was a baseline in 2023 before we start our improvement project. As you see here, data collection type, it was mainly manual data collection, which has many flaws and typo errors from data entry and very delayed data entry. Also, we have from some monthly reports, some annual reports, which reflects inconsistency and not a standardized process. What is the outcome now in 2025? Automated and digital that reflects utilization KPIs for the clinicians, and in the same time also we used, as I mentioned, some clinical quality measures, which is specialty specific. Like, for example, if surgery, it will be surgical site infection readmissions for all our physicians. 3 columns here, the score for benchmark departmental, to have benchmarking between peers, and doctor scores, which is updated timely. You are welcome. Benchmark. Thank you.
You can just show the last slide and we can expand.
Okay, thank you.
Yeah, so we are extremely happy that there is a possibility that our Caho is going to host a program together with New Moassat in Kuwait in the year 2026. Thank you to the New Moassat team for that. We are really looking forward to that.
Thank you.
Good to know that, Mr. Hassan, that with your application development, you could not only the compliance you have improved, but also accountability among the physicians. Otherwise, normally very few departments take the accountability. With this enhancement of accountability as well as the compliance rates, and also you could improve the KPI for the clinicians as well. Thank you so much. Over to Dr.
You're
Ayush
welcome.
for announcing the next speaker.
So the next speaker is among the most sought after person for the solution he has brought into the place. Most of the operations and billing people are thankful to him. So I'll not cut short. I'll invite the founder and CEO of Priority Technologies, Mr. Surjit Thakur, sir. Can we have a round of applause for him, please? He's going to present on the topic of real-time discharge tracker from Rajagiri Healthcare and Education Trust, Kochi. Thank you.
Thank you, Dr. Ayush and Caho, for having me here. Can you have the presentation, please? So I'm also CIO for Rajagiri Hospital, and there we have implemented these solutions. Apart from Rajagiri, the solution is at multiple places. But what we have trying to do here is trying to solve a perennial problem that all hospitals face is discharge delays. What we have done, again, we are talking about the challenges is lack of visibility of discharge status. No one knows. My father was in ICU during this Diwali. And to be honest, the only person that, even when the doctor came on round and said in the morning that you can get him discharged, we used to bug only the nurses because they were the closest. So the challenge was unpredictable discharge times, bottleneck due to last minute billing and all, delayed bed turnover impacting admissions. And for a busy hospital at Rajagiri, at times, because the discharge delay, the patient who's supposed to be admitted gets admitted in the afternoon. So all those, and plus, all hospitals will have TAT, they'll go back and do some post-facto analysis of where the delay was. But what we have tried to do is a real-time analysis. Doing this because there are multiple players, the real challenge is there is absolutely no accountability of who's owning it. And this leads to revenue loss, patient experience, and of course the NPS. What we have done is we have married three people, people, process and technology, people because we have made every individual department accountable. And one, by making accountable, by giving the data on a real-time basis as to what is happening on that. And then the departmental coordination between the various, whether it's between OT or lab or blood bank or pharmacy or nursing, that is seamless. Process-wise, each department knows exactly that they have to give the clearance in X time. And plus, to put more pressure on the people, we have give a public display of this so that patients also know as to what is where it is stuck. That puts the pressure on the department to adhere to the timeline. Technology, because we're just building a tool. So this is the photograph where actually the real-time discharge tracker has been put in the ward for display, which sort of puts, this is the one example of it. Because of this, now the pressure is also on the clinicians because they have started planning the discharge one day in advance. Because they know that now the patients will come back and say that the discharge is because of you, I know. You can also set up a time of, this is the actual patient in terms of discharge summary, nursing clearance, pharmacy clearance, where is it, the different colors signify whether you are overly delayed or you are within the timeline. You can set up a different timeline for cash and credit. What falls between green or amber or red, that can, it's a configuration that can be done. And each of the respective wards, there is a display there that they run only for that specific, that gives them a real-time display, and their KRA is not to ensure that everything happens in green, nothing goes to even amber, forget about red. This tracks on a real-time basis that if this is an aberration or this happens every time in this ward. Or with this doctor, or maybe for pharmacy. So all of that can be addressed here. The best thing about this is that this increases the patient satisfaction. This is measured in our hospital, and it has improved the patient discharge, post-discharge satisfaction levels by almost 20%. Thank you very much.
Thank you, Sujit sir, for being the prescription medicine for every hospital's headache. And the next participant will be from St. Peter's Medical College Hospital and Research Institute in partnership with Medicine VR. They come from a beautiful clean city of Hosur, just on the outskirts of the technology hub, one of the technology hub of India, Bangalore. They are here to show us how virtual reality is taking over and dethroning the regular ways of medical training, and it's going to be an interesting one. Thank you.
Good afternoon, everyone. It's an honor to be on this platform today. I'm Dr. Chaitanya, and I have with me Dr. Dilip. We're representing St. Peter's Medical College. So in healthcare, quality care and patient safety is at the heart of everything we do. And to achieve that, we need to empower healthcare professionals with better skilling opportunities. because traditional training methods are effective, but they are still constrained by, say, patient safety risks or lack of inadequate hands-on practice or high resource demands. So our core problem was clear. How can we train our students safely, effectively, at scale without relying heavily on physical resources? And that's why Virtual Reality Based Simulation Lab. Set it up in 2023, and currently it supports the training of about 750 students. That's both medical and nursing students. And what it offers is virtual reality based skill training, where students can practice those skills any number of times till each one gains measurable competency. So here's a small video about the software. Sorry for that delay, but okay. So the skills, as you can see, your typical skills like say catheterization or more, they're all present in the form of virtual reality. Now those are present in two modes, that's called guided and evaluation. So with guided mode, what happens is that, yeah. So this is where, this is how the lab looks like. And each student is given their own login with which they can access those skills that are present virtually. And like I said, they are present in two modes. That's guided mode and evaluation mode. And guided mode is where the students are given step-by-step instructions on how to perform that procedure, along with some theoretical knowledge about, like say, the equipment or about the instrument that they use, or in this case, it is the interpretation of ACG. Once they are done with this guided mode, they go on to the evaluation mode, where they will independently practice these skills, and they get their performance analytics by the end of it. So what happens is that by the end of this independent performance, they get scores like, they get to know where they have missed out, what are their areas of strength and weakness, and that is also reflected on a user and an institution dashboard that supports the competency assessment of every individual student. So we conducted a pre and a post-intervention study to actually measure the impact, and the results are interesting. We saw that the procedural knowledge scores went up from 61% to 78%, and the procedural skills improved from 49% to 82%. Most importantly, the error rates reduced from almost 51% to 18%. What's most interesting about this innovation is that it is totally scalable and replicable. So what happens is that the technology in itself is scalable because you can create from 60 skills, you can create 100 skills tomorrow. And each of these labs can be leveraged as center of excellence where the training can reach 1 lakh healthcare professionals in that particular geography across various disciplines. And such a similar thing, you see that it is implemented in like 15 institutions across India, and currently it supports the training of 9,000 students virtually. So it's also scalable, it's also sustainable, both educationally and operationally. And most interesting aspect would be the integration with mannequins, where it will finally combine the benefits of both modes of training. And that's why is not just the future anymore, it is the present in upskilling our healthcare professionals. Thank you, everyone.
Thank Dr. Chaitanya and Dr. Dilip for the amazing presentation. I'd like to share a little anecdote. It was exactly 10 years ago. I was in Pune at my medical college, and there this Google box had come, VR box. I don't know how many of you must have remember. It was just a simple box with 2 very simple lenses, and there was nothing in it. And I asked one of my colleagues to just close his eyes. I put a set on him and asked him to open his eyes. When he opened his eyes, he said, where he was, he felt out of place. And then I told them that this technology will be changing the whole healthcare technology, and today what they have done is one of the best examples that we can see today, that all the medical doctors will not be needing any kind of
live patient to test or experiment or upgrade or practice their skills. With these skills, with their basics, with their knowledge and their hands-eye coordination practice, it will be a very nice asset. Thank you so much for the presentation. Thank you. Over to Dr.
Thank you, Dr. Ayush. The next presentation is by the Astor Whitefield team. As my co-jury members, the chair, have already mentioned at the beginning of the session that there are so many presentations, and we are very happy to see this time that there were many doctors, clinicians who participated. So one of the presentation is on surface guided radiation therapy by the Astor Whitefield team. Over to you.
Thank you, ma'am. Firstly, thank you to Cahotech, the jury members as well as the chairpersons. I'm going to be just presenting a very treatment-oriented innovation, surface-guided radiotherapy. What is the issue we have? We have patients who have to be treated for 6 weeks, every day, 20 minutes a day, and because we are working on sub-millimeter accuracy, we need the patients to be immobilized and to make sure that they are in the same position every day. Now, for that, we use conventional X-rays as well as CBCTs usually. Over the last 2 decades, we have been doing that. A lot of radiation exposure to such patients. Even then, we do not know if the patients are moving during treatment. So basically, we don't have a real-time positioning accuracy during radiotherapy treatment. And this is where it becomes important for us during the treatment as well as on a daily basis during the 6 weeks. So the objectives were, the SGRT allows us to meticulously monitor the patient surface, both during setup and treatment. It gives accuracy, patient safety, and boosts the comfort. It uses mainly something known as structured light onto the patient's body, and it has around 2.6 million nodal points, because of which we are able to match the patient's body exactly to the same thing every day. And it is an advanced system. It has 3 camera units and it reduces the positioning errors. So I'll just go to the 2 videos. The video running at the bottom, you can see with the patient taking a deep breath, the room lights up to green, so they know exactly where to stop hold their breath and keep that going so that treatment can be delivered at that time. The image on the upper right, the patient's arm has been moved, and that's why you see the red mark there, and once it is corrected, it becomes green again. So it helps the person setting up the treatment to immediately do it. It is non-invasive, time efficient, the radiation exposure is not there, there's elimination of other required immobilization methods, and it supports breath hold techniques. Now we have used smart methods. The specific goal was to do real-time positioning accuracy. The measurable progress was daily setup, verified and double-checked with our CBCT method. Achievable clinical flow target was to accomplish the first to all breast cancer patients within the 3 months, then all cancers by 6 months. Relevant outcomes were to achieve accuracy of daily positioning and follow it with reproducing the same over the entire therapy period. And time needed, within a year, we were able to convert from the conventional treatment methods to cut down the turnaround time. What were the outcomes achieved across board? You can see patient-related outcomes significantly reduced the discomfort, achieve participation of patients in their own treatment, and tattoo-less. So we used to use pin-prick method, tattoo methods, which have been reduced. For doctors, it is accurate treatment delivery. We are confident with our treatment. Real-time monitoring is possible, so we know patient is moving, confident in delivering even unusual non-coplanar treatments. And for hospital, the cost reduction because of reduction of immobilization methods, more patients can be treated, and for the environment, because plastic is reduced, we are able to reduce the environmental impact. There's a collaboration required, lots of physicians, physicists, technologists, and the patient. And for this, we use a lot of interdisciplinary methods to align these goals and resolve it. And each member brought in their own expertise into the workflow. And additionally, we collaborated with the external stakeholders to make sure that our technical support is allowed. The challenges was that it was a pioneering project integrating SGRT with existing systems, and we faced hurdles for the staff and patient initially. Adaptability was key, the feedback, and we developed tailored patient education strategies. With these efforts, we were able to treat both the staff as well as the patients with SGRT confidently. And with the Astor core values, we were able to get through and make sure that this advanced technology is provided to all our patients. Thank you.
Thank you. Give it up for Team Astor Whitefield.
Thank you.
Thank you, sir. Thank you for having me.
The next presentation would be by Charanok Hospitals Private Limited, Kolkata, would be presenting on AI-enabled IBUS guided PTCA.
And thank you, Dr. Vipul Roy, sir. Thank you, sir, for the presentation. My topic is AI-enabled IBUS on the IBUS guided PTCA. So conventional angiography actually not very competent to detect the plaque or the plaque burden assessment and the stent assessment. So that's why the patient come back within a very small span of time, even within 1 year or etc. But our goal is simple, to show how the IBUS improve the accuracy and safety of the PTCA procedures. The key takeaways are the IBUS enhanced decision making, optimizing the stent presentation placement, and improve the outcomes. So our vision is simple. It is a position of the IBUS guided PTCA to claim in each of the complex interventions. So now the problem comes where the concern. The actual concern is simple. That is the underestimation of the lesion severity, inadequate stents expansion, and the higher restenosis risk. So why the IBUS is required to be AI enabled? Actually, AI enabled IBUS enable us to see high quality enhanced picture that mainly focus on the area of interest, which is more precise, and the automated lumen assessment and the lesion assessment is there. That's why our problem is solves too much. And regarding the artifact, it is also just reduces the artifact. That's why enable us for the precision stent placement. It is the example of that IBUS enabled with the AI, that we precisely see where the lesion is and what is the position of the stent and what should be the size of the stent. So that's why the critical cases is done along with the IBUS, that is enabled with the AI. That is the simple, we have the 4 cases, there are complicated cases, but still patient do not come within the 5 years. And that's, we increase our last 3 months stat, we gradually increase our total number of cases that is enabled with the AI. And that is the conclusion for my side, that each and every patient should have the IBUS guided PCI, that is AI enabled, that improves the outcome. Thank you.
So the last of this series would be, this hospital is from Royal Care Super Specialty Hospital, Coimbatore. They have literally all the accreditations that could be there. And we invite Dr. Sendil Kumar to come up and present what they have done novelly, combining magnetic resonance with some focus ultrasound. We also have the team, Dr. Manohar and Mr. Srinivas, along. So, wonderful team. They have done something so innovative, which is the first time in India. And over to you. I'm not going to spill the beans. They will spill.
Good afternoon. Warm greetings from Royal Care Super Specialty Hospital, Coimbatore. I'm Dr. Manohar, the President, Medical Affairs. I am Mr. Srinivas, the Vice President, and Dr. Sendil, Consultant Radiologist, and a key member of the MRG FES team. We are very happy and proud to say that we are the first hospital in India, Southeast Asia, Middle East and MENA region to introduce this MRG FES treatment technique for the treatment of Parkinson's and essential tremors. And we have successfully treated more than 200 patients as of date. Without wasting time, I hand over the mic to Dr. Sendil, who is a key member of the MRG FES team.
Thank you, Manohar sir. Thank you, jury members and Cahotech team for the opportunity. Magnetic resonance guided focused ultrasound is a non-invasive treatment option for patients with essential tremors and Parkinson's disease who haven't responded to medication or are not willing to have an invasive surgery. The procedure uses focused beams of ultrasonic energy guided by real-time MR to target areas deep within the brain with no anesthesia, no incisions, no radiation or permanent implants. And this chairman, Dr. K. Madheshwaran, a practicing neurosurgeon who saw the system in Japan in 2020, and he felt that this will be the future of neurosurgery in treating movement disorders. And this is our team of neurologists and neurosurgeons. We launched the system in 2022 for the very first time in the Indian subcontinent for treating essential tremors and Parkinson's disease. And it is a single session, incisionless transcranial ablation in the region of interest, delivering ultrasound waves. The targets includes ventralis intermedius nucleus in thalamus for treating tremors, and the other target is paradothalamic tract, which is for treating bradykinesia and rigidity. We use a 3 Tesla research capable GE Signa Architect 128 channel system along with the Insightech Exablade Neuro. The patient will be awake during the entire procedure. Initial temporary sonications are done as a dose sonication to evaluate on-table evaluation, and followed by sonications with mean temperature more than 50 degrees to produce a permanent lesioning. And the treatment process includes patient preparation, planning, target verification, treatment and assessment. This is how the system looks when integrated with the 3 Tesla MR, and you can see a helmet-shaped transducer mounted on the couch, which has a 1024 piezo electric elements, phased array coils, which operates at a frequency of 650 kilohertz. And with advanced focusing algorithms, we'll be able to pinpoint the location at the target areas in the precision layer of 2 to 5 mm. And pre-procedure planning, we do a baseline CT and an MR to create the skull density ratios and the target markings in the MR. Skull is an important barrier for ultrasound traversing into the brain, and this is how the patient is prepared and placed over the MR, and he has to wait there for another 2.5 to 3 hours. And this skull density ratio has a range of 0.4 to 0.7. Our Indian population has what we discovered as 0.56, which is a very optimal level for giving the procedure and treatment. And you can see this 48-year-old gentleman from Dubai. He has tremor-dominant Parkinson's disease with severe drug-induced dyskinesias. The second, and you can see the tremors in the hand as well as the jaw tremors. The third video, please. And immediately after the procedure, at the same night, he started having his own food with his own hands. The fourth slide. And the very next day, he was jogging along the corridors of our hospital. The next slide, please. This is the first ever patient we treated on 8/8/2022, and he started writing just immediately after the procedure, and you can see the pre and post procedure writings. In conclusion, so far we have completed around 207 treatments at Royal Care. 20% were ET and 80% were PD. We have a follow-up of 3 to 36 months. There are no major complications. Minor complications like transient ataxia, dysarthria, weakness, somnolence and headache are there, which gets resolved by 2 weeks to 2 months time frame. It's a very effective and safe procedure. The future is more than movement disorders. Already obsessive compulsive disorder for there has been an approval, and we have done India's first case for OCD, and another more blood-brain breakage for treating tumors is also on the trial stage. And this is our team. Thank you so much for the patient listening.
Thank you very much, team from Royal Care, Coimbatore. So we now invite our jury members who have been patient through the day. Yesterday, sat through 45 presentations, and also earlier we had more than 120 plus applications. So we had to filter through and identify those 50 presentations, out of which 45 were presented yesterday. So may I request all the jury members who were there with us for the healthcare innovation.
So may I call upon by their names so that they know that they are around. Dr. Rajni Ashok, Ms. Soma Chakrabarti, Dr. Parthasarathi Mukherjee, Mr. Devanand, Dr. Jyoti Clara, Mr. Saji Matthew.
I request the jury members
to... Dr. Vijay Agarwal sir, Naren Sehgal sir, please.
Dr. Vijaya Lakshmi, Dr. Priyanka Bahal, Mr. Subodh Singh, Ms. Ananya Mitra, Dr. Mahalingam Venkateshan, Dr. Sumit Kumar Khan, Dr. Ranjan Mohapatra, Dr. Smita Padi, Dr. Suchandra Gatre, Mr. Sandeepan Karmarkar, Dr. Deepak Mitra, Dr. Santosh Dora, Dr. Anupam Das. May I request you all to please kindly come on the stage for a photo session. If I'm missing any of the jury members, my apologies, but I would request you to please come on the stage. So a big round of applause for our jury members. They have removed time from their precious work and they have been doing this for the last almost 2 months. A lot of people were involved into identifying the best of the innovations, and finally yesterday we had it, and congratulations to all the winners who are going to be announced.
So thank you very much. I want to take this opportunity to thank Dr. Ayush, Dr. Rahul Deshmukh, Rajaraj and Bobby Ramesh. May I request the four of them to please be in front of the Cahotech 2025. Ladies and gentlemen, let's give them a big round of applause. A very strenuous exercise and they did it in style. Last 2 months they've been working very hard. Big round of applause to them, please. Thank you.
So thanks for the cooperation to all the chairperson and of course the delegates, the speakers. We are almost now, we have taken care of the time that the backlog was, and now let's start with our session 6. Dr. Deval, do you remember the one most frequently used word in central part of India, central and western part of India? Especially in the healthcare setup, yes?
Yeah, it's jugaad.
Yes. So, how many of you all know the word jugaad? तो जुगाड़ क्या बिगाड़ सकता है? So, let's not talk about jugaad because jugaad is only a temporary thing. Let's talk about something which is going to be permanent, which is going to help you with improving quality in healthcare. And the session 6 is all about it.
Yeah, so the transformation strategies for to unlock opportunities in tier 2 and 3 cities. So when yesterday also when the discussion came on technology, a lot of people were asking, all this technology you can talk about, but what is the cost impact of that? You know, whether it's costly, whether all the hospitals can adopt that. So that's exactly what the experts are going to discuss now. Very interesting session. Will be chaired by Dr. Naren Sehgal ji, Medical Director, Sehgal Neo Hospital, New Delhi, and one of the doyens of Caho, Dr. Babu Narayanan, the dynamic leader from Chennai. Dr. Babu, yes, he is the Chief Business Officer and Head Quality and Consultant Physician, GEM Hospital, Chennai. He'll also be introducing the CHO concept making an impact. And speakers.
We have Mr. Aravind Ganesan, the Chief Technology Officer of Kaveri Hospital, talking on choosing technology wisely, what works and what doesn't for small hospital. Then we have Mr. Gerald Chaideep, who's the CEO of Medversity, with the topic, changing the mindset, building a culture that welcomes technology in small hospitals. Panaban, welcome sir.
He's the founder and CEO of 10X
Technologies Private Limited. Technology, making small hospitals efficient and profitable. And over to the chairperson.
One more speaker, Mr. Vishal Gupta, Head Healthcare Business India, Ingram Micro India Private Limited, New Delhi. He is speaking on building the digitally smart small hospital, a blueprint for the future. I'm sure that a lot of small, medium hospital representatives are here. So this is a session for you. All your questions about how to implement technology in your hospital will be answered in this panel. So please stay tuned. Over to the chairs.
It seems we have covered up a little bit of time. We are still lagging behind, though we had to have lunch in between, and some of us must have missed a few sessions. What we are going to discuss today, as has already been told, is very, very important in the sense that healthcare in India, 65% of the population is catered by small healthcare organizations. And it becomes very important that this segment, which is serving the maximum population of India, which is fragmented and needs to come up, should be supported. So our session is basically transformation strategies to unlock opportunities in Tier 2 and Tier 3 cities. We focus on small and medium hospitals, which form the backbone, as I told you. Yet these hospitals face enormous challenges. They have limited resources, manpower shortages, rising costs, and difficulty in adopting new technologies. The question before us is, how can small hospitals embrace transformation smartly, affordability, and sustainably? We have an eminent panel today. They have already been introduced to you, who will share actionable strategies for the future. Now I invite Dr. Babu. He will tell us the status and how the SHCOs can make an impact. Babu.
Good afternoon. So maybe more than 12 years into this quality and patient safety CAHO, the question before us is that yes, we have covered maybe around 15% of the top creamy layer of say tertiary center and quaternary centers group of hospitals, right? Why does the healthcare happens in India? Maybe around 65%. Why does it happen? It happens with the small healthcare organization, anywhere between 50 bed plus or minus. So the question before us, before CAHO, is that how to reach those kind of people, right? And with the kind of hospital structure what we have, the healthcare system what we have, this is the population of hospitals which is not touched by maybe NABH or otherwise any accreditation standards. So the question before CAHO, maybe last year when we were contemplating on this thing, was that what is the process we can do to touch base with them? That is one thing. Then we can travel the extra mile of reaching the practicing clinician, right? So at the end of the day, it is that quality and patient safety is not with those built up with all silos and multi-million-dollar 100 or 200 or 500 bedded facility. It is that how the quality or patient prems and prompts and clinical governance can be established in 50-bedded hospital. So for that, whatever the digitalization or technology, what we are bringing in, it should be accessible and affordable. The whole session is about how we can make this technology accessible and affordable to this SHCOs, which is anywhere between 30 to 70 bedded hospital. How can really they see value in it? So through SHCO, which is under HCO, that is Healthcare Organization, which is headed by Father Johnson, the SHCO's mission under CAHO is that to reach out to this 70,000 plus or 80,000 plus small healthcare organization. So the whole discussion will be towards it and it will be around it. Thank you. Now I invite Mr. Aravind Ganesan to deliver his talk. Thank you very much for sticking on to the time, sir. Thank you.
So we hope you will stick to time. You will get 7 minutes. The first bell will be after 6 minutes.
afternoon, everybody. As the presentation comes up, I think the context has been well set by two of our panel moderators. SHCOs form about, most of them are partially or are completely undigitized today. So while the flavor of the day is AI, the more important thing is that we have to address the backbone of our healthcare system, 80% of capacity, to basically enable them to digitize and at least start with the digitization journey before they actually evolve and climb up that Maslow's hierarchy of becoming a self-actualized AI-based system. Right? So that's what I'm going to talk about. I'm going to talk about a very basic premise or practical tips on how healthcare organizations can go about the digitization journey. So we'll get started. The topic of my talk is choosing technology wisely, ideas to make technology work for SHCOs. So typically what are the constraints that we have? So we have a resource constraint but a community-driven environment. Right? So a patient base of a small healthcare organization comes from the word of mouth. It's the reputation of the one or two proprietary doctors or a few doctors in that hospital who will drive the volume for that particular hospital. They have limited capex capability. I mean, usually not enough capex to make big investments from them. Right? And purely from a digitization perspective, they have paper-based or at best Excel-based workflows or small billing systems, etc., etc. And there's low digital literacy, high attrition, and then systems which are probably fragmented, where they have been recommended systems by somebody and they've tried to adopt them, but not really integrated with them with the existing workflow. Right? So, how do they go about it? So these are the ecosystem that we're dealing with. So how do they essentially go about digitizing? Or more importantly, why should they digitize? I mean, why should we really force them to digitize? I mean, their job is going on, they have enough patients coming in, right? One is purely from an operational efficiency perspective, right? What you cannot measure, you cannot monitor, and what you cannot monitor, you cannot improve, right? And that is the biggest case for digitization, right? So essentially, operational efficiency is the biggest advantage of digitization because you can have quick registrations, you can have the quick discharge process, and probably reduce patient wait time by 25% by simply introducing a queuing system into the hospital for the patient, right? And it need not even be digital. Right? Clinical safety, I mean, if digital prescription systems are there, then you have less prescription errors and as well as less dispensation errors if you are managing to integrate it with the pharmacy system. Right? Like regulatory compliance, I mean, even small hospitals, if they have to have some amount of insurance coverage, at least going for NABH and NABL compliance will help them. Right? And patient engagement, this is the biggest business case for anyone to get into a digitization journey. A simple SMS and a WhatsApp to a patient about following up on their particular episode of care goes a long way in building loyalty for that patient and driving that patient again to that particular hospital. So that is the reason that they should digitize. Right? So it could be every minute saved is every patient's experience that is improved in a hospital. Now typically when we talk about digitization, the old realm is how much capex do I need to make? Because all of our hospital administrators are tuned to think in terms of capex. But the good thing about digitization or digital transformation is that it is actually moving towards more OPEX-based journey purely because of capabilities like a fast network capability like fast internet, ability to move all of the software onto the cloud, and the data packs being very cheap. Right? So these are the three drivers that have made OPEX a more preferable option compared to CAPEX when someone has to adopt software. Right? So when you look at a CAPEX model, you have a high upfront investment on server and server rooms and software, electricity for that, etc., etc. And also you might require dedicated manpower to manage that. When you go to an OPEX, it's basically pay as you go, minimal hardware, you can scale as you want, and at the same time, easy entry and exit. It's basically a situationship that you can establish with the software. If and you can exit out of it if you don't like it, right? So, first tip that I'll start with is start OpEx first. I mean, it's very easy to do. Everything from HMIS, EMR, or a billing software, or a CRM is all available as a software as a subscription. So for a SHCO, it's better to start with an OpEx first, see if you like it, and then if you're scaling up, then decide to invest on CapEx for that. So, this is an important slide. I mean, if a SHCO, which is not digitized at all, if it has to start the digitization journey, it has to invest in only 4 software. One is a billing software and billing and inventory software. Second is basically a CRM software which is integrated with WhatsApp and SMS. These 4 things will essentially ensure that most of the journey is covered. The next thing is if they want to digitize their clinical journey, they can get into an EMR. But at least the administrative part, only these 4 will ensure that a small 50-bedded hospital is digitized for the start and is giving a best-in-class patient experience. And that's what we have seen in our tier 2 hospitals also. So I think that is something that I want to start with. I mean, these are 5 flows that we can start with: front office, billing, pharmacies and labs, patient engagement, and marketing. And marketing and patient engagement is all possible through a simple CRM. And, so the tip here is start with basic 2-3 workflows. Operational flows are more easy to digitize than the clinical workflows. So start with them, demonstrate success, and then scale horizontally. That is the goal. So some of the tips for identifying technology partners and tool, start with the problem, not with the product. This typically happens in a small hospital. Someone they know, a friend of theirs will recommend a software and they'll try to use the software. But is that solving a real problem for them? This needs to be evaluated first, right? And that's something that they need to be focused on, right? Pick up healthcare focused vendor. There are big brands in the market who are really selling best-in-class software, but they might not be healthcare focused. For example, if you are going to purchase an ERP solution, there are very few ERP solutions which are tuned to healthcare workload. So then you have to really just look at the healthcare focused ones. References are a good way to start, but ask for a lot of references. Most of the healthcare vendors will give you a site visit or give you a reference call. And consider local support. See if there are vendors who have actually local manpower available, use them. And data privacy and cyber security is the accountability of the hospital. I mean, if there is a data leakage, the hospital proprietor would be responsible for that, and they have to really pay attention to that. And of course, get a consulting partner. I'll just leave with the last slide here. I mean, I have a couple of slides, but I'll leave it here. So NABH has actually come up with a new program for SHCOs called Digital Mitra, right? So their purpose here is to help SHCOs adopt digital tools, right? They want to get these small SHCOs to at least a silver level of NABH digital capability. So that is one program that we can leverage. They have built a framework. They are actually interviewing consultants who can help these hospitals get on board, and they're also creating a roster of software that these hospitals can use. So this is a program that everyone, any SHCO can actually tap into and then look at it. I'll end my presentation here. Thank you.
Thank you, Arvind. First of all, for respecting time. Now that we've heard about technology, how to choose, what to choose, let's come to the next topic, training and retaining the workforce, and how training through technology can help retain employees in small hospitals. Mr. Gerald will speak on this.
Thank you, Dr. Sehgal, for the presentation. Of interest to you, if we can find that. There you go. So the reason why I wanted to share this image, you know, I consider myself that I come from a social and economic background that gives me access to some of the best quality of health and healthcare anywhere in the world I go. This is Nishka, my daughter, 6 years ago during Diwali. She was trying to calm our dog down, and she got bitten. We were at our my parents' house in Bangalore, modern city, access to high quality care. We traveled from Hyderabad, we got a treatment done, we went to the ER, got a treatment done in a decent hospital. Not a very large hospital, but a mid-sized hospital.
3 days later, we're driving back to Hyderabad. Her hand had swollen up to 3 times this size. Septic shock was about to set in, and we had to rush her to ER and go through a surgery procedure. Otherwise, she would have lost that hand. If this is what is happening in Metro India to somebody like me from the healthcare ecosystem, who has access to the best doctors, the best nurses, and we realized the biggest reason that this happened was post-animal bite hand washing technique wasn't followed. So it's a simple error that can cause a loss of a limb for a young person who can go on to contribute to society and to her family, right? So that essentially, you know, and I won't talk much about Medvacity, maybe you've heard of us, you haven't, but we essentially focus on very simple things. Can we truly make a difference to healthcare outcome because we've been able to train or enable an individual, a doctor, a nurse, or a healthcare system better? And so while that's a background about Medvacity, let me tell you about the burden of care in India, right? There are 1.4 billion Indians, right? There are 1.4 billion Indians, but there are only 1.1 million doctors. This includes all registered doctors since 1926, right? 70% of them practice in Metro India. 70% of India's population sits in Tier 2, Tier 3 and rural India. Quite often, the Indians who need quality of care don't have access to quality of care. You look at the net number of doctors we add and the net number of nurses we add. Nurses are our strongest pillar to high quality care outcomes, right? In India, we have 240 nursing seats as part of the formal education framework, but only 120,000 nurses graduate every year. 55% dropout rate in nursing education. And of course, they continue to drop off later in their career as they exit to practicing in the Middle East, in US, and UK and other regions, or for family or financial reasons, they leave nursing as a practice and go. Significant care outcome losses that we all deal with, right? So, and let me now, having planted that seed, let me walk you through a case study, right? So we worked with a hospital, a 500-bed hospital a few years ago. This hospital has a potential revenue capacity of about 550 crores annually. There are 645 nurses who work in this healthcare system, right? And therefore, the revenue potential per nurse for this hospital was close to 80 lakhs. Right? Simple math, right? The nurses are truly driving, and most hospitals look at doctors first, nurses second. So I'm changing lens here by focusing on nurses first. But potential of impact from per nurse who's practicing at a skill level, that is say a 4 or a 5, would potentially contribute to about 80 lakhs of revenue. But here's the tragedy. For this hospital, they had an annual attrition rate of 60%. They were constantly losing their best nurses, and those who were getting left behind were really the bottom of the pile, nurses who couldn't get jobs anywhere else. So they stayed back in the system, right? So just as a summary, and my apologies, the fonts are a little all over the place. Let me step back for a minute. If I were to look at the cost of attrition for this hospital annually, for a potential of 80 lakhs contribution per year per nurse, the cost of attrition was 39 crores, right? Direct revenue loss. Cost of attrition is cost of hiring that talent, replacing that talent, bringing that talent up to a skill level that they can contribute to 80 lakhs revenue contribution. And then the cost of direct revenue loss, because NPS was low, patient return rate was lower, healthcare outcomes were poorer. 18 crore direct revenue loss. That's a very significant numerical factor attached to training and retention. But quite often, most healthcare systems look at training as a good to have, but not must have. And especially for smaller healthcare systems, the criticality of training and driving clinical outcomes becomes very important. This slide, I'm going to leave it on the screen for a couple of seconds. It's a little formatting is a little bad, but apologize for that. We lost some fonts on translation. But if you see, bulk of the nurses who ended up practicing in this hospital I just talked about were in level D and level E of competency. Whereas you need your level A and level B nurses to actually drive that 80 lakh revenue per year contribution. But those are the nurses going to the Middle East, to US, to UK, or to larger healthcare groups. Most nurses want to work for a big brand because that improves their outcome to travel internationally. So in the end, the small to medium healthcare groups end up struggling to retain talent, right? Doctors will still make money in any healthcare system. But essentially the cornerstone of your healthcare system is improved care outcomes, then training becomes one of the most crucial lenses you work on. Here's a quick example of how we build frameworks by evaluating competencies, by assigning competencies at different levels, and we create a structured plan for the healthcare system to climb up. So how do you take a level E nurse all the way to level A, and how do you improve your care outcomes? We put measurable dashboards on all of that. This is, I think, my last slide. But essentially what we've observed, I'm not sure if you can read it right at the back, but what we've observed, while improved training and improved earning capacity impacts both the hospital and the nurses directly, retention actually goes up when you invest in nurses. Invest in their training, invest in their upskilling, invest in creating a career pathway for them. When you don't invest, they go out and work for somebody else and you actually have economic loss. So we, as part of Medvarsity, what we try and do is we try and measure in everything that we do, have we truly seen an improvement in patient outcomes when we work with institutions or doctors and nurses individually. This is from a March 2025 survey that we did. Quick observation, question asked us, did you see an improvement in patient outcome? 85% of them said yes. So my last, and that essentially is my presentation. Thank you Chair for inviting me today. But what I'd like to put to this group today, training has historically in most organizations, I come from a tech world, in most organizations sits in HR and the L&D department. If you move the training to a CEO and CFO's chair, the outcome will be much healthier. Thank you so much.
Thank you, Mr. Girard, for underlining the importance of training, especially with the secondary healthcare organization or 50-bedded setup. And the cost what you put was really, of course, appalling, and of course, those kind of knowledge has to be shared with the decision makers. So now going to the next topic, I invite Mr. U.K. Ananda Padmanabhan to give us some kind of cost-effective technologies so that the small healthcare organization can be efficient, effective, and profitable. Over sir.
Okay, thank you, Chair, for giving me this opportunity. And although my name is Ananda Padmanabhan and my initial starts at A, I am always the last speaker in all of them. And for the people who have attended my sessions before, I am a little notorious for talking for more than I am required to talk. So, with the permission of the Chair, so quickly what I am going to talk to you today is about frugality in technology implementation. So, what I am going to talk to you is about the operations management system. Quickly, the value propositions in a hospital is the increase in revenue, next is the reduce in cost, better compliance, and improve efficiency and enhance patient experience. These are all the value propositions in a hospital. And ultimately the objective is to ensure 30% EBITDA and more. I am very clear about it, then only the organization exists. So we have seen in the hospitals a lot of these solutions, technology solutions like hospital information system, electronic medical records, patient relationship management, human resource management, supply chain management, quality management, building management system. But one thing which we have not seen is the operations systems management, operational management system we have not seen. So what I did was, in the course of my 35 years of my work, I saw the gaps that existed in the hospital system where everything was not digitized. There were many areas where it was not digitized and which was affecting all the propositions, the value propositions. So I developed this, what do you call it as operation system management, and in that we use hyper-automation. And I use hyper-automation in the sense that this hyper-automation is not very expensive. You must understand, hyper-automation means bringing together all the technologies like low-code, no-code. How many of you have heard about low-code, no-code? Anyways, yeah. So low-code, no-code is a very inexpensive technology. The Zoho Creator is one of such technologies. Then cloud computing, Internet of Things, wireless technologies, real-time location tracking system, robotics, all that are emerging technologies which are used in small and medium-sized hospitals. And with the operations management system, we say in the operations management system is a platform where 15 modules are just ported onto this platform and built on a hyper-automation platform using technologies like IoT, AI and core, and a single sign-on facility. The nice thing about this operating system management is you have one single sign. You don't have one for ticketing system, one for real-time location system, one for energy management, so you don't have that. You have a single sign-on, all the 15 applications you have it on a platform. Enables organizations to be faster, easier, cheaper, and better. All the 4 words are worth the weight in gold. Okay, and do more with less, and objective is to have an EBITDA of 10%. So very quickly, what are all the applications in the operations management system for a small hospital? Asset management, when you say asset management, it involves cost, efficiency and compliance. And electricity, water, fuel, medical gas, waste management, cost and efficiency. And then room refrigeration equipment, temperature for NABH and all you require for operation theaters, ICUs, all that. You need to maintain, say, 19 degrees to 22 degrees or 24 degrees. You get compliance. Then ambulance and transport, so you collect money, you spend on diesel, you spend on repair. Then review of patient problem, you have patients who come, but you don't follow up for review patients. So you lose at least about 30% of the patients drop off. Then the medical equipment procedures, we use in the operation theaters and ICUs, we even use ventilators, monitors and all that. We don't charge them properly, we use some of this technology like BLE tokens and all that, and we try to find out, we charge all the equipment properly both times. Fire protection and safety, in fact yesterday they presented a paper on that. We use QR codes to ensure compliance of refilling the fire extinguishers and ensuring the fire hydrants are in place, and visitor management, portal management, queue management, parking, all these things happen in small hospitals. All these are used with very simple solutions. We do this. The another is housekeeping services. You employ about 40 to 50 people. Then you have other staffs like the nurses. You have hostels. Even if you are a small hospital, you have a small hostel. We manage that hostel in this restaurant. In every small hospital, you have a small restaurant. You again digitize that. Ticketing system. If you have a maintenance problem like water leak or maybe a housekeeping service, you have a ticketing system. Feedback system, services, cost management system, cost compliance, all these modules are sit on this platform. Asset management, I'm going to quickly run through at a breakneck speed. You have to listen to me and maybe you can take this presentation later. In the asset management system, you can do biomedical equipment, preventive maintenance, breakdown maintenance of all these, breakdown preventive maintenance can be done for all kinds of equipment, biomedical equipment, IT equipment, engineering equipment. And these are all the QR coded equipments, these are all the screens that you have. Then you also see the status there. Then utilities man, this is extremely important. Even if it's a small hospital, they spend about 50,000 or 60,000 rupees per month on electricity. Are you paying penalties? Are you paying low penalty? Are you paying maximum demand penalty? We put some small IoT device, just cost about 30 to 40,000 rupees. Then install them, get this kind of dashboards. Don't think only big chain of hospitals can get this kind of dashboard. We developed this dashboard using the Zoho Creator. Slab based, we can create that. These are all practical solutions which we are implemented again. Here, what we can do is we can also put sensors in the operation theaters. One second. Yeah, we can put sensors in the operation theaters, and we can also put and know the temperature of each of the theaters. And then ambulance transport system also we can manage putting some of the sensors. We can track the ambulances, we can know how much of diesel we have spent, how much of repairs and maintenance we have done, how many trips we have made, we can find. It may be a small hospital, but you will still spend a lot of money on transport. you are able to see how much money we have spent, how many liters of diesel we have spent, how much is the fuel expenses, and then again we can upload all the bills into the system, and we will know. Say if an auditor comes and asks, we will be able to show, and we will also know the EBITDA of this hospital. This is extremely important. You know, we are able to manage all the expenses, whether it's electricity, water, everything we are able to get and get it into our EBITDA system. When you say EBITDA system, we have 4 main expenses in the hospital. One is the manpower expense, material expense, and the maintenance expense. Manpower expense and material expense comes out of HIS. Maintenance will come out of this software, and we will be able to run EBITDA on this. Fire safety equipment, and this yesterday they also showed this in the presentation. We have a QR code. Just scan the QR code. We are able to inspect all the 40 or 50 without any paperwork at all. So you are able to also get a dashboard, how many fire hydrants have been inspected, how many fire extinguishers have been inspected. And this again, they showed it, CMC Vellore showed a beautiful presentation on this. They put BLE tags like this. You may have ventilators, monitors, infusion pumps, syringe pumps. You may have maybe wheelchairs, stretcher trolleys, and you are able to monitor them. You know how much have been used, how to charge, how many hours to charge, all that is available. You are able to know in and out on the system. And for patient monitoring, and last is even the restaurant. Even in the hospital restaurant, when you don't do manual billing, you do all digital billing, all comes into the platform. So you are able to see all this, and these are all some of the hospitals which are using. Thank you very much. With the second ring I stop, believe me. Thank you.
Thank you, Mr. Anand. Though all of us, we are becoming aware that technology is something which is inevitable and we'll have to adopt, but it is very, very important that we choose the right technology for the kind of setup that we have, and we should not be spending too much and then our plans and the plans go haywire. So now I will invite Mr. Vishal Gupta. He is the country head of Ingram Micro. To tell you a small thing, the first time when you invited me, I got an invite that micro people are inviting you. I thought it was the pharmaceutical micro. But then when I was there in the discussion, I realized the potential and what all you are doing. So I'm very sure you will guide us very well. Building the digitally smart small hospitals, a blueprint for the future. I think everybody would want to hear it.
Thank you, sir. Good afternoon, everyone. So, if you don't know me yet, I am Vishal Gupta. I have been a healthcare CIO for over 26 years of, and now I am starting something very interesting, which is a kind of a building a healthcare ecosystem. For the hospitals, specifically tier 2, tier 3 hospitals. Next. Let me skip few slides. Okay, so just to give you introduction, Ingram Micro is the largest technology distributor in the globe as well as in India. And whenever you purchase any hardware for your personal use or for your organization, ultimately it is coming from one of the technology distributor or the solution aggregator. So what we are trying to do is we are trying to add a layer of the solutions specifically for the industries like the hospitality industry, banking or the healthcare. Since I'm a healthcare, passionate person since last many years, so that's why I was appointed in the micro to build the solution. Can you go next, please? Okay, so that's what we are doing. So in India we have so many companies. We call it IT companies. We call it the IT system integrators or the IT partners. And whenever any hospitals needs any hardware, they approach to these IT companies. The IT companies typically approach to any technology distributor like Ingram, and then we ultimately deliver that hardware to the end user, which can be a hospital, medical center, diagnostic, or anything else, right? So what we are trying to do is we are enabling this partner ecosystem so that they have an understanding of the hospital as a business, right? So whenever any technology partner or any small IT players is going in India to selling any piece of hardware, PC, printer, laptop servers, or any cloud solution, then he should be able to make any difference for the digital journey of that particular hospital by selling the solution. It may be a small HIE solution, PACS solution, EMR solution, any AI-based solutions, any solution for the operational efficiencies, any solution as Arvind mentioned, for the operational efficiencies, the patient delight, clinical excellence. So this is the framework which I launched recently. And after all my 27 years of experience as a healthcare CIO of the major corporates, as an advisor of ABDM, so this is the kind of a framework specifically I launched. In this framework, if you see the core infrastructure, this is the base of a kind of essential pillars of any kind of the hospitals. This is the typically infrastructure. That infrastructure is the infrastructure as if for the servers, for the data centers and all. On top of that, there are the assets, we call it the end user devices. That is a bare minimum required for any kind of hospital. On top of that, we call it the core solution or the base solution, as Arvind also mentioned in his PPT. Base solution means like the solutions which is a small EMR system or the HIS system to manage your billing, your insurance, your patient appointment scheduling, and some sort of the clinical notes. So we call it that bare minimum system. On top of that, there are various levels of HIS applications, and based on their requirement, you can keep on adding those functionality and keep on adding those solutions, right? So with the core solution, if you are having some sort of a requirement for the digital imaging, then you can go for the PACS, that is picture carving communication system, on top of any HIS. And then if your HIS solution is not covering ERP or HRMS solution, then you need to add that as an additional layer. That is a basic framework. We call it the fundamental layers or fundamental pillars that should be available for any sort of the digital hospital. On top of that, the journey start, which we call the digitally smart hospital journey for any hospital. You know, that gives a flavor of the clinical excellence, the patient centricity application, the operational efficiency application, as you mentioned, a long list, and then the quality compliance. So these are the four essential pillars. They sits on typical of an infrastructure layer, or I should say the application layer, the core application layer, which is a HIMS enabled layer. And by having these pillars like clinical excellence, you can enable your doctors, your nurses, so that they can give a better treatment to the patients. You know, you are enabling them. If you heard of the something called the CDSS, the clinical decision support systems, there are so many systems. You know, we saw in yesterday's Pitch Fest also, the AI-enabled system helping the doctors, helping the nurses, so that they can give the better care, so that they can take the right decision on the right time. So we call it the clinical excellence system. Patient centricity system, so that whenever the patient or attendants are there in the hospitals, they are enabled, they feel happy, or whatever it can be, any audiovisual system, your QR based system, your PMS system, any system, that makes a life easy of the patient when they are in your hospitals. We call it the patient centricity application. And there is a flavor we call the operational efficiency. The operational efficiency means, as Dr. Yukian listed down, any application that is making life easy of your non-clinical staff. That can be a CSSD, your porter, your housekeeping, security, any staff, any departments of the hospitals. You are making their life happy, their life easy, so that they can function well when they are treating, when they are being the part of the hospital administration. And the lastly is the quality and compliance. Since the cybersecurity is one of the key issues, then NABH compliance, then ABDM milestones, there are so many compliance issues are coming up in India. So that layer, we call it the quality and compliance layer. There are so many solutions providers in India in each of every building blocks of these, be it RTLS, be it AIML, be it any solution which is NLP enabled solutions, your EMR adoption solutions. There are so many solutions. And within those solutions blocks, there are so many, a big list of ISVs, we call it the industry-specific vendors, the health tech vendors. So I think the selection of those ISVs is very, very essential, based on the requirement of your hospitals. And that framework, especially the small hospitals and the mid-sized hospitals should keep it in mind. And that helps, to have their journey. On top of that, what we have done is, one of the challenges which I receive from the across India, whenever, we deal with the smaller hospital or the mid-sized hospital, they have a good intention for the digital health, but they don't know how to start from where to start. What should we do my technology? Who will help me? For example, most of the time there is a doctor-driven business, right? A tier 2 hospital having 100 beds, but they don't know what should the PCs, printers, laptops, cloud-based versus non-cloud-based, what is the best HIS, what is my requirement, what should I expect from my HIS vendor or any technological tech vendors, right? If I deploy HIS, what should be the modules? So I tried to simplify that. I launched a kind of a calculator for all the hospitals in India. Soon that would be published, so that any hospital owner can use that, and and they just simply put their bed size. Let's say if I'm building a 600 or let's say 60 bed hospital, I put it 60, and then list down the complete requirement of the hardware, and with the layer of the solution. For example, HIS, what kind of modules you need to buy, what would be the time frame, what would be the approximate cost on that. So that is the kind of a. Can you go next? If that is, we have 1 minute. So that is the framework I talked about. That is for a small hospital. If there is a 100 bed, less than 100 bed, core infrastructure plus core solutions. Then there is a mid-size, which is like the core infra, core solution, some sort of a quality compliance and cyber security, the patient centricity app. And if you're a large hospital, then you need to take care of all the digital framework which is applicable for the healthcare, be it core infra, core solution, quality compliance solution, operations, patient centricity, and clinical excellence. Thank you with that.
Wonderful, Vishal. Now that we have heard diverse perspectives, from choosing the right technology to building the right culture and ensuring cost effectiveness, let's now bring these together and explore how transformation can be accelerated in small hospitals practically. We have about 10 minutes left, 20 minutes actually, but we are cutting it down to 50 minutes to save more time. So we will have a round of questions, probably maybe one question would be possible, maybe two, let's see. So the first question is common to all. I would like all of you to speak one by one. If you had to pick one transformation lever for small hospitals that gives the fastest impact, what would it be? Digitalization, process redesign, or skill building? I repeat, digitalization, process redesign, or skill building? We can start with you, Jared.
That's a tough question for me to answer since I am in the skilling space, but let me try and combine both of those. One of our biggest discovery in understanding the hospital system was that the biggest source of knowledge comes from within the hospital where the transformation needs to happen. But quite often what happens is historical knowledge being generated in that hospital or healthcare system daily, weekly, monthly is lost. And every time when you come across a complex problem or a new kind of challenge, you try and bring resources from outside. If digitalization can help build retained knowledge that can go into training more effectively, I think that's the best investment in technology.
Yeah, I would put digitalization on the top, because once you digitalize, then you can do process mining. Once you digitize, the process mining is possible, and once you do process mining, you will be able to do simplification, and then the process becomes simpler through digitization. And once you simplify, systematize, and digitize, then skilling becomes easy. So if you have a very complex situation, how do you skill it? So I think that digitization is the foundation, and after digitization, you should also go to automation.
Do digitalization and the process mapping and skill enhancement goes hand in hand. Like I would say that digitalization is, that is a superset of this.
So sir, I see this as a continuum. You start with digitalization, then you do capacity building or skill building, because that is what will keep the digitalization sustainable. The problem with digitalization is not the first step. The problem is to do it again and again. Once you do the capacity building, the organization itself goes into a process redesign mode. So that is, I think it's continuum. The first step is digitalization starting.
So I think most of them have voted for digitalization as one of the most efficient thing among the three.
A small comment by me. I think I did ask tell only one, but if you look into it, I think all three of them are required. Because once you start digitalization, you will also require skill, and you will also require change of mindset and redesign. All of them are actually necessary. Maybe you can say you start with one and then second and third, depending on what the circumstances are.
So, the small healthcare organization, they have their own challenges. Maybe, Arvind, you had a very good journey. I mean, like maybe in retail
tier 2 or tier 3 cities. And what do you think is that, I mean, like the small healthcare organization, 50-bedded hospitals, that tech traps that they have to avoid during that digital journey?
Susan, so we have a Kaveri as a group, it's actually 3 different markets. We have a very tech-savvy market, which is Bangalore. We have a mix of human interface with tech-savvy market, which is probably in Chennai. And then we have a tier 2 market, which is in Trichy, Salem, Sultan, tier 2 and tier 3. So the key challenge in our hospital has been how to really build a product which works in all 3 markets. And what we have realized to most of our failures is that not one product does not work in all markets. That's what it is. So if you build an app, it will probably work in Chennai and a Bangalore, but no user in Trichy or Salem will actually download an app. Right? So with tier 2 and tier 3 and small organization, you have to basically start with simple steps. It has to be techno-human interaction. It cannot be completely technological. You cannot basically expect the user to be completely tech-driven. Then it's a cultural thing. It's at least, probably it's a Tamil Nadu thing, but I don't know. But it's more of a cultural thing that needs to be human interface. Second thing is, go for the buzz. Don't go for the best product. Go for the product that works for you. Start simple, and that will be the mind buzz for that.
It's a most practical, I think, decision from an SSCO level. So coming to Mr. Jirang, I mean, like when we try to, of course, try to acquire knowledge or whatever maybe the skill. Now, acquiring that knowledge and skill becomes a little bit of costly effort, right? I mean, even for maybe a chairman in the city or even for a doctor, it happens to be a costly one. But what we are trying to look into is that knowledge acquisition at tier 2 and tier 3 cities. So, what do you think that, I mean, those healthcare personnel, how can they acquire knowledge, do it digitally, and is it possible, cost effective, or affordable?
Dr. Babu, it's a very critical question you asked me. Today, I mean, just a shameless plug about Medvarsity. Today we've got learners coming from 1,136 towns and villages across India. So yes, doctors and nurses across India are interested in investing in upskilling. And here's the dichotomy of what I deal with. I have zero interest from healthcare systems in India asking to invest in their nurses or doctors. So here's an interesting ecosystem. The consumers, the doctors and nurses individually are interested in upskilling themselves, but no healthcare system is actually interested. If we can solve that problem, if we can build accountability, responsibility for healthcare systems to train and enable, the impact will be far.
I think that's well said, because when we look into the system, except for highly evolved system, it doesn't mean that it is like say 300 or 400 bedded multi-specialty hospitals. It is like evolved system which is academically oriented. They have a very good training programs, and they think that investing in training and skill building for their staff is very important, but it doesn't happen everywhere. I think that is a kind of space where every hospital owner has to look into that. At least I can, maybe 500 bucks I can spend for training to start with, simply. I think that's a very good concept you brought in. And coming to Mr. Anand, see, if at all I wanted to take some technology or something like that, what do you think would be the low cost by high impact? I think you have narrated a lot of things, but lowest cost and highest impact.
Lowest cost is, I would say, adopt the low-code, no-code technology for building small applications. Then use IoTs, Internet of Things, for managing electricity, water, and all that. And then use concepts like ABC analysis for managing materials. And then maybe have a lot of dashboards in different applications. Whether it is transporting a patient or transporting patients inside a hospital or outside a hospital, I think it's very, very important to have clear dashboards so that you don't keep on following up manually.
Of course, in your presentation also you have highlighted that those kind of things are not, it is not like, not within the reach of SHO, it is within the reach of SHO.
For your information, if you want to build a low-code, no-code application, if it costs by pro code, we call it the hardcore. If it costs about, say, 1 lakh of rupees, this will hardly cost you 10,000 rupees. So that is the beauty of this low code, no code. And another comparison is if you have a building management system which costs about 5 lakhs or 10 lakhs, if you use an IoT, it will hardly cost you about 50,000 or 60,000.
So there is a kind of very good pitch what you are making, that it is very, actually it is no cost, maybe we can say. So coming to Mr. Vishal, we are saying that whenever we put this kind of, whether you wanted to store your data in your cloud or otherwise in your premises, even the bigger hospitals are taken aback by the kind of cost or whatever the thing which is involved in it, right? Building that storage facility or like that. How can we think of this, making this a cloud, AI or remote monitoring, a kind of scale down? You're not thinking about scaling up, scale down, so that a 50-bedded hospital can buy it. Think about buying it, at least dream about buying it.
First of all, the health tech is not that complex as we think. Specifically, the tier 2, tier 3 cities. There are so many solutions available in the SaaS mode, right? They are the cheaper solutions, and they give, the immediate ROI to the smaller hospitals in terms of the clinical excellence, operational efficiency. There are so many, smart solutions. We just, the smaller hospitals, they just need to find out two solutions and they need to start deploying. And they give a good flexibility of hosting data, on the clouds as well as on your on-prem. I think those flexibilities are there. So they are kind of meeting all the concerns which are typically having in terms of the data security and data privacy of the hospitals.
Thank you, Vishal. I think wonderful learnings. I am sure the audience would definitely go back motivated, especially these small healthcare organizations, that they have to adopt new technologies and adopt it intelligently. In the end, what I can say is the future of India's healthcare transformation will be written not in metros, but the towns where patients seek access, affordability, and assurance. Let's make that transformation happen, maybe one innovation at a time. Thank you so much. It was wonderful having you all, and thank you so much for sparing time and coming for this panel discussion. And thank you very much, Kit, because I think this is one of the most wonderful places which I have visited, and the magnitude really has impressed me very much. Thank you so much.
May I request upon the esteemed panelists to please stay back for a photo session. Please come forward. Thank you. So our next session talks about meeting patients where they are best served. Dave, is it about the reception or the mortuary that we are talking?
Definitely not the mortuary. We are all here to save the patients and make a difference to their lives. So obviously, I think majority will not agree. But yeah, unfortunately, some of them go to mortuary. That's what the statistics show. 1 in 10 patients are harmed due to the medication errors. So yeah, this is the role of technology in care continuum. So that's a topic which we are going to discuss. And we have two fantastic chairpersons for the session, Dr. Rahul Deshmukh, Medical Director and HOD Anesthesiology, Medcare Orthopedics and Spine Hospital, Dubai, and Dr. Vishal Goel, Group CEO, ILS Hospitals, GPD Healthcare Limited. Can we have the chairpersons here? Yeah.
And we have the speakers for the day, the dynamic Dr. Manish Kohli, the founder and president of Full Alliance for Digital Health and Equity, former chairman of board for HIMSS, who will be talking on digital bridges, connecting to safe and quality care. Then we have Dr. Sanu Anand, the director, Smart ICU Strategy and Growth,
Cloud9 Physician Healthcare Private Limited.
We will be talking on the technology as a catalyst to access the quality of critical care.
And in fact, this session has 5 speakers. Okay, so the third speaker is Dr. Rajavardhan Rangappa, Lead Consultant, Manipal Hospital, Bangalore. He will be speaking on the continuous wireless monitoring integrated with Steady using iSciences PSC platform. And Mr. Sumit Puri, CEO and co-founder, Prana AI Wellness from Sick Care to Healthcare. And the final speaker, Mrs. Akansha Ticholka, Group CNO, Medcare Hospitals and Medical Centers, Dubai. She'll be speaking on can technology improve handoff and communication healthcare for safer care. So can we have all the speakers? Yeah, all the speakers are on the stage. So over to the chairs for the fantastic session, for the deliberations. Thank you.
Good afternoon, ladies and gentlemen. This is probably better. The mic is actually on now. All right. I'm Dr. Rahul. I will be sort of hosting the session. My duty is to set context for the session, but Dr. Santwana has already said it so well that I don't really need to talk much about it. So can we have a quick round of applause for our hosts for the day, Dr. Santwana and Dr. Devanand, please. They have been doing a fantastic job, so let's have a round of applause. Okay, now coming to the session. It is about care continuum, how technology will help us or how technology can help us in improving standard of care when there is transition of care. So I personally don't agree, but pundits usually say we should learn a lot from aviation industry and the safety standards of aviation industry, and we should implement those. So going by that notion, even aviation industry, the moment there is transition, the moment there is connecting flight, we all become anxious whether my luggage will arrive or there will be some delay. So even if we consider, or even if we agree that aviation is the gold standard, even they are suffering. So there are certain lacunae in healthcare industry, particularly when it is transition of care from one place to another. And here we will be looking at the entire spectrum from home care till intra-hospital care and post-discharge care. The entire spectrum will be discussed during this session. I know we are running late, I won't be taking much of your time, but this is how the fantastic panelists will be looking at various angles of this care continuum, and they will be putting forward some tech solutions to improving the quality of care. I think without further ado, let's welcome our co-chair, Dr. Vishal.
Thank you, Dr. Ishu. And I think the topic is fantastic with where the patients are best met. I think over a decade, the things have become very dynamic. The things have moved right from hospital to hospital-centric to patient-centric. The location has changed as per the care requirements. It can be hospital, it can be clinic, it can be at home, it can be an AI monitor device, it can be virtual, it can be at multiple locations. And we have our esteemed guests and panelists to talk about the subject. We'll query them and then it happens. Thank you.
Dr. Manish needs no introduction. He has come all the way from US to enlighten us about the care continuum from a physician's point of view. Over to you, Dr. Manish.
Thank you, Dr. Deshmukh. And I want to give a round of applause to the audience, those who have stayed back so late. So, round of applause for the people who have stayed for the last session. My immense gratitude to our hosts here at Kids and Kims. What a fantastic facility, what a fantastic mission. Truly an honor to be here. And what makes me feel good is if I happen to need medical care at this moment, I can actually rely on a good institution. And I think that's what this talk is all about. How many people here love to travel? Travel to exotic places, destinations unknown. Well, there are no reliable hospitals, clinics in many of those places. And in fact, some of the villages we are talking about today in India, some of the communities we work with in Africa. And that is what this is all about. As a doctor, as a potential patient, as a humanitarian, we believe that access to quality healthcare is a human right. Regardless of where I may be, in my office, in my home, in my car, traveling, quality care should be accessible. So a little bit about the organization that I founded a few years ago, the PUL Alliance for Digital Health and Equity. PUL in Hindi means bridge, building bridges to a better future, building digital bridges. PUL in Tamil actually means grass. What are the qualities of grass? Grass is resilient. The wind blows, nothing happens to grass. We mow the lawn, the grass grows back, sometimes to our annoyance. But this is what resilient healthcare is about. People in the communities are able to serve themselves in a manner that nothing changes that reality for them. And we work solely on one mission, and this is where our partnership with Caho is so important, and we see a huge alignment because we stand for improving access to quality healthcare. Not just any healthcare. Just having a provider is not enough. It's imperative that it has to have quality. And how do we do so? And we've heard these themes today. Capacity building, strengthening operations, and transformation. And a lot of the transformation actually has a digital component in this day and age. So what we want to talk about is how do we reimagine a new model of care? So this is really not about saying what we take today and just incrementally increase. It's saying how do we actually build capacity that is a sum of various things, but greater than the sum of its parts. We bring in community-based care using community health workers. And yes, we're using a technology partner out of India that is doing this in India, in Calcutta, in Kharagpur. Hospitals, upgrading them. Did you know 70% of medical equipment that goes to Africa goes to landfills? There is a problem that can be solved. A doctor who does not have the sutures when he is in the OR or the right OR table, that is a solvable problem. And I think those are kind of things we address. And then obviously looking at companies like Cloud Physician who provide remote ICU care. In fact, we are also working with them in providing remote ICU care in Africa. So imagine a village in rural Africa, a patient who lives in a village can not only get preventive care, but when, let's say this is a pregnant woman, goes to the hospital and needs a C-section, gets the right surgical care. And guess what, if the baby is born premature, we've got a partner like Cloud Physician, and there are others as well, who can actually support the care across the continuum in the village. So I'm gonna be fast and brief now because I'm in the interest of time. But we've talked about the care continuum from the community to the hospital. Within the hospital, there's a care continuum. And a lot of medical errors are made because transitions are not managed well. And I think that is really what we want to talk about. How do we reduce errors in transition of care? 70% are due to poor communication. And impact is medication errors, wrong site, surgery, treatment delays, higher readmission rates, increased costs. These are all of the things that Caho represents in improving in India that we can collectively improve globally. Structured protocols for handoff, I think Akansha is going to talk about them. Standardized mnemonics, staff training, information and communication technologies. It's not just technology, it's not just IT. Information and communication are the first two words. That is the purpose. Let's use it for that. And we can improve. So there are a number of technologies, and somebody once asked me, what's your favorite technology? My reply was, what is the problem you'd like to solve? And let's talk about the technology solution that's going to be most relevant. So thank you.
Okay, next will be Dr. Sanu. Dr. Sanu Anand will be talking about the daily health or the ICU, daily ICUs.
Hi, I'll try and stick to the time. Talking about technology as a catalyst to access to quality critical care. When I passed my fellowship in critical care more than a decade ago from a rather premier institute in the country, I happened to come back, work in a few corporate hospitals, or was on my way to another country, to the west rather, until I met the co-founders of Cloud Physician Healthcare, trying to solve a very specific problem, that is access to quality critical care irrespective of where a patient is. If you really look at the scenario today, we have actually witnessed many centers of excellences presenting how they deliver quality care here. But we look at when we get to the bottom of it, quite often we either have a problem with access, or we have a problem with quality delivered, or we have a problem with the cost. And this quite often precludes a poor patient or even a financially well-off patient who's living remotely away from the hallowed halls of these centers of excellence from receiving the proper critical care services from experts, so to speak. So we are a healthcare organization solving precisely this problem. We deliver location-agnostic critical care services to more than 24 states in this country across 250 centers, and plus another few countries, a couple of them in Africa being one. So in the last 8 years of our existence, we have managed close to 2 lakh patients. This data is a few months old. We managed more than 2,000, currently manage more than 2,000 critical care beds across the country. So what are the common challenges in the ICU? There are numerous challenges, but if you really look at it, everything boils down to lack of proper expertise being available at the bedside right at the time, and also data being truncated in multiple places. Anybody who has ever been admitted in an ICU really knows there is an ICU sheet, there's a lab sheet, there's a HIS, there is a LIS, there is a PAC system. There's so much data. When I as a clinician go to the bedside, I have to literally pull off my hair and pull data from multiple places to be able to deliver care. This happens when I'm at the bedside, and remote problem almost is only augmented. And this leads to loss of life, loss of revenue, and multiple problems. And in a typical two-world situation that's depicted in this slide, this is how an idealized ICU looks in the West, and to the left you have how one of our ICUs looks. So we live in a different world, so trying to force-fit technology which works in the West really doesn't really solve the problem. So we looked at frugal innovations at that point in time, rather than, like many of the speakers here have spoken about, rather than trying to fit a technology or a software or a EMR platform or whatever it is into a particular ICU or a particular hospital. We looked at what we really need, what can be done now, and what is important and what is need to have. So initially we looked at Smart ICU as a solution. This is back when we had very few doctors. Right now we have more than close to 100 doctors, one of the largest intensive care teams in the country, managing many patients across the country. But back in the day, initially we started with Excel sheets, and I was able to deliver care even with Excel sheets. Then we developed our own platform, Radar, which is a critical care ICU critical care patient management platform. Placing these high definition cameras at the bedside allowed us to look at the patient, his or her vitals, readings of monitors, and two-way audio-video systems with the bedside allowed us to communicate and mimic a bedside round in the same way. There were a lot of naysayers, including a lot of critical people, like myself, who didn't really have complete faith in the system when I started off. But early days in the model, there was this young boy in Muzaffarpur district of Bihar. He was 14 years old, and he had a disease called ARDS, acute respiratory distress syndrome. And with his ventilatory parameters, his expected mortality or the chance of dying was about 85% at that point in time. He wouldn't have made to the gate of the hospital, and the closest big ICU which had the expertise to manage him was in Patna, which was 3.5 hours away. So his fate was kind of sealed, and luckily we happened to have a presence in this ICU at that point in time. One of our critical care physicians, qualified intensivists, our critical care nurses got on the job, took over the care of this patient, instituted advanced prone ventilation protocols. This was almost 7 years ago. And on the right, you see him discharged after 1 month. He finished his college, he has a job now. So this is many years ago. And that kind of made us realize that this model works. And then when COVID finally hit, this hospital was actually ready to prone ventilate patients. So at that time when this patient was prone ventilated, that was the first time it had happened in the district. I mean, it has a population of few lakhs. So over a period of time, we moved from, this was still a very manual thing where we had a care delivery platform, we had physicians, we had cameras, etc. Then we moved on to more efficient things. I was able to deliver care, we were able to deliver care, but not just at the scale that we wanted. The number of patients we could take care was still less. So what a clinician really needs is technology as a tool which can cut the scut work and allow me to do what I do best, take care of patients. So then we developed live video monitoring. This is an automated discharge summary. Live video monitoring, live vitals. So there are AI algorithms in the camera which look at the monitor and automatically chart vitals. There is an automated note writing tool. There's an automated discharge summary. So this is a, it's not playing. Okay, there is a automated discharge summary which pulls information from various, anybody who has worked in an ICU, a patient stays for about 20 days. It's the amount of data is worth 4 files kept in 3 different cupboards, and making discharge summary roughly takes about 4 to 5 hours. That is that much more time the patient is staying in the hospital. That is loss of revenue for the hospital. Another patient waiting in the ER to come into the ICU, that's that much more risk for another patient. And it's also waste of precious time of the resident doctors or the junior consultants or whoever else is making the discharge summary, the transcriptionist who's finding time, and also the patient's family who's waiting for the discharge summary to become ready. So now with this AI tool, the documentation time reduces, actually it's more than 40%. We just, when we measure it as 40%, today it's close to about 60-70%. Computer vision allows cameras to look at monitors and automatically using image analytics take a picture, and the image gets goes into a tabular column like that. This also increases nursing efficiency by 30%. Now the thing is, none of these tools are replacing anything that the bedside physician or nurses do, but it's just making their work so much more faster because it's taking away the scut work, so to speak. Over a period of time, multiple other models came on, frontline critical care, where in addition to technology and the remote care, we also have teams on the ground which take care of patients. Our analytics dashboard give valuable insights into quality metrics and business KPIs of each and every ICU. If I offhand ask an average corporate hospital, what is your Apache score for the last 3 months? Can you give me a trend? Can you run analytics? Most of them do not have the capability. Those who do have take a humongous amount of time. The quality team goes back, reconciles it. Typically takes a couple of days to get that data. These live dashboards are available in a matter of few minutes. Going forward, the way is building more AI tools. So we are right now building, have actually rather built AI agents which can actually sit on top of any EMR as a skin. And these are some of the examples where one, we're able to detect patients who are on the bed or not. This is important from a reconciliation of number standpoint. In the NICU, detecting respiratory rates or respiratory distress using both language and vision analysis, detection of patient in bed, patient position detection as a measure for prevention of bed sores, and there are a few other models which you don't see here. So overall, the stacked approach initially, which started with just a few physicians, then virtual physicians and virtual nursing and Excel sheets, now has metamorphosized into a care delivery platform plus customized AI agents, which sits on top of their existing EMR. And if you look at this whole pyramid, this essentially forms the pillar on which our location agnostic critical care delivery platform stands. And the proof is in the pudding. We can speak all we want about ideas, but outcomes always speak for themselves. This is the outcomes that we have had so far. 50% increase in ICU resource utilization as a matter of protocols being instituted. One additional life saved for every 10 patients. 40% decrease in ICU, it's up to 40%. Ballpark is 20%. And a lot of training and upskilling for the staff as well.
Thank you, Dr. Manmohan, and for enlightening us with smart strategy how to manage the ICU beautifully. And I would like to invite Dr. Rajavardhan Rangappa as a lead consultant from Manipal Hospital, Bangalore, to further talk about the remote monitoring in ICU.
Good evening, everyone. We discussed about a lot of topics today, especially related to tech industry per se. As you've seen, if it doesn't reflect on the saving lives, there's nothing. And then we are looking at devices which can change the outcome or saving lives of the patient. Here, today I'm discussing about continuous wireless monitoring. It's integrated with MED system or RRT system, which most of the hospitals have. It's basically a study of 6 months retrospective data which we have analyzed from Manipal Hospital, Sarjapur. Can you go to next slide? So basically, we know that in the hospital, especially when the patient gets admitted in the ICU, we are going to monitor continuously. But when the patient goes to the ward or gets admitted in the ward, what we do is we do intermittent monitoring. That is every 4th hourly or 6th hourly, that's what we do. If patients are sick enough, what we do is we try to monitor more regularly. Okay, that's where the MED system or a rapid response system comes into play. That's what most of the hospitals have a model or RRT model system. What we did is, in the last 3 years we have been using in fact, but its use is more and more using recently. So what we have done is, those patients who are sick enough or who have abnormal vitals, we decide to monitor with wireless continuous monitoring device, iSenses it is called, we using remote monitoring device. So it's, as I told you already, it's a retrospective observation study. Inclusion criteria was this, use more than 5, definitely. Patients who are discharged from the ICU per se. Next is physician discretion. Sometimes we physicians feel that this patient is going to deteriorate. Those patients we're going to identify and put in the ward. It doesn't need to have a post-ICU patient per se. Patients who are admitted to the ward on the OPD basis, or it can be from the emergency. Okay. Then exclusion criteria, sometimes we want to connect it, but families will not be willing. Though that time we will not put it. We collected data from the ICU registry person, movements and mortality logs, water ICU transfers, readmissions and notifications come from the iSenses system. This is the data we have used here. So this is the movement, ICU movements per se. As you can see, gradually the number of monitored patients in the MET have increased, and in fact iSenses monitor have increased. Here, the patients in the MET have moved to the ICU is around, you can see, I'll just go to 1 month data because it's too much of data here. It is 16 patients in the December, whereas the iSenses patient moved to the ICU is less 3, whereas non-iSenses is more. Okay. So overall, this is the overall outcome you have to see here. So when you look at the patients who have moved from ward to the ICU per se, with the iSenses is around 11.2%. It's a percentage of patients because MET there will be a lot of patients. In the iSenses the numbers are less, so we calculate a percentage. It is 11.2%, whereas without iSenses it's 18.8. But one thing you should understand in this data also, the patients who are sicker will go on the iSenses remote monitoring device per se compared to med patients. This reduction is 7.6%, which is absolute. P-value is 0.028, indicating the importance of this system and effectiveness in preventing the patients going to the ICU per se. This is readmissions. Basically, patients from the ICU would have gone to the ward. Then they would have readmitted back to the ICU. This is ICU readmissions. As you can see here, with iSenses, it is just 4 patients who got readmitted, whereas from the med, the 10 patients they readmitted. It is 2.1 versus 2.6%. Since the low numbers, I don't want to interpret this the absolute numbers. Next comes to mortality. There are a lot of numbers are there. I'm not confused with numbers. I'll go to the this thing. So what is here is, as you can see here, there are med patients admitted to the ward. They can be classified in 2 groups. One is iSenses monitor, non-iSenses monitor. The mortality in non-iSenses monitor over a course of 6 months is 1.3 to 4%. Non-iSenses, that is. Whereas with iSenses, there are 3 patients who have died actually compared to non-iSenses. But all 3 are end-of-life care patients. We had a subset of patients who, when they are on comfort care or end-of-life care, they insisted on having a monitoring so that if you remove that, to be frank, we didn't have a single death in iSenses group or remote monitoring patient group. That's a very good numbers for us. So when you look at it, within MET, there are 6 patients who are being put on the MET or iSenses per se. Then also we had a 0 mortality, indicating that definitely monitoring make a better outcome in the ward, especially with the mortality perspective. So last thing is the intervention perspective. As we know, because we have a remote monitoring attached, it will send a lot of notification. When you look at this number, over a course of time, that almost if we have put on 34 patients, the notification percentage as high as 87.2%. There is notification of around 505. But for that notification, how much we acted upon is the thing we are looking at. What we decided is, for this notification, our responsiveness, we decided to divide it into 3 levels. Level 1 is something where nurses will manage, maybe just increasing the oxygen level or just giving a painkillers or something. That is level 1 intervention. Level 2 interventions where doctors are involved. This involves maybe putting a BiPAP on this patient, or giving fluids or injections, or giving administration or advising blood test per se. These are level 2 intervention. Level 3 intervention, as I told you already, shifting to the ICU. These are level 3 intervention. There are 3 levels of intervention we have done for these patients. So as you can see, the interventions will vary for these patients. So as I can see, we have not done so much intervention compared to the whatever notifications are there. There is a thing which will come, whether that we are having too much data, too much notification we have to act upon. But when you look at the outcome, as you can see here, we had a lower readmissions rate, a lower ICU transfer rate, lower ICU readmissions rate, and third thing, as I mentioned already, we had literally 0 mortality. We can say that we are a 200+ bedded hospital with pretty much well staffed and all. That way, we might have said 0 mortality, but 0 mortality is still a big number for us. So this consistent trend reinforces that long-term operational stability and clinical impact of integrated remote monitoring within the MET will improve the outcome as well as decrease the mortality. Thank you.
So, firstly, thank you for sticking to the time. So we already had the ICU as well as the remote monitoring now. So let's go to the wellness space. May I request Mr. Sumit to talk about the wellness and home care as such. Thank you.
Good afternoon, and I'll quickly try and cover what I feel is very important in these times, because we are saying we should probably be focusing on wellness rather than illness, healthcare rather than sick care. I'm sorry for my throat because I was in Delhi, so it's not the best. Quickly, we talk about the current challenges that we face on India's sick care model. It's more treatment focused, fragmented. There are gaps, as we all know. There's too much of pressure on the healthcare professionals, doctors, and there's a growing disease burden. India is a disease capital of the world. So there is a need to really change the way healthcare is being delivered, clearly. And it needs to be looking at paradigm shifts. And that's what we're basically talking about. The catalyst for change has to be technology. We've had significant interventions. We've got the National Digital Infrastructure, the ABDM mission doing some great work. We've got a lot of access being enhanced. But there is still gaps. There are gaps between infrastructure, gaps in insurance and healthcare, the gaps between rural and urban, significant issues that we're basically facing. And also in how technology is being used in hospitals. So frankly, there is element of people, process, and technology. All of these three things need to come together for this to be really effective for the patient. That's not happening at the moment. So that's what we basically talked about. How do you really make that work for a typical consumer? So this basically means a little bit more of AI and Gen AI. Of course, you all understand this is important. We need to kind of look at more personalized care. We need to kind of focus on how we really make this at scale. And that's where we're talking about specifically looking at aspects like early detection and diagnosis. Now, I'm just going back in time. I used to be in insurance companies earlier, and there we had new technology being tried out. Now in India, typically we saw in the morning somebody saying 2 minutes it took for a doctor typically to interact with the patient. That's what the time they have. You look at Australia, they've got 15 minutes as a mandatory time to spend with the patient. That's mandatory as per government regulation. In the US, they say 17 minutes is the time difference between a doctor who's sued versus a doctor who's venerated, who's really glorified. Because that's the time you're spending in educating the patient. In India, we don't have the luxury. The only solution is AI, because technology will need to augment and enhance information for the patient to the doctor, making it much faster. You could probably get some very good suggestions, and then the doctor can decide what is the right treatment. But again, there are other elements to it. You can obviously look at the quality of healthcare recruitment. And I'm not even talking about, of course, the delivery is dependent on people. There is AI that can help you in recruitments. We have technologies today, and I've already used them, which can actually ensure much better quality recruitments. And even trainings. We've heard Medvasari talk about this before. But there is a need to really augment both people and process so technology to work better for really good outcomes. And of course, if I look at the impact is huge, in billions economic impact. Only for India, how much it can save if we really start focusing on this better. Now, there are other elements to this, IoT and wearables, extending healthcare beyond the hospital walls. Because the patient today, the consumer of today, the Gen Ys, Gen Zs, they do not want to waste time waiting in lines. Whether it's the OPD lines or it is testing and all of that, they need their whatever treatments now. And again, they're pretty much used to the Blinkits and the Zeptos and all those kind of additional inconveniences. That's what they're expecting from hospitals, from healthcare. It has to extend beyond. It has to be viable. It has to be available to you anytime, anywhere. That's where IoT and wearables can do for you. And of course, beyond IoT and wearables, you can also make it even more convenient, even more accessible, even more cost-effective. And I'll talk about that as we go forward. But there is significant need for making this continuum of care, enabling this to be available to you all the time. With, again, we look at smart OPDs, we look at also interventions that are basically not for preventive in nature. All of these elements will come to the fore. Cloud will play a big role. You have to start looking at a more connected health ecosystem. And that connected health ecosystem will also include electronic health records. And I'm talking about a wellness health record, not only electronic health record, because there are other elements to wellness. There is nutrition, there is sleep, there is stress management, there is exercise. All of these need to come together for you to really be healthy. So that's another element to this. So again, look at other elements. We look at how do you really start utilizing elements that are really, really critical in terms of also making the revenue cycle management work well for you, because so many times claims are rejected by insurance companies because they're not being connected to you, and there's so much of back and forth and inefficiency in that sense. But with the cloud, you can today optimize cloud usage. We have solutions that today can, if you basically were to tell me, I'll not pay anything for my cloud usage for the next 18 days, 20 days, we have solutions that will say, please use that without any cost. We will show you the difference, how much money you saved, and then you can think about using it. As hospital administrators, you can start seeing the value, the ROI immediately from cloud interventions, which again is hugely beneficial from an ongoing cost efficiency perspective because you scale up or scale down. again, I'm talking about actually enhancing value, implementation strategies, because the key proof is in the pudding, is in actually executing this. And that's where we see a lot of possibilities. I mean, and I talk about a few things, like for example, discharge planning, right? I mean, there is that huge problem when the person basically is told by the doctor, you can leave today morning at 9, and he has to wait until 6 in the room. He's not able to go back because of various gaps in process. Now that's another key area which can be plugged by technology. But first we have to figure out the gaps in process. There are process issues there which can be actually augmented. Are we doing pre-planning discharge? Are we actually ensuring data is being transferred to the system immediately? Are you actually able to have electronic health records that are updated seamlessly? There's a significant possibility around this. Each step, from 4 hours to 6 hours of discharge, can be reduced to not more than 2 hours. We did this to Max. Max hospitals, our only core KPI was 75% people need to be transferred out of the hospital within that 12 period. That's the kind of things. And I'm talking about various elements there. I'll not cover too much time, but there are strategies there. And we can overcome barriers that we have for infrastructure in India with telehealth and remote care. Huge possibilities which can be done. EICU as well. We tried that EICU in Africa, where I was again trying this in Kenya and Nigeria. That's again very, very big. We heard Cloud Physician talk about that. So, real-time locationing systems for assets, for your patients, for also clinical tracking, all of this can enable. We actually had RFID tags that can basically also track assets, asset optimization, and we've done that again. Very, very significant in optimized efficiency, 40% reduction in costs. I'm talking about real-world impact. These are just numbers that you can look at. 50 million patients saved, 100 million cost savings, 10-90% accessibility, but with just lab and mobile, which we again piloted and experimented. I'll very briefly touch about Prana AI. We are trying to elevate the game in terms of home care. We're looking at seamless integrations and, of course, reduced readmissions and true healthcare, not just sick care. This is a 1-minute facial scan that we do, which gives you multiple parameters just using your own mobile phones, and then you can complement it with any further tests and additional parameters. And finally, I think this is what will get us to the future-ready state we want, to get us to that level of preparedness by which we can handle the disease burden that is growing day on day in India and the world. So finally, I'll just say the last aspect is embrace digital transformation. Look at new technologies which can actually augment both your process and people. Look at your process first. Fix the process, then look at technology. And of course, also enhance the skills of your people. Look at investing in infrastructure. Look also at collaboration with startups, with new ideas, because that will enhance the overall value of the country. Thank you so much.
Thank you, Mr. Su. Again, thank you for speaking. I understand we still have valedictory and people have flights to catch. So what we'll be doing is we'll be having maybe a couple of questions to each of the panelists, and then we can wrap up this session. So if I may start with you, Dr. Manish. In your opinion, has technology really helped us in bridging the gap in care continuum? And if you can give us some example of this.
Thank you. I think we have not realized the full potential of technology. I think there are isolated success stories that can be emulated, but I think there's a huge need for innovation. I also believe that in today's day and age, our technology and tools that are available is very different than it was even 5 years ago. So I think that innovation space on solving complex problems is even more exciting. But I'll give you an example of how we looked at the care continuum and really impacted care for stroke patients when I was the CMI of Cleveland Clinic Health Hub. So we had built a brand new facility, and the mandate was not to build another hospital, but to deliver on quality. That was non-negotiable. And one of the priority areas was stroke care. Now, stroke care is not a single doctor endeavor. It's a complex multi-team endeavor. So we were able to actually start with standardized care. So the first step was, what does great care for stroke patients look like? How do we actually identify all the caregivers, doctors, nurses, pharmacists, who will be touched by during that process, and ensure that they would be trained on teamwork and collaboration. Third thing we looked at was what are the communication points when a stroke patient does come to the door. And looking at the modality that would be the most appropriate. Sometimes when I'm sitting next to a nurse, it's better rather than send an email, right? And then when you're running a code, you need to communicate differently. So really kind of paying attention to communication and collaboration. And the final thing we did was technology enablement. And this is really a strong integrated digital platform that touches different aspects of the organization. Really created a blueprint. So regardless of who was on call on shift, anybody who was part of the stroke team provided standardized care. We were named the Stroke Center for Abu Dhabi within a couple of years of opening. So and I think that's what success looks like. But it starts with people first. It actually starts with standards of care first, and then people, and then processes and technology.
I think very insightful, Dr. Kohli. I think while we look at technology integrated and enabled care continuum, it also taxes the care providers, right from clinicians to admin to nursing to staff all around. So what do you think would be the key enablers? As you said, definitely one is systems, process, communication. But to prevent this burnout, what can really be the possibilities? Because it's becoming more taxing. It's 24/7, 8 to 365.
I think physician burnout, nursing burnout is a product of inefficiency that exists in the care process. I know of no nurse or doctor who went to medical school to just type into a computer, right? So I think one of our speakers earlier said, think about design. You need to think about how you reduce the friction for the doctor and nurses, bring the joy of medicine back. I know of no colleague, and we have several physicians on the panel, who would object to seeing 2 additional patients. But you tell them to do documentation and 2 more patients, they will object. So I really think it's being thoughtful and mindful. And again, I am like you, I think the airplane analogy is good to a certain point, but they've simplified the cockpit, right? And I think we need to have that mindset.
Speaking of burnout, I think we must have the nursing viewpoint as well. So, Ms. Akanksha, if you can tell us, in your opinion, what are the main barriers for continuum of care or transition of care?
So, good afternoon everyone and all the panelists. So, in my opinion, as a nursing, I can say the main barrier comes in our communication and coordination. And communication and coordination, see what happens usually, there are a lot of transition of care, patients transitions happens during the care from one department to another, or one nurse to another, one doctor to a nurse. So many areas, and you can see at WHO or JCI, if you see all those, they have published the studies that a lot of errors, a lot of life-threatening errors happens during the transition of care, and that's purely due to the communication and coordination. So especially for that, it's very much required that we need to have a proper handover, and there are a lot of standardized formats which has been made, like either it's ISBAR or SBAR or IPAS, so many, like in the OTs, like your safety checklist, all these are the type of the handover which really helps us to get the communication and coordination. Second, doctor, I can tell you that basically the nursing, and whenever there are errors happens, especially it is like wherever error happens, it's like comes across to the nursing why the errors has happened, and then poor nurses sometimes become a second victim also of this. So that's the reason having a proper processes, especially the fragmented care when we have it, we need to have a proper processes, because technologies definitely can help us to add a value, but having a processes and standardized planning. If you have a standardized planning, like I can give you example here, like when we want to discharge the patient and suddenly the nurse or the doctor remembers there is no proper equipment at the home, and then what happens? Patient stays at home, so stays at hospital. So or we realize when we discuss with a family member, patient cannot be transferred on second floor because there is no lift. So these are the areas of the which comes into the planning. So if you have a proper planning, definitely when you have a proper planning, again, I can give you example here, like we have the discharge planning at the time of admission, and we go through the discharge barriers, and when we have a barriers, we give the solutions to the patient. It is, in fact, it's not helps only to the nurses, but entire organization, to the doctor and operationally. So this to actually burnout happens of the nurses, not only and only workload, but the kind of workload, unnecessary workload. So that's the reason I think technology can help the nurses in a big way. Thank you. Thanks.
Probably our last or maybe second last, I can come to you, Dr. In all this technology adoption, how do we make sure that digital literacy is not the sort of limiting factor for digital access to care? We don't want to give anyone, it should be inclusive. So what can we do to ensure that everyone is included?
That's what we all know, that coming of technologies, it has its own limitations. So first, I want to discuss from the hospital aspect, from the community aspect. When you look at the hospital aspect, there are a lot of things. Example, if before coming to the hospital, you can make just registration or appointment, you can take easily online. That's a simple thing. But a lot of people don't have access to it. Recently, I think yesterday we had a presentation of one of the speakers about Tulu Health, where it can help them speaking in their own local language. With AI coming up, a lot of apps are coming up which have integrated local language, speaker mode and all, which it has become very easier for them to communicate also. Second thing is, in India, as you know, our best resource is human resource. When they come to the hospital, even though a lot of technology is there, there's one person who's coming to always help out to fill the forms. If they're not literate, they can fill the form. Even if they're literate, even if they're illiterate, somebody is there to help them out regarding all these things. Always we make sure that how much our EHR or EPR systems we have, there are always people who are there to help out in the hospitals. So in the hospital, it's not a problem having a digital illiteracy. When it comes to community, definitely it is a setback at this point of time. Okay, but in India, we are working through systems with AI coming up. Definitely we'll catch up on it. So it's just a matter of time, I guess, with AI apps getting integrated with the local languages, and it will be soon that you don't need to be digitally literate to learn a lot of things and to do a lot of things related to that.
I think it's also important that with so much of AI integration and digitization, that the patient privacy and dignity is protected, because there is exposure all around to people, identity trials, everything going on. I think, is there a line where we need to draw between the expansion of the data beyond a point, or maybe put a regulatory controls on that?
Regulatory controls already exist regarding this. The main thing here is, whatever the data goes into AI, it is gone into the AI completely. Nobody has control on those data. Nobody has control on the data. Sometimes it might be difficult because if you put the patient identifiers, it is into that system. Okay, nobody knows what happens to the data. Right now, there are a lot of blurring of lines in the aspect per se. I think only with regulations coming up, we'll come to know later.
We're almost at the end. So one question for each panelist. If all of you can answer with one, maybe a couple of words that the audience can take home. How we can implement better technology to improve the continuum of care, or what can be done, or what needs to be done.
So I think it's extremely, we are at that crossroads when, to be honest, we don't know what tomorrow holds. There was no ChatGPT a year ago. I have doctors in my organization who are developing sandbox projects, churning out apps on a weekly basis. That couldn't happen a year ago. So there is enough tech out there currently. There's enough data out there currently. I think right now the focus should be on using existing tech, going back to the patient, looking at a very pragmatic way of let's solve problems of the patients and healthcare at large, and what tech can we use, rather than trying to predict the future. The focus should be on analyzing the patient and problems. There is enough tech out there right now to solve most of our technology needs in healthcare. There's enough data out there as well. It's just about putting it together and using it in the right way.
I would echo said, I think our ecosystem is quite disorganized. As a doctor, it's pretty overwhelming. There's so much technology out there, I don't know how it works. And what I see is that any technology that comes from my space makes my job harder. I'm doing more tasks. So I really think the first thing we need to do is reduce friction for the frontline doctors, nurses, caregivers, reduce the burnout, and really organize our ecosystem so that we are bringing thoughtful solutions to the front lines. And I think forum
is coming up. When it comes to community, hospitals don't want to take that initiative, taking the responsibility of the patient person, because even if they start monitoring, if something happens, because you know India, something happens, community action is first thing, any courts and laws will decide. That's why hospitals don't want to get into the home care side at this point of time. If you look at it, the companies which are in the hospital care, that's what is happening. It's all fractured at this point of time. We should start encouraging the hospitals to take initiative, not punitive actions. If you take responsibilities just for the care of patients, that's where I think once you start blurring the line and start motivating hospitals and the doctors for taking care of the patient, let them establish a system where we can have a continuity of care. That way, I think yes, it can happen.
I think for me, the focus has to be on adoption of customer-centric technologies, not just technology itself, but adoption. And aligning people process towards technology. I think that will really create maximum impact.
As a nurse, I can say that technology is not to replace compassion, but it is to create a space for this healthcare worker. You know, because whenever we bring a technology, and as a nurse, I can say the first question from the finance or the CFO will come, how many nurses are we going to reduce it? But please to find that technology is enabler, it's not a replacement. That's what I want to tell everyone. It is going to help the healthcare team member. Thank you so much. Because it's going to help all of us to get rid of all our routine mundane work, where we can give more and more time for our patients, and we can have more and we can reduce the clicks and we can improve the care. Thank you. Thanks.
So I think that brings us to the end of the session, and I really would want to thank all the panelists who have covered the entire spectrum in the sense of being clinician, being admin, being the nurse, being various segmentation, and I think it has, I'm sure, brought a lot of insights to everyone. I thank you, all of you. Thanks to kids for organizing the forum and Cahotech. Thank you so much.
Thank you. Thank you.
Please join for a group photograph. Request all the speakers and chairs to join for a group photograph, please. Request all speakers to collect their mementos from the chairpersons once they go on the stage. The audience have become silent. We request you to at least let us know your presence. Yeah. So I have again a good news and a bad news.
Oh no, not
You
again.
want,
Please.
What do you want first?
Please, please, please.
Bad news?
No more bad news.
Only news. So the good news and the bad news is that we have almost come to the end of today's thing, with these sessions. So this is the last session, followed by the valedictory, and this is a very small address by an international guest. So to chair the session, we call none other than our President, Dr. Vijay Agrawal sir, President of Caho, to come onto the stage, and
We
Dr.
have
Lalu,
the dynamic Dr. Lalu Joseph, the Secretary General of Caho. And yes, he forgot to tell you the bad news. Anyone can guess? No chocolates for guessing the right answer. You're going to miss us. Anyways, Dada told me one thing about Dr. Lalu when we were talking last evening, is that how many of you all know what is TRP? You know what is TRP? No chocolates for guessing the right answer?
You say chocolates are the, then only they'll give you answer.
No, I could have given something better. So, Dr. Lalu has the highest HRP, not the TRP. TRP is for the television rating point, which is generally for the news channel. But Dr. Lalu has the highest HRP, that is the healthcare associated rating points. She is the most sorted on all of the social medias and on LinkedIn and the other professional websites. So welcome Dr. Agarwal, sir, and Dr. Lalu Joseph.
So yeah, so over to the chairs. So we have a special address by an international speaker, Dr. Rabi Dablis, who is the CEO and founder of Aman Viva, former Senior Manager Quality and Medication Safety Services, Cleveland Clinic, Abu Dhabi. We'll be speaking on dual engines of medication safety, digitization, automation, and the good news, as I mentioned, this is the last session, and it will be followed by the valedictory.
Rabia, over to you for your talk. Dr. Dablis, you are muted. I think you are muted.
Okay, sorry, you can hear me right now, right? Okay, sorry about that. Good afternoon, everyone, and sorry to be the last person who is holding you back from going home, but I'll be as brief as possible. I had the pleasure of working with Dr. Manish for several years at the Cleveland Clinic in Abu Dhabi, and I really appreciate Cahotech and Dr. Vijay and the rest of the scientific committee for the invitation. So to begin my session today, I'm going to always start by why. Why are we having this conversation, and why are we always focusing on the importance of design in building hospitals that are safer? So a question that I'd like to ask to when I have this presentation or talk about it is, what do you think an elevator, Miss Universe, and a hospital have in common? Well, it's that bad design is everywhere. Here's an example of an elevator in one of the centers actually where we were working when we were building the Cleveland Clinic Abu Dhabi. And if you can see from it, this is extremely difficult for you to be able to know which floor to get to. So what happens if you get on the wrong floor? Well, you can go back in and then you can find the right floor again. So not that big of a deal. Here's another example with Miss Universe back in 2017, where actually they've announced that Miss Colombia is the winner when it was actually Miss Philippines. What was the reason? It was actually the design of the actual card that was used by the presenter who read it the wrong way. So what happens when you read the wrong name? Maybe a bit of bad publicity, but that's the maximum that can happen. But the third would be is we also have a lot of bad design that we see in healthcare. And what is the outcome when we have bad design in healthcare? Well, the outcome could be, a patient losing their life. And we don't want to be in the shoes of that patient. We don't want our family members to be in the shoes of that patient. So that is why we are all committed as healthcare provider in making sure that we want to take care of our patient and build a system that is safe for everyone. And what do we know? We know that 1 in 10 patients is harmed in healthcare. This is data that keeps on being repeated over and over again. But we also know that more than 50% of that harm is preventable. And a lot of the errors that we see are coming in from transition of care, but we're also seeing a lot of issues that are with medication error. And I've worked for more than 15 years within several healthcare organizations to see how can we prevent this using a systems approach. So if you go back to some of the data or some of the work that is being done by WHO, is that in 2021, they came up with a global patient safety action plan. And they said in 10 years, we want to make sure that we are building a system that is, safe from harm. And if we look at some of the strategies that they have in place, 3 things resonated with me when I looked at the report. The first one being, you want to have a high reliability system. So we always keep on hearing about HROs. And I know some individuals, some gave some examples from the aviation industry, which is it's supposed to be an HRO, where you're always focusing on harm, you're preoccupied with failure, and you're making sure you're designing a system that is fit for the individuals that are working on it, which is really the basis of how you want to structure your organization. You want to focus on the safety of the clinical processes and also focusing on information sharing, research, and risk management. And I will not be going into the details of it because really this is not the topic of our conversation today, but at least I wanted to give you show you some of the frameworks or the objectives of the work done by WHO is really primary two things. Building the high reliability systems and also ensuring you have constant flow of information. You can research that report and it goes into a lot of detail on what is the roadmap to follow in order for you to be able to reach that state of preventing harm. What we know from Dr. Lucian Leap, who is the father of patient safety, he says the single greatest impediment to error prevention in the medical industry is that we punish people for making mistakes. But if you look at where people stand in the bigger scheme of things, this is what is called the SIPES framework. It's called the Systems Engineering Initiative for Patient Safety, is that, as you can see from the image here, people are only one component of a system. So any caregiver, or the people could be the staff, the patients, the teams, the skills. And there's a connection. They are connected to the technology and the tools they're using. They are connected to the organization in which they are working. They're connected to the environment. And by the environment, it could be the physical environment where, lighting, noise, temperature, layouts, and even external, which could be political and social factors that can affecting the workflow, and then the tasks. So all of these are factors that are actually influencing people. And when you influence people, that is going to influence the process. It affects the work that is required, the physical, the cognitive load, and some of those social behavior. And so work system results in process, results in outcome. And the outcome could be on the organization, it could be on the people, and it could be also on the patients. And it's a cyclic thing. So depending on the outcome, it feeds back into that work system. So when we go back and we say, I want to punish someone for making a mistake, it's really rarely the cause of the error happening. Unless someone has intentionally went around and tried to kill patients, we know it's usually a system issue. And this is where a lot of the discussion around automation and digitalization comes into play. So if you want to kind of look at a bigger picture, give you kind of a bird's view eye of the medication journey, it starts with the selection and the procurement of the medication. That's usually done through the formulary and therapeutics committee. We have the physician prescribing. We have order verification by a pharmacist, preparation and dispensing. Ideally, it should happen in pharmacy, but in a lot of hospitals, they happen on the nursing units, depending on your resources. We have storage and transport, administration, and monitoring. And where do you think most errors happen in the medication journey? Well, it's usually in the prescribing phase and then the administration phase. In the good old days, when people were using fully paper system, a lot of the errors with prescribing were related to writing the wrong medication, writing the wrong dose because of bad handwriting. But what we're seeing right now with prescribing is that a lot of the prescribing issues have to do with medication reconciliation. So even if you introduce a technology that is fixing one problem that you had, if you're not fixing the process by which you're actually doing the work, you're actually making the work worse. And one of my colleagues earlier actually mentioned exactly the same. Before you introduce a solution or a technology to your problem, make sure you're actually fixing the process, because automating a bad process is just making something and making it even worse and expanding its reach. So when we look at the Institute for Safe Medication Practices, we have what we call the hierarchy risk reduction. And the highest leverage one is creating forcing functions and constraints. So for example, removing concentrated potassium from the floor prevents people from actually giving it and having patients dying from arrhythmias. But also the second high leverage is automation and computerization. So making sure that I automate my processes, anything that I have a paper system, I make it electronic. The medium would be simplification and standardization, having reminders, double checks, and checklists. And the least one is policies and procedures and education. So we always say when something bad happens, well, we're going to go and educate the nurse. Well, before you educate the nurse, you have to go back and review. Do you have a workflow that works? And did you automate that workflow to make sure that you're designing a system where you want to make sure that you're making it in a way that it's easier to do the right thing and harder to do the wrong thing. So when we're thinking now about automating our medication journey, there are different ways we can do this. When you're thinking about selection and procurement, you can have, let's say, automated replenishment. You can build different formulas within your system to automatically help you replenish your orders. That way you don't run into issues with having shortages of medications. And this is where you can also generate the use of maximizing the artificial intelligence use. The second one would be through physician prescribing. You can introduce electronic health records. Under auto verification, you can introduce auto verification functionality. So let's say if you're in a clinic setting and you're using, medications that are non-high risk, you can allow for those to be automatically verified as long as the patient meets specific criteria. And then in the preparation phase, you can have packing dispensing robots, automated carousels, IV admixture robots, and IV workflows. And under storage, automated dispensing cabinets, you can have transport robots that you see now roaming different hospitals, and then more and more the introduction of radiofrequency ID, especially for chemotherapy, for narcotics, and then for high-cost medications. And under administration, we know that IV infusion pumps and barcode administration are one of the technologies to use. And last but not least, under monitoring, you can introduce artificial intelligence where you have, the AI going into the chart and picking up on patients who might be at higher risk of developing clinical deterioration, or you can also identify various trigger tools to say, well, there's a high likelihood that this patient has actually experienced an ADR or an overdose because of, we have trends of them using naloxone or using flumazenil. So you're relying on your AI agent to go into the chart and picking up on these things and making that information more legible and available for the healthcare practitioners. So the question always is, what do I start with? So if you are an organization that is, has limited resources and you're currently doing everything manually, if you have the option to start with something, the best practice is always to start with your electronic health record, because when you start with your electronic health record, you're allowing for e-prescribing. So you're minimizing the errors that are happening to poor handwriting. But also when you introduce your electronic health records, then you're also able to introduce next or afterwards your electronic medication information records. So that will make it easier for the next step to prevent errors with IV administration. Next, infusion pumps is also one of the technologies that you want to implement first, and then barcode medication administration. And in order for those to happen, then you need to make sure you have a robust system within your pharmacy department where you're enabling the generation of labels and whatnot. So these are, some of the things that you kind of want to think about when you're introducing technology. There's a lot of options that are out there, but, again, we go back to the same concept of that focusing on human factors. How do I design a system that is fit for the limitations and the capabilities of human beings? And when we have that approach with whichever technology we're trying to introduce, then we know we are on the right path for creating solutions that are sustainable and then that we can continue to replicate time over time. I know we're very limited with time today, but I mean, if anyone has any questions, I'm happy to answer them. Thank you. I cannot hear you.
So thank you very much. And of course, with this in this very important talk that he has highlighted about the issue of medication safety, both I can say Lulu and me are very determined that we give a call of action that medication safety will become a focus area for Caho to see that we reduce medication errors in this country. By all our efforts together, let's work on it. So thank you very much. And we have Mrityunjay, please, if you can come on the dais and
So please give a loud applause for Dr. Mrityunjay, the Director General, Industry Institute Innovation Office, KIT University and CEO, KIT TBI. So we also, we are entering the last phase of the conference, which is the valedictory and award ceremony. So we will invite the following dignitaries to come onto the stage. Our Vice President, Dr. Shankardas Gupta, Changasen Gupta, sorry, Mr. Dr. Naren Sekar, Mr. Som Mittal, Mr. Manish, Father Johnson, and Mr. Soumyakat Satpathy. So we are having all the dignitaries on the stage now. So Father Johnson is coming, yes. Father Johnson is the chair of the healthcare hospital wing of Caho. He's also the CEO of Rajagiri Hospital, Kerala. So I request Mr. Satpathy to introduce, please have a seat. Mr. Satpathy to introduce our guest of honor, Mr. Mrityunjay sir.
Respected dignitaries on dais, of the dais and the delegates, regarding Dr. Mrityunjay sir, what should I say? He's a distinguished colleague of mine, my senior colleague. He is the Director General of Research, KIT University. He is also the CEO of KIT TBI, that's Technology Business Incubator. And he is a PhD holder in molecular microbiology from University of Delhi. Also, he has done his postdoctoral from ETH Zurich, Switzerland. He has numerous awards to his name. I'm not going to detail with that. He has got almost close to 300 research publications in his name. And he single-handedly established this TBI, which till date has helped almost close to 400 startups, creating more than 6,000 jobs till date, and it is continuing. And he is a very lovely person to work with, and he is just a call away whenever we call. Thank you, sir, having me here.
So, very good evening to all of you. Great to be part of this valedictory ceremony of Cahotech. I think thanks to Vijayji and Satpathyji for inviting me here. I'll not take much of your time, just tell you, this is a very different kind of campus where you are. And because I heard that you are coming from different fraternities, especially from the medical, the hospitals, and the technology development in the field of medical sciences. So ladies and gentlemen, I'm here for a purpose today. I thought there'll be a crowd of people who are talking about medtech innovations and hospitals. I'll briefly speak on one thing. Where I go, I speak about it because that's what I have learned in the last 17 years of my stay here in the campus. What is missing is building the path exercise. Cahotech is a platform where people are coming together, listening for 1 or 2 days. But what is next? Could be CahoCon, then next Cahotech 2026. But let me tell you, we are forgetting one thing, building the path for us. What is that? It's a process. Wherever I go, I talk about it because that's where the scientific community, researchers, clinicians are probably not doing the right thing. As a profession, clinicians doing great job, surgery, prescribing, looking after patients, but then the real problem statement, what you are looking at, is not being translated properly in a form of path exercise. And that's what I want to tell you here. It's a process which brings up problem statements. I am sure you've been hearing about this since yesterday about the Beach Fest. Some of the exciting company, I saw the list, have been talking. Wow, without taking blood, you can measure hemoglobin. The company is becoming bigger and bigger. And how can you look at microalbumin by a simple device? Maybe Prante has talked about it. There could be a smaller CPR machines. There could be a lot of exciting things happening around the world, around India, also around here. But what is missing? The convergence of the clustering approach, which I've been telling here and there everywhere. I was in Dehradun, then in Chandigarh, then tomorrow in Delhi. Same concept which is missing in our countries infra is being built, conference are being there. Great thing because Cahotech is a very prestigious conference, I have been told, and I have seen that. But what is missing is probably clustering approach where we can bring problem statements from you and then start building through a process of prototyping, developing, interesting MVPs, do a piloting, test beds, providing validations platform, certification trials, and these are all happening here in KIT. So I wanted to welcome all of you, I don't have much time, but to the India's largest incubator which I represent called KIT TBI, 490 odd companies, close to 26 medical professionals having their own companies. And that's what we want to celebrate here in the Cahotech, that how can you work together with you, not only to run a conference, to organize a conference, but how can we take technology for further development processes, validations, test certifications, paid pilotings. It's something you have heard about it, ETA, Early Transfer Executive Program. You bring technology at TRL 3-4 level, how can you work together to make it TRL 7-8? So this path is probably not been told in a structured way in many places, and that's what I'm a great admirer of those things, to see that these things should not only end up in a conference abstract book or a note, but let us pick up problem statements from some of you, which are very exciting, unmet need, and work in a clustering approach through a path building exercise to see that how do we bring convergence of funding, resources, infrastructure, the mentors. We can bring from everywhere. I think somebody was talking from a country, we can bring from everywhere. Harvard Medical School to AIMS Bhubaneswar to AIMS Delhi. I think this is what we should do now. Cahotech, I was talking to Bijayji that this is what we can do to work together to see that startups are not going to only develop it, but it's going to deploy through you. Because you are all MedTech fraternity, medical science fraternity, you can make it happen. Let us work together. I'll not take much of time because I know it's a very session, some awards we're going to give. But welcome to India's largest incubator. I think you should have gone there. If you're not there tomorrow, please go to KIT TBI. 490 odd companies, more than 10,000 employments that we have created, and already 160 plus technology products in the market. More than 1,800 crores private equity funds we have raised. We never talked about it because we are from Bhubaneswar. It's in Delhi, Mumbai, Bangalore, Hyderabad. It's not only India. It's happening in Bhubaneswar now. So that's what I was very excited to talk to you. Welcome to Bhubaneswar, welcome to Odisha, welcome to KIT, which is one of the very strategic platform which not only talk about education, research, innovation, and most importantly, the enterprise case in true sense. These companies have now gone to a wealth of close to 25,000 crores valuation company. So as a scientist, as a molecular microbiologist, I should also speak about commercials. Otherwise, everything is going to be parasitic in nature, even the conference. So let us work in a clustering mode. Somebody brings problem statements, somebody builds prototypes, somebody takes up into next level of TRL development, product validations, and that's how Cahotech will be very different in other conferences. So compendiums should be come with, I think that's what I was talking to the other members of Cahotech, because they're also my colleagues. I couldn't give much of time, sir, but I think the next, before conference, we'll build a new chapter for Cahotech, where we'll bring out compendium of technology solutions in healthcare sector, which are matured, deployed, affordable, adaptable, and scalable. So beyond this, we have built one more organization called Bhubaneswar City Knowledge Clusters, which is an initiative of the Scientific Advisor to the Prime Minister Office, called the PSA Office, 8 clusters, and we are one of them. I chair the cluster. Under that, we bring in a lot of institutions like AIMS to Harvard Medical School to startups to government. And on 21st, 22nd, we are having a biggest sustainability conclave. 50 top solutions in sustainability will be showcased in Bhubaneswar, where these are coming from all across India. Why I'm saying this, science must build technology, and technology must build product and enterprise. Otherwise, these are only limited to publications and patents. I'm a great admirer of this process, the path building exercise. I wish many of us would really think better than what I think today. If we do that, I think not only Odisha, India is going to rise and shine in manufacturing sectors. This is what my wish list. I hope some of you will take it forward. And I thank Cahotech 25, which is, it's come to KIT. And thanks to Mr. Satpathy, who has taken a lot of pain to organize here. And but I see that this is going to be different in next year. We see a lot of innovations we celebrate out of India for the globe. Thank you so much.
Thank you, Dr. Mrityunjay, sir. In fact, I think so there are a lot of the youngsters who are there who are getting more and more motivated as the session is coming to an end. May I request our President Sir, Dr. Vijay Agarwal, to please felicitate Dr. Mrityunjay. Thank you, sir. Thank you for your presence and for your motivational words. Any session, any conference, any event is left halfway through if we do not acknowledge the contribution, especially by our sponsors. And we take this opportunity to thank our sponsors.
Too much data, too many disconnected systems, too little time for what truly matters, patients. That's why AFMA came into being. The soul that fuels the complex healthcare ecosystem. An AI-powered platform co-developed with doctors, nurses, patients, and care teams. We bring everything together. Seamless electronic health records, real-time insights, and AI-driven automation. A mobile-first experience, anytime, anywhere, so that healthcare teams can focus on patients, not paperwork. From hospitals to labs to pharmacies, AFMA connects every touch point, enabling double boost in patient throughput, higher accuracy with 90% fewer errors for safer treatments, and seamless collaboration between care teams. And with our flagship apps, each touch point runs smooth, keeping doctors, nurses, and patients in sync 24/7. Because when everything works together, less time is spent on managing systems and more time saving lives. Faster, safer, better. Let's build the future of healthcare together.
Our gold sponsors,
AFMA, powering tomorrow's healthcare.
Welcome to Kaveri Hospital, where cutting-edge healthcare meets compassion. From its humble beginnings in Trichy 2 decades ago, Kaveri Hospital has grown from a 30-bed facility into a multi-speciality healthcare institution. Kaveri Hospital offers high standards of medical care under its centers of excellence: liver diseases and transplantation, urology and nephrology, vascular surgery, orthopedics, cardiology, neurology, oncology, 5,000 plus surgeries, 200 plus doctors, 300 plus beds, 800 plus medical professionals. At Kaveri Hospital, we believe that healthcare goes beyond treatments. We will continue to deliver world-class medical care with compassion, expertise, and dedication. Experience the convenience of complete healthcare all in one place. Kaveri Group of Hospitals.
Our silver sponsor, Kaveri Hospital.
MedVarsity, a name synonymous with healthcare education, has cultivated a legacy of excellence. With alumni from over 192 countries, MedVarsity's reach extends far beyond borders. MedVarsity stands out as India's only healthcare edtech brand accredited by the British Accreditation Council. Every course is meticulously crafted by clinicians and rigorously peer-reviewed for the highest quality. Why MedVarsity? Because we are not just an institution, we are a movement towards a better future in healthcare. Take the leap with MedVarsity and transform your career and the lives of many. MedVarsity's unparalleled network encompasses clinical training agreements with 60% of India's top corporate hospitals. This exclusive access ensures our students gain practical insights alongside industry leaders. At MedVarsity, we revolutionize learning with our case-based learning methodology, a first in Indian healthcare education. Experience real-world scenarios with our case-based learning approach. unique to MedVarsity. MedVarsity, educating healthcare leaders worldwide.
Our silver sponsor,
Hospitals are
MedVarsity.
transforming fast, yet patient data remains fragmented, disconnected and delayed. Clinicians need real-time insights, not retrospective data. Asansis introduces the Patient Status Engine, a next-generation medtech solution built to enable continuous, advanced patient monitoring, seamlessly capturing real-time vital data and streaming it securely to clinical systems. Powered by wireless sensors, AI-driven analytics, and full interoperability, Asansis connects patients to clinicians, anytime, anywhere. It integrates with EMR and its platforms, ensuring data security, scalability, and compliance. Delivering continuous visibility across care settings, Asansis empowers hospitals to act early, optimize resources, and elevate patient outcomes. From bedside to command center, a single digital fabric for smarter, safer care. Asansis Life Care, driving innovation, interoperability, and intelligent care.
Our bronze sponsor, Enhances. Our silver sponsors, Charnock Hospitals.
This NABH accreditation reinforces our commitment about our world-class emergency care and safety to the patient.
This accreditation is a validation of our round-the-clock dedication and expertise in emergency medicine.
Our technical partners, Woodland Hospitals. Our silver sponsors, Cloud Physician.
You know, I have to commend Cloud Physician for a quiet video, no sound. Has anybody been to an ICU and you see all the beeps? You can't really make out what's wrong. This is what a good ICU should look like.
our technical partners, ILS Hospitals. Thanks to all our sponsors, the ones who have not shared their videos as well. We really acknowledge your contribution towards this conference.
Sorry. So now we are coming towards the end of this conference, and before we get into the award ceremony, I request Dr. Lalu Joseph to make the announcement for the Cahotech 2026 along with President Dr. Vijay Agarwal. So, any guesses where the next Cahotech 2026 is going to be held? Oh. So yeah, if you will make the announcement, yeah.
It will be at Andhra Pradesh MedTech Zone, AMTZ, Visakhapatnam. Because of minister's visit, he could not be here. They have sent a small video. Let's play that, please.
Yeah, we'll play the Cahotech video first, followed by Mr. Jitendra Sharma's videos. Yeah. So the Cahotech video first.
Future is loading. Prepare for the Cahotech event, where data meets destiny.
Thank you. A huge round of applause. So the host is AMTZ. So we have a video message from the MD and the founder CEO of AMTZ, Mr. Jitendra Sharma. Can we have the video, please? He was supposed to come here today due to some emergency. He couldn't make it. So he has sent a video to us.
The Consortium of Accredited Healthcare Organizations in India is a platform and a premier body bringing together accredited healthcare organizations. Accredited healthcare organizations stand for their credibility, efficiency, and their novelty. Adopting newer and newer technologies, right from better sources of cyclotron, FDGs for PET CT scan centers, which we are very happy to supply to entire Orissa from AMTZ Visakhapatnam, to tele-ICU care. Technology is and will continue to change the way we provide healthcare. Caho leads this mission through Cahotech, which is the flag bearer event of technology being adopted and accelerated by the Caho members. We are very happy to support and send our best wishes to Cahotech 2025, which is being held at Bhubaneswar in one of our partner institutions, a very esteemed institution. We also hope and look forward to hosting Cahotech 2026 at AMTZ Vizag, which is world's largest medical technology cluster. Being the world's medical technology cluster, world's largest cluster, we produce all categories of medical technologies, radiopharmaceuticals, diagnostics, disposables, and wearables. But we would look forward to integrate this ecosystem of technology and technology platforms into the mission and vision of Cahotech members. Therefore, best wishes and good luck for Cahotech 2025, and see you at AMTZ Vizag in Caho 2026. And hopefully, this partnership of AMTZ and Caho will bring a new cloud of medical technologies, a new bouquet of medical technologies for all the Caho members, for the clinicians, and for the patients. Thank you and Jai Hind.
So we have a representative from AMTZ here.
May I request Barnali Hazarika to please come on the stage, and can we play the video of AMTZ?
So this is a beautiful venue where the Cahotech 2026 is going to be held. It's a quick glimpse of the campus.
I welcome you all. As Dr. Sharma said, we are open with our open hearts. Please do visit AMTZ, and we would love to host all of you for Cahotech 2026. Just a small glimpse of AMTZ for all of you.
So Cahotech 2025 is handing over the baton to Cahotech 2026, and you all are welcome to join us over there.
Please give a huge round of applause to the AMTZ who are kind enough to host the Cahotech 2026. All are welcome to visit Visakhapatnam, which is one of the beautiful beach destinations. So hope to see you all there. Rajan, you have a tough job in hand.
So now we would be starting with the award ceremony, and the award is for the two categories, the winners for the hospital innovation and the winners for the early technology adoption. We would start with winners for the hospital innovation, and in this the subcategory of administrative and organizational excellence, may we invite the first place is shared by two organizations. CMC for the statutory documentation management software. Hearty congratulations to Team CMC. And Rajakevi Healthcare for the real-time discharge dashboard.
CMC, and no one is there. Dr. Lalu is there? Okay, please to come. CMC team. Yes. Congratulations.
The second place is by Peerless Hospital. We have two first places and we have a second place by Peerless Hospital.
This category is administrative or organization excellence. This is the category. CMC and Rajagiri shares the first place, and the second place goes to Peerless Hospital. Now comes the second category. The Peerless Hospital is here. Peerless Hospital team, yeah. The Peerless Hospital team is not available, so we'll go ahead with the next category.
HR Excellence is the subcategory under Hospital Innovation, and the first place goes to Retaining Talent, Restoring Balance, a tech-driven nursery journey by Medcare Hospitals and Medical Centers, Dubai.
We have Rahul. Yes. Yeah, that's okay. You can represent.
The second place goes to New Mosfet Hospital, Kuwait for application development for doctors' scorecard, supporting ongoing professional practice evaluation. And we have a third place. So as it's getting a bit darker, I'm getting a little night blindness. We have two second positions. The second position is shared by Kinder Hospitals, Kochi, Kerala for the Kinder Voyon Focus and AI-powered HR transformation.
Yes, Kinder team is here.
Kinder Hospitals,
Yeah.
Kochi, Kerala. Run, young men, run.
We move on to the third category, which is Clinical Excellence, and the first prize goes to Charnock Hospital, Kolkata, West Bengal for an AI-enabled IVAS guided PDCA. Charnock team. And the second prize is taken by Apollo Sage Hospitals, Bhopal, Madhya Pradesh. First prize is Charnock and second is taken by Apollo Sage Hospital. The Apollo team, Apollo representative on the stage.
Our next category is Academics, Research and Excellence. And the first prize goes to Astor Sanad Hospital, Riyadh for the research or study to evaluate the response regarding the nursing orientation program and its impact in nursing practice amongst newly hired nurses in Astor Sanad Hospital, Riyadh.
Dr. Rahul can represent Astor and can come over and take it, please. He's part of Medcare, which is Astor Hospital.
And the second prize goes to none other than our own KIMS. Development of a training module on infection control practices for interns and postgraduate students from the Kalinga Institute of Medical Sciences, Bhubaneswar, Orissa.
KIMS team,
This is the entire KIMS.
Kalinga Institute of Medical Science team, anybody? I think Mr. Satpathy is there on the stage. Director of Operations himself. Is there anyone else?
So a big round of applause for the Hospital Innovation winners. Congratulations to all of you. Now we go into the early technology adoption. The winners for the administrative and organizational excellence. Kaveri Hospitals, Chennai, Tamil Nadu gets the first prize for automated card and UPI verification systems.
Yes,
team is here. And the second prize goes to Ruben Memorial Hospital, Patna, Bihar, for patient care assistant and lead conversion AI agent.
Patna is in news today.
There is one more second prize which goes to the KPJ Specialized Hospital, Ghazipur, Bangladesh, from the KPJ PMS, Patient Management System. The two hospitals share the second prize.
So we are proud that we have international partners joining in for the Cahotech events and winning prizes as well.
There's Ruben Memorial Hospital on stage. KPJ Specialized Hospital, Bangladesh. Please give them a huge round of applause. They travel all the way from Bangladesh to participate in this Cahotech 2025.
Our next category is for clinical excellence, and the first prize goes to the Royal Care Super Speciality Hospital, Coimbatore, Tamil Nadu, for the magnetic resonance guided focus ultrasound.
And the second prize is taken by Basavatarakam American Cancer Hospital and Research Institute, Telangana, for their hypersight project.
Please keep on joining your hands together.
Yes.
For all the winners.
And one more happy news is that there's a lucky draw which is going to happen now. So please wait in the hall to know the lucky draw winners. Yes, the Basavatarakam team on the stage.
Our next category is HR Excellence, and we invite upon Sarvodaya Hospital, Faridabad, Haryana, for the first prize, that is improving staff training, tracking and compliance through the implementation. Faridabad, Haryana team.
Yes, so two of our very important members are
Our next category is academics, research and excellence. May we request St. Peter Medical College Hospital and Research Center in partnership with Medicine VR at Hosur, Tamil Nadu for their lab VRS project.
Yes, the St. Peter's Medical College team, yes, they are on the way. Second prize is taken by Apollo Hospital, Bhubaneswar, Odisha. Oh, I can see the Apollo team waiting for this.
The Apollo Nursing Excellence Framework integrated clinical education and monitoring systems. We're requesting all the team members of Apollo.
All the team members of Apollo, please come. This is your moment.
We are glad that at least there are so many people from Apollo who join us, and welcome.
Please give a huge round of applause for Apollo Bhubaneswar.
You can see the team works, get the dream work. So wonderful Apollo team.
So there is a lucky draw announcement now that the lucky draw will be taken right in front of you here. So the game was Catch and Win, a special game curated for Cahotech 2025. So
May we request the esteemed dignitaries to please be seated.
Lucky draw winner, Balaji.
Balaji, at least you could have put your surname or the place. Sir, today I am Santwana Balaji.
The lucky winner is Dr. Pushparaj.
Dr. Pushparaj.
He just left.
So Dr. Pushparaj is second winner.
Dilip Gudipudia.
So
yes, we have the participant here. From Basavatarakam.
You have been double lucky today.
Samrit. Oh, yes. Ruben. Ruben Hospital.
Mr. Mahmood.
Sir, can you please repeat?
Mr. Mahmood.
Mahmood. Mahmood, is he in the hall? Mahmood.
From KPJ.
KPJ, Mahmood. Yeah, you are here. Please come. We've been calling your name. Is it wrongly pronounced? Yes, please. Yeah, Bangladesh takes the prize. It's Mahmood. It's not Mahmood. Yes.
So for all those who are lucky, hearty congratulations, and those who are not present over here and became unlucky, better luck next time. And with this, I request Devanand to proceed with the further requirements.
Yeah, so we have come to the end of the ceremony. So to give the vote of thanks, may I request our Secretary General, Dr. Lalu Joseph, to deliver the vote of thanks. And with that, we are signing off. Thank you so much for being a patient. Yeah, audience, thank you so much. I know it was too heavy sessions today, but I think you have been very patient. Thank you so much for being a wonderful audience.
I have a lot of people to thank, but I'm not going to take time. I have prepared some slides. So let me quickly take you through the vote of thanks. So if I miss out anyone, my apologies. First of all, big round of applause and thanks to all the delegates who stayed back, and also the numbers. I think we touched about 550, and also the hybrid mode online, we had several delegates who joined in. A conference of this size is not possible without the support of all the sponsors. Wish to take this time to thank our gold sponsors, Artma, Dogstripe, our silver sponsors, Medversity, AWS, Charnock Hospitals, Kaveri Hospitals, Cloud Physician, bronze sponsors, Intuitive, iSciences, Ingran, and thank you to all the technical sponsors, several of them who really came forward and supported this event. The digital media partners of Caho, the Spark Voice of Caho, and also the Blank Slate. So for all the innovation presenters, our editor, Dr. Sonali, will be contacting you. So the upcoming issue on the Spark will cover all the innovation and also the technology Pitch Fest articles. Now our AI partners, Tulu Health, the website partner, IBs, delegate kit partner, Dozy, knowledge partners, several of them. Really wish to thank all our knowledge partners and our chief guests. Let's give a big round of applause to the guests of honor and the chief guest, Mr. Kiran Gopal, who was with us last evening, and the guest of honor, Professor Suman Chakrabarti, Dr. Mrityunjay, Dr. Jitendra Sharma, and all the chairpersons of the various committees that were put together. It's not easy conducting an event of this size when we are all over the place. So several global chairpersons and others who came together to make this event a grand success. Special thanks to Mr. Somital, Mr. Prashant Sharma, Dr. Deepak Mitra, Dr. Nitiraj, Dr. Muthu Singaram, Mrs. Mukta Arora, Dr. Ayush, Captain Bobby Ramesh, Dr. Naren Segal, Dr. Babu Narayan, Dr. Rahul Deshmukh, Dr. Vishal Goyal, who put together the sessions and curated several of the sessions that we had today. The speakers, big round of applause and thanks, and I think they really added value to this conference. Extremely well curated, and thanks to Mr. Somital and Dr. Manish Kohli for doing such a wonderful job. The Pitch Fest Masterclass speakers, Dr. Vishal Mukta, Aravind Ganeshan, Dr. Bhaskar, Dr. Shantanu and Ms. Ashwini for the wonderful masterclass that they had. Innovation and early adoption, the grand jury, several rounds of jury, and we really wish to thank them for the time, the efforts they took to go through every presentation. 120 submissions. Thank you so much for that. And to all the technology adoption finalists, 50 presentations that were made. The Pitch Fest jury, again, many of them joined us from different parts of the globe, and we really wish to thank all of them for taking the time and for being with us. The finalists of the Pitch Fest and poster finalists, pre-conference workshops. So we had two very interesting pre-conference workshops being conducted. One on technology and infection prevention, another one on diagnostics and technology. Both were very well subscribed. Yesterday we had about 120 for the infection control and about 100 participants for the diagnostic pre-con. And really wish to thank all the delegates who participated, Zoom Hospital and also Kalinga Institute for hosting the pre-conference workshops. The entire organizing committee of Caho for Cahotech 2025. Big round of applause and thanks to Professor Achyuta Samanta. We really feel at home here in this campus, and thanks to Professor Achyuta Samanta for making us feel so with the help of his team, especially Dr. Soumyakanta Satpathy. I think he needs a standing ovation. Both Professor Achyuta Samanta and Dr. Satpathy. Big round of applause. They are the principal sponsor. And they are the principal sponsors too. In fact, they have supported every aspect, the stage, the venue, the food, and really an event of this size is not possible with the support of the host institution. And we are very, very proud of our partners, Kalinga Institute. Thank you, sir. Thank you. And please convey our love and regards and thanks to Professor Achyuta Samanta. And to the MCs, from morning till now, let's give a good round of applause to Mr. Devanand and Dr. Shantana Bhattacharya. Thank you to the Caho Secretariat. This is the pillar of Caho. We have several girls and boys, I must call them. They are all over the place. They are working from the cloud, but they are working with you, and really thanks to the Caho Secretariat. The patrons of Caho, unfortunately they couldn't join us. They are the pillar of support for us. The 6 patrons, we remember them and we thank them for the kind of support they extend to Caho. The event management team of Caho, Mice and More, Do we have Sarthak and Sumit here, please? Big round of applause to them. They've been really helping us. You know, this is a place where we really have not had any event so far, and this is the major event. We were very, very skeptical because we are so used to conducting events in Delhi, Mumbai, Calcutta, Chennai, Bangalore. But this is the first time that we have come to a tier 2 city, and we were very hesitant and scared. Thanks to Samyakanta sir, along with our event management team, seamless, and we really wish to thank the event team along with Samyakanta sir for making this happen. Big thanks once again to KIIT Bhubaneswar, our organizing partner, truly indebted, and I think the growth of Cabo will have this event as one of the major milestones. Thank you for that. So dear participants, looking forward to meeting all of you at Kalam Convention Center, AMTZ. Visakhapatnam is a lovely place, beautiful, you please plan to be there for 3 days at least. It's not enough. On behalf of Madam, yes, it's a lovely place, scenic place, and I'm sure you'll enjoy. So keep 3 days for AMTZ. So thank you once again, and look forward to meeting all of you at CahotCon 2026. Please block the date in your calendar. 10th, 11th and 12th of April 2026 at Chennai Trade Center, Chennai. We have 32 pre-conference workshops hosted by all the hospitals in Chennai and around. It will be an academic feast. We will have more than 3,000 participants attending, and we really look forward to meeting all of you. How many of you are joining us? Wonderful. Thank you so much for that. And Diagnostic Con is the other one that we are hosting in Indore. That's going to be on the 24th and 25th of January 2026. Please join us there. And I think it's been a great event and great support extended by everybody. So let's give ourselves a big round of applause. And what we carry from here, it is for the patients we serve. So please remember, any technology that we adopt is for the patients, for the benefit of that person that has given himself to be treated by you all. So with that note, thank you once again for joining. Have a great evening, safe journey, and looking forward to meeting you all very, very soon. Congratulations to all the winners, and goodbye. Thank you.
Healthcare never, but outdated systems, they do. Too much data, too many disconnected systems. Matters, patients. That's why Apple gave it to me. The soul that fuels the complex healthcare ecosystem. An AI-powered platform co-developed with doctors, nurses, patients, and care teams. We bring everything together. Seamless.
I'm planning to come. That's why not many hospitals luckily I met you. So my last Dheeraj sir also those essentially best of